profession, it's not an easy task. We had to prove ourselves at all walks, in whichever discipline we had been. So if I take you back into how the whole PA profession started, can I know how many PAs are here? Students? Is a hall full of PAs? Only this many? How many more? If I stand from here, I don't find many hand hops. Fine. Anyway, even this counts much to us. So this profession was not a cakewalk, neither for the mentor, our patron, Dr. K.M. Cherian, because he had to bring us into a medical profession where we were not welcomed in a very warm way. We were shunned, we were shunted, we were made to run from, not alone from pillar to post, from beds to beds, from wards to wards. And all the seniors who are here will have a history, will have a long memory as to how they have made their place to this. And when we met here, after 2 weeks of a conference at Delhi, me and Mr. Veerappan, a senior physician associate here, were saying that we are back to this auditorium, which is very nostalgic to us, where we were given our degree, our PA degree. For me, it is 25 years back, and for him, it is 27 years back. So this auditorium is somewhere where we've always wanted to come up and speak to. This place is where we have had our old memories, where it was the first day we got our degree, we got our appointment order as a physician assistant then. But then from that day to present, right now, present day, we are trying to claim our profession not as a physician assistant. We are trying to change the nomenclature itself into a physician associate. So if you all had a look into the conference topic that was given for this year, was the journey of transforming from a physician assistant to a physician associate. So there are a few things that I would like to emphasize to you, because very shortly you will be coming into the same profession as to where I stand. And these are the requests. These are what I expect. These are what is expected of you. And this is what you should be doing when you get into the profession. There are few things, few gaps, few nuances which cannot be taught in a classroom, which either has to be learned from what you observe from your senior, or what you get to watch, you get to learn, which doesn't come always, which is not taught every day. These things is what I try to say as the nuances of what you need to learn to come into a profession which is going in a national way now. So the first thing that is expected of you as a physician associate student is that you should respect your pioneers. I hope you all will agree with this, with your senior, at least if you don't call them sir or ma'am or whatever. But then when you get to see them, when you get to bump on them on your daily basis, or when you get to hear of them, please have a little tone of respect onto what you speak. The next that is expected of you as to when you become a profession is that you should improve your soft skills. I do believe that you all will be knowing what soft skills are. Can I take it for granted that you guys know what soft skills are? I don't get a response. Do you all know what soft skills are? Fine, I think you have your lecturers, professors here who will be letting you know as to what soft skills are, because I'll not be taking much time of yours. And then what is majorly expected of you is you should mind your tone when you talk to any of your profession or of the profession which is allied with you. You might be working in a team, so you will have many professionals who will be coming up with you in the same team. So you need to mind your tone. You cannot have an authoritative tone even to your junior. It's not expected of you. You need to mind your tone. So that's where your soft skills come. It carries a long way. You need to be meeting many people in your life, on your profession. That's where we spend half our time. So you need to mold your body language. You cannot throw weight around. You cannot move around thinking that you're a senior then. And you cannot make yourself feel very timid as you are a junior too. So you mind your body language. How you present yourself matters more. And majorly, mostly, what we generally tend to do is when we get into the profession is we get stagnated. Never get stagnated. Don't get stuck to the department that you have been brought into. Please widen your knowledge. For you to widen your knowledge doesn't mean that you read alone. You need to go do research. You need to go think prospectively as to what more you can do, what more exams that you can give up to come up in that same profession. Even if you have been put into an eco department, you have your senior here who will help you. There might be many exams which you can give up to come up in that same field that you are in. You will have a lot of mentors, you will have a lot of guides in your doctors and the clinicians who are around you who can guide you into giving papers, present, research. Know what you're doing. See, if you are in a research paper, doesn't necessarily mean that you just collect data and keep mum. But you need to know what data you've collected. You need to learn as to why that is being collected. You need to know why the study is being done. So please widen your knowledge. Cultivate a very good communication skill. You might be a very hard worker. You might be putting your heart and soul into what you're doing. But if you're not able to communicate as to what you've done, do you think you will be able to come up? It's very difficult. There may be very few who can understand your skill in it. But then when you're not able to communicate, it's very difficult to come up that way. And that too, when we are going pan-India, we need to be very communicative. We need to speak up as to what we do, where we stand, how we come up, how we've come all this way up. And try to learn many languages other than the regional language that you are in. You need to know many languages. Patients come up with each and every nook and corner of our country. So at least learn a common language. English alone isn't done. Other than the regional language that you are in, try to learn the language from where your patients come from. Few words, which will make much difference in their life too. Because the patients who walk in don't come with a very good mental frame that they walk. Anybody who walks into hospital isn't with a positive mood. They all come with mixed emotions. So you should know that when you speak in their language, at least few words, it brings them close to you. So that's where it starts. That's where your soft skills and communicative skills starts. So these things are never taught in a classroom. You either learn from observing a few people who are with you, or by these things of conferences or where you go to learn such things. When you get into the profession, very shortly, say for few it will be in year's time, for few it will be another 2 years' time. When you come into this profession as a physician associate, you are expected to keep yourself updated in technology and in your field too. Other than all these things, apart from all these things, remember that you need to teach and you need to educate your juniors in the field, either in your department or from the junior who are doing the same course. There is nobody to help us in the in-service other than our own selves. Self-help is what matters here. So why do we think we come up on a working day, on a prime time where we need to be in our department out here to speak to you guys? It's only this that we want to convey to you, that we have to walk a long way together to make the bill, that act that has been passed in favor of us, where we've been included in this National Commission for Allied Health Profession. We need to walk along and to make our cadre shine up, to be shown very prominently is when we increase our numbers. We are hardly 5,000 who's been registered in our Indian Association of Physician Associates. I request all those who are in your final years, please get into this association, take a life membership. You all know our website for the Physician Associates Association. Please click onto the website, register yourself, and that will help us speak loud when it comes to the national forum. And see to it that you guys attend conference. Please prepare and present papers and try to be approachable. The major thing, when you have a junior who's going to come up into the profession, they should feel free to come and speak to you, either with doubts or with something. Please be approachable. Don't build a wall around you, which will not make you approachable at all. So let me finish with best wishes. All you guys, please rise and shine. We need to walk together, hand in hand to make our profession shine high. Thank you.
Thank you for the motivational session, ma'am. Next, we call upon our another senior physician associate, Mr. Veerappan, plant head at Bioengineering Lab, to present a talk on framing the research question. Over to you, sir.
I have to operate this one. Where is PPT? Good morning, everybody. I'm quite happy to be here on this greatest occasion. After 27 years, I'm staying in this, coming and standing in this auditorium. I'm very happy and proud to be here in my mother institute. Now I'm going to give a talk on small talk on framing a research question. If you see the power of phrases, when you listen it, you'll get so many things in your mind. I be there. This has been stated by Jesus to his disciples. I be there. I was there with you. I am there with you. I will be there with you forever. The simple language gives a great meaning to the people. So how a man talked on behalf of God, I be there. The second one which I like so much is, though we know we'll never come back, we'll never come again. It gives a lot of meaning. It happened to me when I entered here 27 years back. After a long period, I'm here again. I'm quite proud. The last one, there is no need of saying anything about that. This phrase by our Vivekananda, Swami Vivekananda. Then what is a research question? A research question gives the complete idea about the research, what you are going to do. It gives the direction. It gives profoundly the meaning of what we are going to do. It is a probing statement. You have to find an answer from it. This statement completely tells about what you are going to do, how you are going to do. How to formulate a research question? You can use a word, it's an acronym, FINER. We have to find out whether we can do a research, whether it is possible, feasible to do with our own setup. Interest, it's supposed to create an interest to the peer group. And it's supposed to give a pleasure to the financial persons for this particular research. And it's supposed to be novel. And there should be a research as should have been done in this particular concept. It's supposed to disprove the whole research, whatever happened till today. It's supposed to be a unique one. It's supposed to follow the norms, ethics. It should assure the patient safety whenever you do a research. And the research is supposed to be a relevant one. It's supposed to be useful to our own environment, for our own patients, for our own benefit. We have to formulate a health policy by doing this research. When you see a research question, we have to find out the component of it. What are the components? Picard, population, where we are going to do the research, on which group, which age group, which disease condition. Intervention, what you want to see. When you want to see that the surgery, whether it is useful to the patient or we are giving a medication that is useful to the patient, there are so many intervention can be done with the research question. A research question is supposed to have all these things. Comparison. If we give a drug, what will happen? If we don't give the drug, what will happen? If we give a drug with another drug, there are two groups. When you compare two groups, what is the result? Outcome. What is the end of the study? What you are getting out of it? This time frame says that after how many days or after how many years we are finding the result. See, consider this statement: the role of hydroxychloroquine in preventing COVID-19 in healthcare workers. Now we are going to identify the population, interest, comparison, outcome, and time. Here, the population is the healthcare workers who are really doing the great job by saving the patient. So they should not get affected. Now, intervention, what we are going to do, whether this hydroxychloroquine really helpful to the patient, helpful to the workers, how often we have to give, how long we'll give. See, when you comparison, you can compare a group of people with this drug, another group without the drug. Outcome, healthcare workers, whether they end up with COVID-19 or without any issue, they come out. What is the duration? After 6 weeks, we want to find out this particular condition in a patient, in a healthcare worker. So how we'll frame a question now? Can hydroxychloroquine administered once weekly for 6 weeks protect healthcare workers against COVID-19 infection? See, we have talked about a statement. With the help of Picard, we have made it as a research question. Now this research question, when somebody reads about it, they'll get an idea how this really, the drug plays a major role by protecting the healthcare workers. See, now I'm taking another broad spectrum topic. Consider type 1 diabetic mellitus. Now we have to do a research review on this particular topic. Recent changes, what happened. Now, if you narrow down the search, which is feasible to our current setup, we have to make a setup. Now, the population is type 1 diabetic mellitus. Intervention, testing a drug. See, we have to test a drug, how this drug plays a major role with disease condition. Comparison, by giving the drug or without giving a drug. Or you can give some other drug and compare it. Outcome, blood sugar measurement has to be measured. How long we are giving? After 3 months, we'll come to a result. So these are research question. What we are going to make here is, what is the effect of metformin usage on blood sugar level in type 1 diabetic mellitus after 3 months of usage? See, by getting an idea of what you are doing and forming it as a concept and making it as a research question, these research questions will give what you are going to do, and all your research is supposed to revolve around this particular question. What is bad research question? Study of telemedicine during the lockdown period. Now, if you say there is no question at all, and there is no duration, and where we are really going to use it, this can be rephrased in such a way. What is the patient satisfaction after telemedicine consultation during the lockdown period? This is a right way of framing question. The first, if you see the statement, that is study of telemedicine during lockdown period is not a research question at all. Another example, does consumption of cinnamon help in lowering lipids? Now this question, without any clear-cut idea, the quantity of cinnamon is missing, subject missing, time interval is missing. But how we can rephrase this question? Is the lipid profile altered after the consumption of cinnamon powder 3 grams per day for 2 months in non-diabetic patient? See, when you go and read this question itself, you will get an idea of what research they has been going to do. It's supposed to create an interest when the readers going through it. Again, though we know we'll never come again, kindly feel the people around you, feel the environment, and respect the people, enjoy the moment. Again, we'll never get it. Thank you so much.
Thank you, sir. We now call upon our next speaker, Ms. Priya Jabakaran, Senior Physician Associate, Manager Operations and Transplant Services. Over to you, ma'am.
A very warm good morning to you all. It brings me immense satisfaction to see a huge crowd celebrating the Physician Associate Day. And really, I wasn't prepared for the topic, whatever I was supposed to speak. When I came here, just to keep you all occupied, I thought I will give a small talk. As a physician assistant, people may think that we are going to get focused in only one area or arena. I don't think people should have the thought. How many are very happy and excited to do this course? Can you please raise your hands? Or how many are really disheartened? Why should I take this course? Why have I taken this as a choice? Has anybody got any regrets? I couldn't see anybody, but I don't see people cheering up. Their faces are very sober. There is no cheer in their face. Nobody seems to be happy celebrating this particular event. Please, all of you cheer up first, or I couldn't see you behind the mask, maybe. As a senior PA, I really admired the way my immediate senior, Srividya madam, how she spoke. We had a lot of respect on whatever work they did. We just copied ditto. There was no physician assistant guide. There was nobody to tell what to do in the in-service, what not to do. People are very left blind in the departments. Only our seniors were taking the responsibility of guiding us. Even for going for a break, they will say, go for 10 minutes and come back. Everywhere you should not join hands and go. Come back, that is the discipline we were taught. I don't see loitering of PAs anywhere, because the way they were very much training us in a disciplined fashion helped us to enhance our knowledge, explore all the avenues. We were not restricted to one department. Whenever we got opportunity, we were trying to learn the other avenues, whatever. So coming to my scenario, I was a surgical physician assistant. After doing my 7 years of physician assistantship work in as a surgical PA, I lost my hand in a road traffic accident, right hand. I couldn't go to theater, but I took up a lot of other roles. Like I did my transplant coordination diploma course from Indira Gandhi National University. Recently, I have completed my NABH quality, planning to do my assessor course. I was working as a manager operations and transplant services for Frontier Lifeline as well. It is not that you don't have the capacity. Everybody, God has given a lot of knowledge, and there is a hidden talent in each and every individual God who has created with a lot of sense. So you should think how you have to explore yourself, come out and then gain a lot of adequate knowledge, explore a lot of avenues, and shine in the relevant field. Apart from the relevant field, you should say parallelly, what else will give you a lot of scope. So as a transplant coordinator, I used to think that talking to patients was very difficult, but communication skill was very important. Understanding a patient's mental status. They come with a lot of agony to you. They doesn't come just walking with happy mind. They come to the OPD. Taking a history may be a little difficult task. It is a state-of-the-art technology. And also it is a skill, history taking. You have to apply your full body to listen, properly be a listener, to take the history. Whatever history is taken only is going to go through the diagnosis. What investigations you're going to prescribe. So it is not less just every patient is going to talk about the history in the outpatient department. One cannot ignore even a small comorbid condition, what is not properly understood by you. The patients are all same for you. There may be 100 patients walking into the OPD. You should be a patient listener. When you be a patient listener, you try to learn a lot of medical terminologies. You can explore what is this disease, what is the treatment, what are the diagnoses, what are the investigations to be prepared. So nobody will give you what is this, do that, this is the spoon feeding, nothing. Everything you have to have an intuition and passion to learn it. So nothing comes cakewalk to anybody who's a physician assistant. There may be out of 50 candidates in the class, 10 people will be good and shining. Rest of the 40 people may be average. We cannot blame them. They can shine very well in their life. Study is totally different from practicality. So you have to think that every department put a proper protocol. Go it as a small checklist. In this department, what I'm going to learn, how I'm going to use it. You don't ask a question what this organization has given back to me. How you have been useful in the organization, what you have learned from the organization makes a lot of huge difference. It doesn't come just like that. You have to put a checklist, whichever department you get the posting. Here I have come. What I am supposed to do? What are the checklists I am supposed to learn? What are the protocols available? What are the standard operating protocols? What are the NABH standards? Now all the hospitals are NABH compliant hospitals. So you people have to have the intuition and passion to learn what is new technology, what is the routine activities in that particular department. So always be motivated, be cheerful, give respect to your elders and the seniors. No need to say madam or sir. At least you should respect and abide the rules pertaining to that particular department. If you do this thing, you will be a successful physician assistant. In future, nobody will pinpoint you or blame you. Wish you all the best for all your endeavors. Be cheerful that you have taken a very best course. Lot of avenues are there in India as well as in abroad to explore and get yourself in the PG. When you do a post-graduation, whatever you learned in the UG is going to be really useful. Okay? Wish you all the best. Thank you for giving me the opportunity.
That was inspiring, ma'am. Next, we call upon Ms. Sudha Subramani, Senior Physician Associate, Chettinad Hospital, to share a few words. And it is proud to announce that she has been awarded as the Best Physician Associate 2022 at the IAPA Conference, New Delhi. Let's give a big round of applause.
Thank you everyone. So good morning to one and all present here. I'm Sudha, Physician Assistant from Chettinad Hospital, passed out from MMM 2005 to 2009 batch. So basically I'm from cardiac surgery department. So I think all of you are junior here. So I just want to share what I do and what other physician assistants do all over the world. So we have both extremes all over the world. They are physician assistant who close ASD, VSD, and also they are physician assistants who do just restricted to the leg side alone, just for taking vein. So the thing I wanted to make here is, it's all upon you, who you are and what you want to be actually. So I can't restrict myself to be a physician assistant left over around the vein side at all. But there are some things which made me to go to the head end, do sternotomy, sternal closure, go on pump, and even do some emergency cannulation too. That is because my surgeon, he has confidence on me that I can perform all these things. This thing I want to share to you, because you just don't blame the seniors or doctors or the DNB students who are now competitive in the surgical team. So it is you should explore yourself, you should come out of those things and prove the field that physician assistants are just not an assistant, so-called. You are also capable of doing sternotomy, sternal closure, whatever a junior surgeon can do it. Okay, don't think them as a competitor. Just you need to prove yourself that you are a team, a crucial team member of the surgical team. Okay, so again, one more thing is, don't restrict yourself to cardiac surgery department alone, not cardiac surgery, whatever it is, physician assistant. You have many scopes. You have many other opportunities all over the world. So you can divert your thing, you can do some post-graduations, like I'm doing my PhD in hospital management. So if you are not able to survive in this department, don't lose the hope. It's not like most of them surgical field, actually, most of them have deviated their course, deviated their field. I don't think a lot of people are there in the cardiac surgery department now, because we have DNB, MCH students, all those things. So the thing is, see the world from different angle. You have PhDs, you have masters in MBA, MCH, whatever it is. So do that things. I do my PhD in hospital management. So I just suggesting you these things. The other thing is, it's a peer, how you behave to your people. Okay, that is very important. You need not concentrate on your work or your skills or your thing. There are something called character, behavior, all those stuffs. Those things play an important role. Okay, those things tell you, those things tell others what you are, who you are, so that they can give you most chances, many things, so that you can use those opportunities to shine up. Okay, so anything else you want to ask me in cardiac surgery or surgery field like that? Anything? I'm here to answer you. You can ask me anything related to cardiac surgery or scope or any job opportunities like that. Tell me. People are there, yeah. Ma'am, actually, you need to adapt to the country where you are going. You have exams, all those things. Our physician assistant course is not valid all over the India. It's not a you have to do some other courses, some other exams to go there. So our physician assistant, what we get it from our BITS Pilani is not valid there actually. Some nursing, something is there, nursing anesthetist, those things are there. You have some degree courses like part-time course, some 2 or 3 months courses. We need to finish that and then do all those things and then go for abroad thing. Our course alone is not valid anywhere. That is the thing. So we need our recognition somehow, but these things are all very good, ma'am. Like in Delhi, we had Harshavardhan, Dr. Harshavardhan thing, and here this is Subramanian, sir. So I'm really proud. I'm very happy. We are just not to our level. Current people are very lucky. They are well recognized than what we are actually. So sirs and madam, you need to come up. Okay, you need to see. Now I asked you something. You can ask us. You can ask all the seniors anything if you want, but no one has turned up. It shows what interest you have. You have a good stage. You have a good people to answer. All these people are very well experienced. They know everything actually. You won't get those answers from anyone else in your department or in your surroundings or whatever it is. Okay, say all the very best. You can contact us. All the seniors are there in life member thing. You can contact us for anything at any time. Okay, thank you. Yeah, ma'am. Everywhere, all people are very much needed in all the department actually. I work in Chettinad Hospital, Chettinad Super Specialty Hospital, dialysis, neuro, radiology, every department, there are physician assistants. So don't restrict yourself to cardiac surgery, or cardiology. Those things are very famous. Like, so don't think so. You all are needed in every department. No, like you have cardiology, OPD, radiology, oncology, and transplanting. So ma'am is there. So in every department you are required actually. So search from now itself, from third year itself, you just gain knowledge about all the physicians all over the world. Okay, don't restrict yourself to Tamil Nadu or whatever it is. All over the India, you have many people, and all the seniors they are ready to help you. Like in the IAPA conference, I asked Mr. Manish to help me out with PhD thesis. He's helping me out. He answered my call. He's in contact with me. So all are ready to help you at any point. So please open up, ask them. If you are at a stage, it will be helpful for your juniors to come up and touch you there. All together, we can be at a higher level. Just we can't imagine that. We can prove ourselves to be superior than our seniors. Okay. Thank you. Thanks a lot.
Thank you, ma'am. We now happily welcome our beloved CHS principal, Dr. Deepa C. Philip, to the dais to share a few words, ma'am. Thank you.
A warm good morning to everybody here. So this is a surprise for me actually to be here, but I wanted to add on to what your super seniors have told, and to correct the immediate, what's your name? Just talk now. Sudha. Ms. Sudha, now the physician assistants are not only in cardiac surgery. Now they are all posted in all the departments, and our students who are passed out from the college have been into ortho, they are into nephro, they are into radiology, they are into oncology. All the departments our students are getting posted. So it is not only they are restricting themselves to cardiac surgery, because if you see the today's crowd, they are even more widened than what you people were earlier, because there are a lot of opportunities open for them. They have a lot of ways to get information, knowledge. And even for our students who are passed out from this place, have gone abroad also, every country, wherever you're going it, there is a procedure there for an entry exam. So they qualify, because it is now all the programs here at the college is under with the Tamil Nadu University is a 4-year program. So all the 4-year programs are eligible to go abroad for the higher studies. So our students who completed from our college have gone abroad for higher studies. And also there are people who are gone abroad and doing the work. So they are getting the job profile, they're getting the job opportunities, and also they are getting into the higher studies. So there is nothing that will stop you for growing. And this is one platform where you can get into greater heights. So here the crowd is not only physician assistants. Here you'll find all the category, even our PG students who are joined today are here. So the instructions or your seniors who have told just previously who's ever talked, you did not restrict only to physician assistant. Although people here, they would be thinking, this is not for me. I'm not a physician assistant. I'm in a dialysis tech, or I'm an MLT. No, what you super seniors have told, it is applicable for everyone who is working in a hospital setup. All that instructions, how you have to be in a hospital, because I've already told you, if you remember for our induction program, I say hospital is not a place where you go as you're going to a mall, right? You cannot join hands happily, celebrate it. You can go to a mall, you can go to open places like that. But when you're coming to hospital, we always have to see somebody who's in opposite, and they come with a lot of agony, they come with a lot of problems. So they are looking at you with a hope that something that comes from you will help them to get better. So that is hope. They're looking at each and every one, when you are in uniform, I always say, they don't treat you as a student, they treat you as a staff, because it is very difficult for a patient or a layman to understand who's a staff or who's a student. So once you are uniform and you are inside campus in the hospital premises, then you are treated as a staff. So you have to keep up the dignity as a staff. You have to learn everything. So as your seniors, super seniors have told, how the learnings you get it. It's not everything is spoon-fed to you. It's that how you take it, how you see. Everybody's eyes are different. Everybody's outlook is different. So it is up to you how you look into the things, how you take to absorb it. And anyone who wanted to grow, there is no way, nobody will stop you from growing, right? So there is a lot of opportunities for everyone who are here, not only just for physician assistant, but we wish all the physician assistant and physician associate working here from long time and other hospitals, a great future ahead. But for all the people who are here, you'll all have a great future ahead. Only thing is, whatever the course that you are taking you have to go with a passion. You have to take it with a passion. And on the behalf of the management, on behalf of all the staff of College of Health Science, I wish everybody a happy career. Thank you.
Thank you, ma'am. Knowledge is wisdom. No thief, however skillful, can rob one's knowledge. And that is why knowledge is the best and safest treasure to acquire. Now we are here to CME session on the topic Echo Made Easy, presented by Dr. Ram Kumar, Head of Department of Echocardiogram. I request you to take the dais, sir.
So good morning, everybody, and all cheerful face, and very happy to see you all in such a color dress. And this 20 years down the line, first time I am seeing auditorium is filled with full of colors. I am very happy and delighted. And when I entered this institute in around 1999 and 2000, I am nothing, no cardiology or nothing. I am just an MBBS finished doctor, simple doctor like you and all. With lot of hopes, we entered this institute. 20 years down the line, this institute and you all people shaped me to stand in front of you and to deliver a simple lecture. So that's the simple thing which we learn every day, practice every day, be coordinate with everybody. And this is like a treasure, ocean, this institute. All the people are really like oceans, and my teachers, my colleagues, my registrars, and my lovable patients. We learn daily, day to day. So that's the thing. So little bit I am squeezed in between a important function, and time has given us for a good opportunity. So first of all, I would like to thank that when I entered in 2000, I didn't know anything. I don't know what is angiogram. I went to the cath lab. Who is there in the cath lab? Anybody tell me? Who is your senior PA is there? Yeah, best. So Radha Krishnan is there. So he taught me how to do an angiogram, how to write a report. So even after doing MBBS, MD and other thing, so much of, like this, entering this hospital, we learned from him, how to report an angiogram. It's very simple. He said, sir, these are all very simple. You come and daily come with me, I will teach you. He taught graciously. So I learned from your most important senior, the first batch of senior. I think we should give him a big hand. So my chief, Dr. Ajit asked me, okay, you have learned so many things in the cath lab. Now you go to the echo department and learn something. So I said, sir, I don't know echo. No, you should go and learn. So that's how my chief, promoted me, pushed me. When I went and there was an important physician assistant. Who was there? One Sudha was there. Then I think Bharati was there. So I think we all give them a big hand. So from them only, I learned what is echocardiogram. So they just gave the probe to me. Okay, sir, start doing. You will start seeing the pictures. And that's how we learned. So it was a wonderful and beautiful experience. Who don't know nothing about echocardiogram, I started learning. So these two things are over. Then clinical examination. A lot of people keep coming to your OPD, 200 and 300. So my chief posted me, you go to the clinical department now, start seeing the patients. I said, sir, how to check the cardiology? No, you will learn automatically. So in every places, institute and chief and my cardiology nice department has set up people to teach somebody. So that's what we learned. So in the clinical medicine, we had Gomati, Madam, Farida, and 2-3 people whom I cannot remember. They showed, sir, post-CA Bijana, idan sir protocol. So we learned from them. So that's how, we started learning the nuggets. We started learning the beauties of medicine, really start applying the medicine in this institute. So if you have this ability to learn from somebody, then you will start enjoying being in this institute. And that's why I'm here, 20 years passed down the line. But you will never have the ability to learn, interest to learn, very difficult. You cannot stay here. Our transplant coordinator, was with me for some time. We have done some transplants, went out and picked up some hearts and all. It was a very wonderful time we spent with her. So those are the beautiful memories which I want to recall. So why I have to say it here? Tomorrow you can teach some of the doctors like us if you show an interest. It is not that, for a patient, it is not that doctor's word, 100% correct. Doctor, physician assistant, nurse, all these cardiac technicians, everybody combined, if they put their inputs, form a synchronous understanding, the patient will fly away with any diseases he has. So one more thing I want to tell you. I think most of cardiac technologies also are here. So who is the most prominent cardiac technologist in cath lab? Who is there for a long time, who is little restless? Ravi sir is very silent. He is very senior, so I cannot praise him. So there is one more person. Benjamin sir. So he taught me how to do an angiogram. First patient, it was my, Dr. Lakshman Das patient. First angiogram I did. Sir, ventricular fibrillation going on. He just jumped and shot. The patient survived. So I was cannulating something like, I don't know what I am cannulating, what I am pushing. He found that the patient had a cardiac arrest. He jumped and gave a shock. So these are my teachers. So Benjamin is my teacher. Radhakrishnan is my teacher. Bharati is my teacher. Madam is our teacher. And a lot of other people are my teachers. So we learn from them. So it is a wonderful thing that I learned so many things. But for few 10 minutes, I would like to teach you something called as echocardiography. So till the time you go into a little bit boring session, it will be make it as an interesting session. Now, what is mean by echocardiography? Can anybody tell us? Any of juniors should tell. Why do we do echocardiogram? See, when a patient comes to hospital, we do a lot of tests. Why do we do so many tests? We do to find out whether the patient has any cardiac disease or not. So that is the thing. What are all the tests we can do? So we do some basic blood tests, clinical examination, check the pulse, BP, ECG, echocardiogram, then ultrasound, then cath lab, coronary angiogram. So many tests are there to find out what the disease the patient is suffering from. No? That is the idea. So echocardiogram is such a very useful and a very productive test, very, very easy to learn. Very, very easy to learn. That was, once again taught by you people and all. So I will also teach you how easy it is learned. So echocardiogram is a test that is used in day-to-day practice to diagnose heart diseases using ultrasound waves. So using your ultrasound waves, we diagnose heart diseases. The machine which we use and the test we do is called as your echocardiography. Now, what is meant by ultrasound waves? You all had breakfast or not? No. So you are supposed to have some lunch. No. So anyhow, we will give you some snacks and all. So what is meant by ultrasound waves? So I am audible to all of you. So what is this called? This is called sound waves, nothing. So you are audible to, I am audible to everybody. That is called as sound waves. What is meant by ultrasound wave is still sound waves, but they are not in our audible range. Still sound waves, but they are not in our audible range. That is called as ultrasound waves. If you want the number, our ears can hear from 20 to 20,000 hertz. That's what the audible range. If it goes beyond 20,000 hertz, we call it as ultrasound waves. Your echocardiogram uses your ultrasound waves to diagnose heart diseases. So that is the concept. So you should understand this basic concept. Echocardiogram is a very useful instrument to diagnose heart diseases, which uses sound waves. Sound waves, it uses ultrasound waves. So that is the basic concept here. Now, what are all the heart diseases a patient can have? If you go through the books, there are thousands, 10,000 heart diseases. So it is impossible. But for a beginner, somebody is just in the first year, somebody is in the 5th year, somebody knows how to do an echocardiogram. But I think most of you are not aware of this as a very useful thing. So I would let you know that what is meant by heart disease. Now, how to find out what are all the various heart diseases? It is impossible. But you know that heart is made up of what material? Heart is composed of blood. Heart has got how many layers? It has got a covering, which is called as pericardium. It has got a muscle that is called as myocardium. It has got valves. These are called as endocardium. So heart is made up of 3 important structures: pericardium, myocardium, and endocardium. These endocardium is the valves. We have got 4 valves. Now, inside the heart, there is constant flow of blood. This constant flow of blood sustains your heart pumping function and circulation. And that is very, very vital to the sustenance of the organism or the human being. So the anatomically heart is made up of these 3 important structures: pericardium, myocardium, valves. We should all know. Heart is filled with blood every time the heart pumps and pushes the blood out. So that is the basic thing. So now combining these things, ultrasound waves, we know what is heart is made up of. Now with the help of an ultrasound wave, if I image the heart, I can find out these 3 important structures. What 3 structures I can find out? I can see the pericardium, I can see the myocardium, I can see the endocardium. So how simple it is. So by that, I know that it has little abnormal or little normal, or I can easily diagnose the heart disease. That is the concept of using an ultrasound. So before starting this basic concept, we should always admire our pioneers. See, before echocardiogram, how people diagnose heart diseases? People have diagnosed heart diseases with the abnormalities which they hear with the audible range. So later he developed the stethoscope. So he is the Lennox who developed the stethoscope. Those pictures on black and white, these are the pioneers in echocardiography. One is called as Adler, another one is Hertz. So both combined to form the first echocardiography machine, which looks like this. So have you ever seen the echocardiography machines in our department? So definitely it is much higher advanced version. These are the older generations of machines. Now, even though I have told you about the lot of teachers who are here, we should also learn from nature. Nature becomes your best teacher. Now I have told you ultrasound waves has been used by echocardiography. So bats uses ultrasound waves to locate the prey. Bats cannot see. So without seeing, it cannot find out where is the prey. It lives in the caves. So what it uses is, it sends the ultrasound waves, gets the reflection of the waves from it, and knows that that is the prey. It goes and catches the prey. So that's how a bat uses the ultrasound waves. Same concept here. We have an echocardiography machine. We have an echocardiography probe. That probe sends the ultrasound waves, receives the ultrasound waves. With that, I can able to diagnose what type of heart diseases the patient is suffering from. Basic fundamentals of echocardiography are, it is like two-dimensional examination, M-mode examination, and a Doppler examination. These are the three important steps which we do in our echocardiography examination. Now, if time permits, we will go through all these things, but we will try to finish off at least this two-dimensional examination. Now, what is meant by two-dimensional examination? So these are some of the ultrasound pictures, not of the heart, but of the abdomen. This is how a two-dimensional picture will look like. What colors they have? They have multiple colors or only two colors? They have got only two colors, white and black, and a combination of white and black. So these are the two important colors. There are no multiple colors to confuse. With these two simple colors, black and white, I can diagnose problem in the abdomen or I can diagnose problem in the heart. So most importantly, I can diagnose easily the problems in the heart with the help of these two important colors. Now, the basics of an echocardiogram is, we should all find out here. Echocardiogram uses sound waves, that is ultrasound waves. Once you pass these ultrasound waves by means of this probe into the heart, the sound waves get reflected. These reflected sound waves are modified to a scale called as the gray scale. Based on the intensity of the reflection, they are changed into these three principal colors. So you should be wondering here, how with the help of a sound wave, I can see something. It is an impossible imagination. So with the help of a sound wave, how I can see something inside the rib cage? It is an impossible imagination, but it is made possible by means of all your physics and chemistry. So what happens here is, I am passing only the sound waves. Okay. So I am passing the sound waves. Sound waves has the important property of reflection. Once you pass the sound waves, it will reflect back. I think most of you must have gone to the hill stations. You must have, whoever favorite's name, you must have loudly said, oh, it gets reflected back. So that is the most important property of the sound wave. Same thing. Once I pass this ultrasound waves here, it gets reflected back in the same probe. Based on the reflection, I give 3 important colors to it. If it is not at all reflected, I give a black color. If it is highly reflected, then I give a bright white color. If it is intermediate reflected, I give a gray color. So this is called as the grayscale transformation. Now, based on this, we get these pictures. Okay, now where you are seeing the perfect black color here, this is the perfect black color. So fluid or liquids will not reflect your sound waves. So it will be given as a black color. Your tissues, your muscles, your liver, kidney, myocardium, all these things will reflect the sound waves in an intermediate frequency. So we give them a gray color, little bit of this gray color. What are these white structures here? These are highly reflected sound waves. So these are made up of fibrous tissue or calcium. So that's why they reflect the sound waves much nicely. So they have been given a bright white color. So simple concept, use ultrasound waves, pass it across the body, whether in the abdomen or in the heart, get the reflected sound waves, divide into 3 categories. No reflection, give black. Intermediate reflection, give gray. Bright reflection, give bright white. We get beautiful images of the heart. So that was the concept developed in 1950s, where there is no Google, no WhatsApp, and no social media. People have their innate brain working. Now, because of all these things, we have advantages, but our brain is not working. So try to be away from those things, sit in a calm room and start thinking how people have able to diagnose and apply these technologies. Yeah, so this is how a fat is an intermediate reflection given a gray color. Bone and highly reflected things are given a white color. Non-reflected fluid is given a black color. And I think these will be a lot of things. So we will just now directly go to the how do you do an echocardiogram? Yeah, this is how we keep the probe and start doing an echocardiography. This is how we fold the probe like a pen. These are the various probes. And once I do this, I get an image like this. Okay, this is the image of the heart. Now, how many colors are here? White or black or multiple colors? There is white and black. What does black represents you? What does it mean to you? There is no reflection from those structures. It is filled with blood. So that's why there is no reflection. What are these things which are reflecting here? These are made up of muscle. These are the myocardium. This is the ventricular septum, fibrous tissue. This is the atrial septum, fibrous tissue. These are the valves. All these structures are hard. They are made up of fibrous tissue. So they reflect your sound waves. That's why they have a white color. With this simple concept, how beautiful we are able to see all the 4 chambers of the heart. How many chambers of the heart? So just by putting a probe, get back the image, you can nicely see all the 4 chambers of the heart. I think when next program is on, you can just remind me. How it is this echo, you are feeling interesting or you feel not very interested? Learning echo is very simple. Learning echo is easier than understanding the story of Ponniyin Selvan. Ponniyin Selvan, if you start understanding the story, it is impossible for me. But learning echocardiogram is much more simple than the story of Ponniyin Selvan. So that's how, what we have learned now by echocardiogram is use an ultrasound wave, have a probe which transmits as well as receive the ultrasound waves, send it to any part of your body, send it to any part, change it into 3 signals, white, black or intermediate, and just you put the probe, you will see the structure inside. So how simple it is. How complex is Ponniyin Selvan story? There will be 100 characters, 100 imaginations. So impossible. It is impossible, but echocardiogram is very, very easy and a possible thing. Everybody can do. Just take a probe, put the probe here, you will start seeing the heart nicely beating like this. So this is, cutting this watermelon is easy or not? Same way. Imagine instead of watermelon, you are cutting the heart. You are cutting the heart in various planes. So some of you are here. So you just see who is on your side. Yeah. So you see from the front. Okay. Now you are not able to identify. Okay, you go and see from the side. Now you are not able to identify. You go and see from the top. You go and see from the back. That's how. Yeah, heart, just by seeing the heart from the front, okay, this is normal. No. You have to see the heart from above, below, side, down, and everything. That's how. That's how a watermelon is cut into so many planes. Same thing. You cut the heart into multiple planes. This is how we cut. This is called as the parasternal cut. This is called as the apex cut. And this is called as the, by saying the word cut, you don't feel, very threat that, how can you cut the heart? No. Ultrasound beams are sound waves, which can just slice the heart without causing you any pain. Have you ever undergone an ultrasound abdomen? Do you feel pain there? No. So the word cut is actually not appropriate. It is passing through the planes and going across and getting reflected. That's what. So you know the basic concepts of echocardiogram. Now you are all going to do the ultrasound for the next patient of mine. Nothing. You have to just ask them, please lie down, sir, and turn on the left side. That's all. Simple thing. Now this is the probe. This is your ultrasound probe. This is our volunteer here. Now this is the heart. Okay. When I keep the probe here, the ultrasound beam is not only going on this side. The ultrasound beam will go from here to here and will slice the heart like this. This is how the ultrasound beam will go. It is a fan-shaped beam. It will go and cut the heart like this. And if it go and cut the heart like this, these are your surgical specimens. Most of the surgical PAs can identify what are these structures, but I cannot identify. This is how you get the image of the heart. Okay. Now, what are all the structures we see here? This is the anterior portion. This is the posterior. So like this auditorium, this is anterior, that is posterior. Same way, heart, we have got structures close to the chest wall, structures close to the vertebra. Left atrium is a structure close to the vertebra. This is behind. This is your aorta. Right ventricle is a structure close to the sternum. This is what is seen in the front. This is your another chamber, left ventricle. In between these two, we have got something called as a partition called as interventricular septum. This is your tube, which is called as the aorta. This is your aortic valve. This is your mitral valve. So is it easy than Ponniyin Selvan story or very difficult to understand? Heart chambers is so simple. So 3 minutes is sufficient for you to make you understand what is echocardiogram and heart. Now you can see the previous heart is a dead heart. We went there for taking a transplant. That's why it is not moving. Now once it is transplanted, the heart enjoys the movement of the heart. So this is how the heart moves. Can you see something is opening and closing there? What are those things which is opening and closing? So excellent. So you are able to answer now to my questions. That is most important. 5 minutes of teaching, you are able to answer my question. That is, I am very happy that my teaching is correct. So something is opening and something is closing. How many structures are opening? This is very prominently seen, everybody can appreciate here. This is something opening and closing here. Yeah. So what is this tube here then? So a tube-like structure, once again, we will, revise these structures. Anterior most is your right ventricle. Just behind that is your left ventricle. In between these two is your septum. The left ventricle will receive the blood from which atrium? Left atrium. The left ventricle will pump the blood into which chamber? Which aorta? So yeah, which tube? This is the aorta. So that's how the circulation goes like this. Blood comes to the left atrium, mitral valve. So this becomes your which valve? Between the left ventricle and left atrium, this is your mitral valve. Between the left ventricle and aorta, this is your aortic valve. So how easy we can see the structures inside the heart. In my first discussion, we discussed heart has got 3 important structures. Now I will show you all these other 3 important structures. This is your pericardium, thick fibrous tissue. This muscular layer is your myocardium. These are your endocardium, 2 valves. So we can see all these structures very easily just by keeping the probe there, and by which we can diagnose the heart diseases. So everybody are convinced with your nice pumping function of your heart. This is how the heart beats every time. So starting from the birth till the time we take a last breath, your heart pumps like this function so nicely. What structures are missing in this part of heart? So right atrium is missing. Very good. Then any other structure is missing here? Your pulmonary valve is missing, no? Then your pulmonary artery and other structures are missing. Tricuspid valve is seen or not? So that is also missing. So those are some of the structures. Like I said, you cannot just judge by a guy that he is perfectly normal, just seeing the front. You have to go behind and see, go sideways and see. Then only you can see all the other structures. So now this is one way of taking the heart cut section. If you tilt the probe towards this shoulder, we can get some other cut section of the heart. How different is this from the previous picture? So it is entirely different. Now imagine this is the heart. First picture, I cut the heart like this from top to bottom. Second picture, I am cutting the heart like this. Like, you make a cucumber slice, if you make a long axis cut, that is your long axis. If you cut the cucumber like this, that's how we are cutting the heart. Here we can see this nicely contracting cavity here. What is this cavity called? So this is your left ventricle. Above the left ventricle, we have got a small cap-like structure. This is your right ventricular cavity. In between this is your interventricular septum. This is your mitral valve. Nice mitral valve there. So this heart is normal or you feel abnormal? You all had breakfast, so you are all nicely awake. How is this heart contracting? Energy, it has energy or no energy? It has energy. Say loudly. Your energies are very low. So unless your energies are good, you should give, see somebody is, dull and weak. What we give? We give them energy, Okay, wake up, wake up, wake up. Like that, you are all looking very dull and, lack of energy. So that's why I have to give some energy from this heart to you. Okay, heart, please give them some more energy so that, they will answer more effectively. This heart has full of energy. It is contracting so nicely. Yeah. So we will leave and skip all these aspects. So this is another view of the heart, which is called as the 5-chamber view. I think all these things we will skip. Let's see. We will sum up. I think we will come to the last slide now. I think this is more than sufficient. So why this lecture is taken is to make you understand what is echocardiography. Because I have seen people going to the echo room, slowly opening the door. Polama vendama. No. So you should not have a hesitation to go inside and check, what is happening. If you have that hesitation, that is going to be your first hurdle. You cannot learn anything. There are 100 things to learn, but you will never learn anything. கதவை திறந்த உடனே வாங்க வாங்க வாங்கன்னு யாரும் கூப்பிடுவாங்க? யாரும் கூப்பிட மாட்டாங்க. கதவை திறந்த உடனே ஏன் வர்றேன் அப்படின்னு தான் கேட்பாங்க. பட் யூ ஷுட் டெல் தம் பொலைட்லி, ஐ ஆம் திஸ் மச் ஸ்டூடெண்ட், ஐ ஆம் செகண்ட் இயர், ஐ வாண்ட் டு லேர்ன் எக்கோ. தென் தே வில் சே ஓகே கம் இன். போன உடனே ஹலோ வாங்க சார் வாங்க உட்காருங்கன்னு யாரும் கூப்பிட மாட்டாங்க. ஸோ யூ ஷுட் ஷோ த இன்ட்ரெஸ்ட். ஐ ஆம் தேர் இன்சைட் த எக்கோ ரூம், ஐ மே நோ கிட் யூ, ஹே ஹூ ஆர் யூ, வை ஆர் யூ கம்மிங். உடனே அப்படியே பயந்துட்டு அப்படியே பின்னாடி போயிட்டோம் அப்படின்னா அப்படியே போக வேண்டியதுதான். யூஸே இருக்காது. பின்னே வரணும். After 5 minutes, you should come, stand there politely. Whenever I open, you should show the face. Okay, okay. I have an interest. Okay, this guy has an interest. Okay, call him. Teach him something. So that's how a teacher knows whom I have to teach. திறந்த உடனே அப்படியே போயிட்டு அப்படின்னா அதுக்கப்புறம் எங்கே போனானே தெரியாது. நம்ம தேடி பார்த்தா கூட கண்டுபிடிக்க முடியாது. ஸோ அந்த மாதிரி இருந்தால் லேர்ன் பண்ணுறது ரொம்ப கஷ்டம். திட்டு வாங்கணும் ஃபர்ஸ்ட் திங். யூ ஷுட் கெட் ஸ்கோல்டிங்ஸ். இட் இஸ் வெரி இம்பார்ட்டன்ட். வித்தவுட் ஸ்கோல்டிங்ஸ் அப்படியே ஜாலியாக எல்லாம் கோனைஸ் மாதிரியே கிடைக்குமா? கிடைக்காது. திட்டு வாங்கணும். 10 தடவை திட்டு வாங்கணும். எக்கோ லேர்ன் பண்ணனா திட்டு வாங்கணும். ரூமுக்கு உள்ளே போனாலும் திட்டு கிடைக்கும். பேஷண்ட் இருக்காங்க 4 பேர் போனால் 4 பேருக்கும் திட்டு கிடைக்கும். டெய்லி யூ ஹாவ் டு கெட் ஸ்கோல்டிங்ஸ். ட்ரெயின் யுவர் செல்ஃப். ஒன்ஸ் யூ கெட் ஸ்கோல்டிங்ஸ், ஒரு ஸ்டேஜில் எல்லாம் மறத்து போயிடும். மறத்து போன அப்புறம் you will start jumping and learning. Sir நான் படிக்கணும். You will start. So that's how you should start learning. டீச்சர் திட்டாங்க, சார் திட்டுறாரு, பிஎஸ் திட்டுறாங்க, சீனியர் பெரியாளா அவங்க அப்படியே நினைச்சிட்டு இருந்தா வீட்லயே உட்கார வேண்டியதான், வரவே தேவையில்லை. ஸோ ஃபர்ஸ்ட் ஸ்டெப் ஃபார் லேர்னிங் இஸ், இந்த ஹெசிடேஷன் இருக்கும், கொஞ்சம் இருக்கும், பட் ட்ரை டு மினிமைஸ் இட். அக்செப்ட் ஸ்கோல்டிங்ஸ் கிரேஸ்ஃபுல்லி. show your interest. Keep on showing your interest. Otherwise, learning will be very difficult. So then learn properly. Learn properly from basic teaching. Understand the basics. Learn from your seniors. I think all your physician assistants and technologies have gone all over the world. From, I think your batch started, first batch about 1989. Now they are spread all over the world. If you name any country, some physician assistant from Triple is there. So you should all be proud that you have selected a very beautiful course, very charming course. நான் MBBS படிக்கும்போது இந்த கோர்ஸ் இல்லை, இருந்துன்னா பேசாமல் சேர்ந்துருக்கலாம். So I would have thought, because salary is low in MBBS. Physician assistant மாதிரி ஏதோ சயின்ஸ் அதுன்னு போயிட்டு எக்கோ நம்ம போயிட்டு மேயோ கிளினிக்ல உட்காந்துருந்தோம்னா, the people will pray me and make me to learn and teach somebody. So I have a passion in teaching. So if you are interested to learn, open the door, get 3 times scolding, frequent scoldings, then you come, I will teach you. So thank you for all your patience.
Thank you, sir. We agree with you that learning echocardiogram is much more easier than understanding Ponniyin Selvan's story. Thank you so much.
So last, I think Ponniyin Selvan only one, I think.
You won, sir. Thank you so much. We are expecting our special guest arrival soon, and then we'll begin with the inaugural function of Physician Associate Tricennial Celebration 2022.
We are expecting our chief guest arrival shortly. Please maintain silence. I request all of you to be seated on your seats. Our chief guest has arrived, it seems. Kindly maintain silence. We request all of you to put your mobiles on silent. இதோ வருகிறார் நம் மாரத்தான் வீரன், நம் மாண்புமிகு அமைச்சர், விழாவின் நாயகன், மருத்துவத் துறையின் செயல் வீரரே. கிரிக்கெட்டில் சதம் அடித்தவர்கள் உண்டு, ஆனால் இவரோ 100 மாரத்தான் போட்டிகளில் கலந்து கொண்டு சதம் அடித்தவர். வருக வருக ஐயா. இவருடன் இந்நாளை பொன்னாளாக்க நம்முடன் வருகை தந்திருக்கும் நம் சட்டமன்ற உறுப்பினர் திரு ஜோசப் சாம்பல் அவர்கள். வருக வருக ஐயா. மற்றும் தலைமை நிர்வாக அதிகாரி மருத்துவர் ராஜஜார்ஜ் அவர்கள், மேலாளர் திரு எம் பிலிப் அவர்கள், இதய அறுவை சிகிச்சை பிரிவின் இயக்குனர் டாக்டர் ராஜன் அவர்கள், இதயவியல் துறை இயக்குனர் மருத்துவர் முல்லாசாரி அஜத் அவர்கள் அனைவரையும் மேடைக்கு வருமாறு தாழ்மையுடன் அழைக்கிறோம். Please be seated. கல் தோன்றி மண் தோன்றா காலத்தே வாளோடு முன் தோன்றிய மூத்த குடி நம் குடி. அக்குடி மொழிந்த முதல் மொழி நம் தமிழ் மொழி. மெல்லின உதடும் இடையினை நாக்கும் வல்லின பல்லும் இணைந்து பிறந்த அழகிய தேன் தமிழே. சீராய் அமைந்திட சீர்களை வகுத்து அடியென பிரித்து பாவுக்கு உருவமிட்ட யாப்பின் அழகே. உன்னுள்ளாந்த இலக்கிய சுவையிலும் இலக்கண நடையிலும் என்னையே மறந்தேன் என் தேன் தமிழே. அகத்தியன் கண்ட அமுத மொழியே, உலகத்தின் முதல் மொழியே, தரணி போற்றும் என் மொழியே. கடவுளே இறங்கி வந்து சங்கம் அமைத்து வளர்த்த எம் தமிழே. தமிழாகிய பெண்ணே, தமிழ் தாயே, உன்னை வணங்கி இந்நிகழ்ச்சியை துவங்குகிறோம். தமிழ் தாய் வாழ்த்து. அனைவரும் இருக்கையிலிருந்து எழுந்து நிற்குமாறு கேட்டுக்கொள்ளப்படுகிறது.
நீராறும் கடலுடுத்த நிலமடந்த கெழிலொழுகும் சீராரும் வதனமென திகழ் பரத கண்டமிதில் தெக்கணமும் மதிச்சிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே. அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே. தமிழனங்கே உன் சீரிழமை திறம்பிறந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
யாமறிந்த மொழிகளிலே தமிழ் மொழியைப் போல் இனிதானது எங்கும் காணோம் என்ற கூற்றிற்கேற்ப இனிய தமிழை இன்னிய குரலால் இசைத்ததற்கு நன்றி.
வேண்டுதல் வேண்டாமை இலானடி சேர்ந்தார்க்கு யாண்டும் இடும்பை இல. அதாவது விருப்பும் வெறுப்பும் இல்லாதவனாகிய இறைவனின் திருவடிகளை சேர்ந்தவர்களுக்கு எவ்விடத்திலும் எக்காலத்திலும் துன்பம் இல்லை என்னும் பொய்யாமொழியின் கூற்றிற்கிணங்க இறைவணக்கம் கூற ரெவரண்ட் ஃபாதர் எபிஎம் சாக்கோ அவர்களை பணிவன்புடன் மேடைக்கு அழைக்கின்றோம். அனைவரும் தங்கள் இருக்கையிலிருந்து எழுமாறு அன்புடன் கேட்டுக்கொள்கிறோம்.
Let us look unto the Lord for prayer. Gracious Lord, the creator and sustainer of all living and non-living things in this universe, we bow down before your magnificence. Bless us from the treasure house of grace. Lord, we have come before thee to praise you, to glorify you, and to give thanks to you for your divine providence. Help us to acknowledge your presence in everything in this universe. Help us to see the divine in the face of our fellow beings, so we will be able to treat and care for each of the patients as we are caring for you, Lord. O God of all healing and life, bless our gathering. Bless our chief guest, our minister, to be empowered and to continue the good works for the benefit of the state and people. Bless our MLA to continue the service for the people. Our God of divine providence, we pray for our Madras Medical Mission. Bless our management bodies, our secretary, treasurer, other board members, CEO, and all our staffs to bring this healthcare institution to the forefront of the healing ministry. Bless all our doctors, nurses, paramedics, administrative and support staffs. Lord God, we pray for the physician associates. Bless all of them to help people in need to healing. Bless all of them to perform their duties without any ego, pride, and selfishness. We pray for this program and all its arrangements. Bless all who have toiled behind this. Bless this program as a whole. May we glorify you now and always and forever and ever. Amen. Thank you. Please be seated.
Thank you, Father. தமிழன் என்றொரு இனம் உண்டு, தனியே அவர்க்கோர் குணம் உண்டு. எந்த ஒரு நிகழ்வையும் குத்துவிளக்கேற்றி துவங்குவதே தமிழர் மரபு.
நன்றி. சிறப்பு விருந்தினர் மாண்புமிகு அமைச்சர் திரு மா சுப்பிரமணியம் அவர்களை பொன்னாடை போர்த்தி கௌரவிக்குமாறு மேலாளர் திரு எம் பிலிப் அவர்களை அன்புடன் அழைக்கின்றோம். இதய அறுவை சிகிச்சை பிரிவின் இயக்குனர் மருத்துவர் ராஜன் அவர்களை பூங்கொத்து கொடுத்து அமைச்சர் அவர்களை வரவேற்குமாறு அன்புடன் அழைக்கின்றோம். மருத்துவர் லக்ஷ்மணதாஸ் அவர்களை நினைவு பரிசு வழங்குமாறு கேட்டுக்கொள்கிறோம்.
நன்றி ஐயா. இப்பொழுது மதிப்பிற்குரிய சட்டமன்ற உறுப்பினர் திரு ஜோசப் சாம்பல் அவர்களை பொன்னாடை போர்த்தி கௌரவிக்குமாறு தலைமை நிர்வாக அதிகாரி மருத்துவர் ராஜராஜ் அவர்களை அழைக்கிறோம். அடுத்தபடியாக இதயவியல் பிரிவின் இயக்குனர் மருத்துவர் முல்லாசாரி அஜித் அவர்களை பூங்கொத்து கொடுத்து கௌரவிக்குமாறு கேட்டுக்கொள்ளப்படுகிறது. திரு மேலாளர் அவர்களை நினைவு பரிசு வழங்கி கௌரவிக்குமாறு கேட்டுக்கொள்ளப்படுகிறது.
நன்றி. விழாவை சிறப்பிக்க வந்திருக்கும் விருந்தினர்களை வரவேற்க வரவேற்புரை வழங்குமாறு மட்ராஸ் மெடிக்கல் மிஷன் மருத்துவமனையின் தலைமை நிர்வாக அதிகாரி மருத்துவர் ராஜு ஜார்ஜ் அவர்களை மேடைக்கு அழைக்கின்றோம்.
Good morning, everybody. The Physician Assistance Program, as it was then called, was first put together in 1965 by Dr. Eugene Stead of Duke University in the US. This program actually fell out of the 3-year condensed program, which was started for doctors in America during the Second World War, as there was a shortage of doctors. The certification process for the physician assistants was then done in 1961. Today, physician assistants or associates are present in over 15 countries, including Canada, Australia, and Africa. In rural villages in Africa, they are the ones who treat the patients initially, and only then refer the patients on to the hospital. Today, we are proud to be celebrating the 30th anniversary of its inception in India. In India, we at Madras Medical Mission is proud to say that we are the ones who started the program in India by Padma Shri K.M. Cherian. Now, the program is there in many states in India, such as Kerala, Karnataka, Maharashtra, Pondicherry, and West Bengal. Today, we are also honored to have the Right Honorable Thiru Subramanian, the Minister of Health for Tamil Nadu, at this function. The minister, Mr. Subramanian, completed his higher education in Saidapet Government Model Higher Secondary School and did his bachelor's degree from the Open University. He completed his LLB from the Havanur College of Law at Bangalore and became a practicing advocate in the Madras High Court in 1999. He joined the DMK party in 1976 and became chairman of the Chennai Corporation in 2006. In July 2021, he gave up his MLA hostel and his month's supply of groceries to a poor couple whose daughter accidentally swallowed bleach, mistaking it for milk. He was appointed as the health minister in 2021. Honorable Minister, you're most welcome to come. Next, I would like to introduce someone who is no stranger to M. He is our own local MLA. He won the last election, gaining over 48% of the votes. He's a strong supporter of M. Mr. Samuel, you are most welcome. I would like to introduce someone who is the epitome of the Madras Medical Mission. Because of his unrelenting and selfless work, we have been able to achieve peaks in our patient care. The man who is at the helm of M, and most importantly, who is responsible for paying my salary. Mr. Philip, You are most welcome. Then I would like to introduce the MGR of Triple M. Although he's not as old as MGR, he's the ever young surgeon, Dr. Rajan. Even yesterday, he operated till late night. So he operates from morning till 10 o'clock. He's ever young. Dr. Rajan, you're most welcome. The cardiology department is headed by Dr. Ajit Mullasheri, who is an international figure in interventional cardiology. He's a visiting professor of cardiology in the United States and here at the IIT Chennai. The department under him has probably done the most number of interventional cardiology procedures in India. Dr. Ajit, you are most welcome to this occasion. There is also a little bit of secret about him. He's a very, very good classical violinist player, and he has conducted lots of kacheris. Next, I would like to introduce somebody who spends nearly all his life at the Madras Medical Mission. He comes to work at 8 o'clock in the morning and doesn't go home until 8 o'clock at night. And patients wait for at least 8 hours just to see him. They come from far off places. Dr. Lakshmana Das, I would like to... I'm really very, very jealous of him because I don't know how he manages to keep so fit and so young looking and thin. I would like to welcome all of you physician associates and those in training present here today whose anniversary we are celebrating. You make us proud. Madras Medical Mission runs because of you. Finally, I would like to welcome all the members of the audience, without whose participation today's program would not have been possible. You're all welcome. Thank you.
Thank you so much, sir. மக்கள் தொண்டே மகேசன் தொண்டு என்று மக்கள் சேவையாற்ற மக்களால் தேர்ந்தெடுக்கப்பட்ட நம் தமிழக சட்டமன்ற உறுப்பினர் திரு ஜோசப் சாமுவேல் அவர்களை மேடைக்கு அழைக்கிறோம்.
சிறப்புமிக்க மருத்துவ உதவியாளர் முத்து விழாவில் ட்ரிபிள் எம் ஹாஸ்பிட்டல் இந்த நிகழ்வுக்கு வருகை தந்து பெருமை சேர்த்து கொண்டிருக்கின்ற நம்முடைய மக்கள் நல அமைச்சர் மரியாதைக்குரிய நான் மா சுப்பிரமணியன் அவர்களே, இந்த நிகழ்வில் வரவேற்பு வழங்கியிருக்கின்ற மரியாதைக்குரிய டாக்டர் ராஜு ஜார்ஜ் அவர்களே, மரியாதைக்குரிய திரு எம் பிலிப் அவர்களே, டாக்டர் ராஜன் அவர்களே, திரு முல்லையர் அஜித் அவர்களே, டாக்டர் லட்சுமண் தாஸ் அவர்களே மற்றும் இந்த நிகழ்வில் துவக்கத்தில் பிரேயர் வழங்கிய ரெவரண்ட் பாஸ்டர் அபைட் சாக்கா அவர்களே மற்றும் மருத்துவர்களே, உதவியாளர்களே, பல்வேறு துறையைச் சேர்ந்த ஊழியர்கள் உங்கள் அனைவருக்கும் நன்றி கலந்த வணக்கத்தை தெரிவித்துக் கொள்கின்றேன். ஒரு சிறப்பான தினமாக இன்று அம்பத்தூர் சட்டமன்ற தொகுதிக்கு உட்பட்ட ட்ரிபிள் எம் மருத்துவமனையில் ஒரு நல்ல நிகழ்வில் மருத்துவ உதவியர் முத்து விழா என்ற ஒரு நிகழ்ச்சியில் ஏற்பாடு செய்து அதையும் எங்களை அழைத்து பெருமைப்படுத்துகின்ற இந்த மருத்துவமனையின் நிர்வாகிகளுக்கு மனமார்ந்த நன்றியினை தெரிவித்துக் கொள்கின்றேன். குறிப்பாக அம்பத்தூர் பகுதியில் ஒரு சிறப்புமிக்க மருத்துவமனையாக, அம்பத்தூருக்கு மட்டும் பெருமை இல்லை, நம்ம தமிழகத்துக்கும் குறிப்பாக ஏழை எளிய அனைத்து மக்களுக்கும் உதவி செய்யக்கூடிய ஒரு மருத்துவமனையாக இந்த பகுதியில் திகழ்ந்து கொண்டிருக்கின்றன. அதற்கு உறுதுணையாக இந்த நிர்வாகம் மிக சிறப்பான பணியாற்றுகின்றன. நம்முடைய மாண்புமிகு முதல்வர் அவர்கள் பொறுப்பேற்ற முதல் மருத்துவத்தில் எந்த அளவுக்கு முன்னேற்ற வேண்டும், அதுக்கு உறுதுணையாக நம்முடைய மாண்புமிகு மக்கள் நல்வாழ்வுத்துறை அமைச்சர் அண்ணன் மா சுப்பிரமணியன் அவர்கள் தொடர்ந்து மக்கள் பணியை மக்களுக்காக தொண்டு செய்கின்ற வகையிலே தமிழகம் முழுவதும் சுற்றி சுற்றி வருகின்ற அமைச்சர் அவர்கள் ஏழை எளிய மக்கள் பல்வேறு பகுதியில் அவர்கள் அந்த சிகிச்சை பெற வேண்டும் என்ற நோக்கத்தோடு தொடர்ந்து பயணித்து வருகின்றார். அந்த வகையிலே அம்பத்தூர் பகுதியில் இருக்கின்ற இந்த மருத்துவமனைக்கு வந்து பெருமை சேர்த்திருக்கின்ற மாண்புமிகு அமைச்சர் அவர்களுக்கு மனமார்ந்த நன்றியினை தெரிவித்துக் கொள்கின்றேன். தொடர்ந்து இந்த மருத்துவமனை உங்களுடைய சேவை சிறப்பான ஒரு சேவையாக நடத்திட வேண்டும். இந்த பகுதியில் நீங்கள் இந்த மருத்துவமனை நான் வந்து பார்க்கும் பொழுது மருத்துவர் உதவியாளர் என்ற ஒரு பாகுபாடு இன்றி அனைவரும் ஒரு நல்ல ஒரு சகோதரத்தோடு அன்போடு நீங்கள் பழகுவதை நான் கண்டிருக்கின்றேன். தொடர்ந்து மக்களுக்காகவும் குறிப்பாக நோயாளிகள் மிக தெளிவாக குறிப்பிட்ட நேரத்தில் அவர்கள் சேர்த்து அவர்கள் பயணித்து அவர்கள் சுகமாக செல்கின்ற வகையில் நீங்கள் உறுதுணையாக இருக்கின்ற உங்களுக்கு எந்த நேரத்திலும் நாங்களும் உறுதுணையாக இருப்போம் என்று கூறிக்கொண்டு இந்த பெரிய வாய்ப்பினை ஏற்படுத்தி கொடுத்த மருத்துவமனை நிர்வாகத்துக்கு மீண்டும் நன்றி தெரிவிக்கிறேன். நன்றி, வணக்கம்.
நன்றி ஐயா. வாணியம்பாடியில் கண்டெடுத்த முத்து இன்று திராவிட முன்னேற்ற கழகத்தின் சொத்து. சமத்துவம் இன்றியமையாத இவ்வுலகில் பாகுபாடு மறைந்து அனைவரும் சமம் எனும் கோட்பாடு மெய்யாக மாற டாக்டர் அம்பேத்கரால் படைக்கப்பட்ட உலகின் மிக நீண்ட அரசியலமைப்பை படித்து முடித்தவர். சென்னை மாநகரின் மேயராக சில காலம் அரசு கடமையாற்றியவர். மனித இனம் மண்ணில் நிலைக்க இன்று சுற்றுப்புற சூழலும் மருத்துவத்தின் தேவையும் இன்றியமையாததாகிவிட்டது. இல்லை என்றால் திரும்பவும் ஊரடங்கு, கொரோனா, குவாரண்டைன், ஆன்லைன் கிளாஸ், டல்கோனா காபி என்ற அடுத்த சுற்றுக்கு தயாராக வேண்டியதுதான். இதிலிருந்து நம்மை காக்க தமிழக அரசால் சுகாதாரம், மருத்துவம், மருத்துவ கல்வி மற்றும் மக்கள் நல்வாழ்வுத்துறையின் அமைச்சராக பொறுப்பேற்று சொல்லுதல் யாருக்கும் எளிய அறியவாம் சொல்லிய வண்ணம் செயல் என்னும் வள்ளுவ பெருந்தகையின் திருக்குறள் மேற்படி தமக்கிட்ட பணியை செம்மையாக செய்து வரும் பெருமதிப்பிற்குரிய அமைச்சர் திரு மா சுப்பிரமணியம் அவர்களை வரவேற்பதில் பெருமை கொள்கிறது தி மெட்ராஸ் மெடிக்கல் மிஷன். ஐயா, இந்த அரங்கே தங்களது பொன்னான வார்த்தைகளை எதிர்நோக்கி காத்திருக்கிறது.
மெட்ராஸ் மெடிக்கல் மிஷனில் நடைபெற்றுக் கொண்டிருக்கிற தேசிய மருத்துவ உதவியாளர் நாள் மற்றும் இம்மருத்துவமனையில் மருத்துவ உதவியாளர் இளங்கலை படிப்பு துவங்கி 30 ஆண்டுகள் நிறைவடைவதை ஒட்டி நடைபெற்றுக் கொண்டிருக்கிற இந்த நிகழ்ச்சிக்கு வருகை தந்து எனக்கு முன்னால் உரை நிகழ்த்தி சிறப்பித்திருக்கிற தொகுதியின் சட்டப்பேரவை உறுப்பினர் பெருமதிப்பிற்குரிய இனிய நண்பர் ஜோசப் சாமுவேல் அவர்களே, தொடக்கத்தில் வந்திருப்பவர்களை எல்லாம் வரவேற்று சிறப்பித்திருக்கிற ட்ரிபிள் அமைப்பின் CEO பெருமதிப்பிற்குரிய ராஜு ஜார்ஜ் அவர்களே, வருகை தந்து சிறப்பித்துக் கொண்டிருக்கிற MM பிலிப் அவர்களே, திரு ராஜன் அவர்களே, மரியாதைக்குரிய முல்லைசாரி அஜித் அவர்களே, இறுதியாக நன்றியுரையாற்றவிருக்கிற லக்ஷ்மணதாஸ் அவர்களே, வருகை தந்து சிறப்பித்துக் கொண்டிருக்கிற மருத்துவர் பெருமக்களே, மருத்துவம் சார்ந்த களப்பணியாளர்களே, பத்திரிகையாளர்களே, ஊடகவியலாளர்களே, மாணவ பெருமக்களே, உங்கள் அத்தனை பேருக்கும் முதலில் என்னுடைய நன்றி கலந்த வணக்கத்தினை தெரிவித்துக் கொள்கின்றேன். தேசிய மருத்துவ உதவியாளர் நாள் மற்றும் இன்றைக்கு இந்த மருத்துவமனையில் அந்த ஒரு இளங்கலை படிப்பை தொடங்கி 30 ஆண்டுகள் நிறைவடைவதையொட்டி நடைபெற்றுக் கொண்டிருக்கிற இந்த நிகழ்ச்சியில் நானும் கலந்து கொள்வதற்கான இந்த நல்ல வாய்ப்பை அளித்திருக்கிற இந்த நிர்வாகத்திற்கு என்னுடைய நன்றியினை தெரிவித்துக் கொள்கின்றேன். எனக்கு முன்னால் பேசிய இனிய நண்பர் ஜோசப் சாமுவேல் அவர்கள் எடுத்து சொன்னதைப் போல இந்த இளங்கலை படிப்பு என்பது இன்றைக்கு எந்த அளவுக்கு அவசியமானது என்பதை உலகின் பல்வேறு நாடுகளும் இந்தியாவில் பல்வேறு மாநிலங்களும் உணர்ந்திருக்கிற காரணத்தினால் இது பல மாநிலங்களில் இப்பொழுது படிப்படியாக தொடங்கப்பட்டு கொண்டிருக்கிறது. இங்கும் கூட நம்முடைய இந்த துறையை சார்ந்தவர்களுடைய கோரிக்கை, இது அரசின் சார்பில் அங்கீகரிக்கப்பட்ட ஒரு படிப்பாக கருதி அரசு வேலை வாய்ப்புகளிலும் இதற்கு முன்னுரிமை வழங்க வேண்டும் என்கின்ற கோரிக்கை வைக்கப்பட்டிருக்கிறது. பொதுவாகவே மருத்துவத்துறையில் இன்றைக்கு அந்த மருத்துவ கட்டமைப்பை மேம்படுத்தப்பட வேண்டியது என்பது அவசியமான ஒன்றாக இருக்கிறது. மருத்துவத்துறையில் இன்றைக்கு மிகப்பெரிய அளவில் ரோபோட்டிக் போன்ற அதிநவீன தொழில்நுட்பத்துடன் கூடிய கருவிகளை பயன்படுத்த தொடங்கி இருந்தாலும் கூட மருத்துவர்களும் மருத்துவம் சார்ந்த களப்பணியாளர்களின் தேவை என்பது இருந்து கொண்டுதான் இருக்கிறது. எனவே மிகப்பெரிய அளவிலான அவசிய தேவைகளில் ஒன்றாக இருக்கிற மருத்துவம் சார்ந்த களப்பணியாளர்களின் அந்த தேவை என்பது உலக அளவில் பெருகி கொண்டே இருக்கிறது. 2019 இறுதியில் யாரும் நினைத்தே பார்க்க முடியாத ஒரு பேரிடர் உலகையே உலுக்கி எடுத்தது. இன்னமும் கூட நாம் அந்த பேரிடரிலிருந்து முழுமையாக விலகி வந்ததாக தெரியவில்லை. முதலில் கொரோனா என்று தொடங்கிய வைரஸ் அது ஒவ்வொரு உருமாற்றம் பெற்று தொடர்ச்சியாக பல பெயர்களில் இன்றைக்கு நம்மை தாக்கி கொண்டே இருக்கிறது. கொரோனா என்று தொடங்கியது ஆல்பா, பீட்டா, டெல்டா பிளஸ், அதே போல் கம்மா, கப்பா, ஒமிக்ரானிலேயே BA1, BA2, BA3, BA4, BA5, அதிலும் கூட இன்னமும் பல பிரிவுகள் என்கின்ற வகையில் தொடர்ச்சியாக அந்த வைரஸின் தாக்கம் உலகையே உலுக்கி கொண்டிருக்கிறது. இது ஒரு முடிவுக்கு வருகிற தருவாயில் இருந்து கொண்டிருக்கிற இந்த சூழலில் இப்பொழுது புதிதாக H1N1 என்கின்ற வைரஸ் அனைவருமே அது ஒரு அச்சுறுத்த தொடங்கி இருக்கிறது. 2019 இறுதியில் முகங்களை மூட தொடங்கிய நாம் ஒரு விடிவு வந்து விட்டது, கொரோனாவிலிருந்து மீண்டு வந்திருக்கிறோம், நம்முடைய முகங்களை வெளி உலகுக்கு காட்டலாம் என்று தொடங்கினால் H1N1 வைரஸ் இதுக்கும் கூட முகக்கவசம் அணிவது அவசியம் என்று மருத்துவர்களின் அறிவுறுத்தல் இன்றைக்கு சொல்லிக் கொண்டிருக்கிறார். பொதுவாகவே ஒரு H1N1 பாதிக்கப்பட்டவர் இருமும் போதோ தும்மும் போதோ அவருடைய நீர்த்திவலைகள் மற்றவர்கள் மேல் படுகிற போது இந்த H1N1 தாக்கம் அவர்களை எதிரில் இருப்பவர்களையும் தாக்கும் என்கின்ற காரணத்தினால் H1N1 பாதிப்புக்கும் கூட முகக்கவசம் அவசியம் என்பது இன்றைக்கு சொல்லப்பட்டிருக்கிறது. இப்படி நம்மால் கடந்த ஒரு 2.5 ஆண்டுகளுக்கும் மேலாக வெளி உலகில் ஒரு சுதந்திரமாக நடமாடவே முடியாத ஒரு நிலை என்பது தொடர்ச்சியாக இந்த வைரஸ்களினால் ஏற்பட்டு கொண்டே இருக்கிறது. வைரஸ்களின் உருமாற்றம் இன்றோடு முடியுமா அல்லது நாளை முடியுமா என்கின்ற அளவில் ஒரு கேள்விக்குறியாகவே இருந்து கொண்டிருக்கிற நிலையில் மருத்துவர்கள் சேவை என்பது, இந்த மருத்துவ தேவை என்பது உலக அளவில் பெரிய அளவிலே இருந்து கொண்டிருக்கிறது. அதற்காகத்தான் இன்றைக்கு இந்த மருத்துவ உதவியாளர்கள் அதற்கான ஒரு புதிய இளங்கலை படிப்புகள் என்பது உலக அளவில் தோன்றியிருந்தாலும் கூட தமிழகத்தை பொறுத்தவரை இன்றைக்கு ஒரு 11 அரசு மருத்துவக் கல்லூரிகளில் 220 இடங்களுடனான ஒரு படிப்பாகவும் 65 தனியார் சுயநிதி கல்லூரிகளில் ஒரு 1170 இடங்கள் கொண்ட ஒரு கல்வி பிரிவாகவும் இருக்கிறது. எனவே இது இன்னமும் கூட பல்வேறு கல்லூரிகளில் தொடங்கப்பட வேண்டும் என்றால் இந்த படித்து முடித்ததற்கு இவர்களுக்கான வாய்ப்புகள் அரசிலோ அல்லது தனியார் துறையிலோ மேம்படுத்தப்படும் போதுதான் இந்த கல்வியில் சேர்வதற்கான நாட்டம் மற்ற இளைஞர்களுக்கு கூடுதலாக வருவதற்கு வாய்ப்பு இருக்கிறது. எனவே நிச்சயம் மாண்புமிகு தமிழக முதல்வர் அவர்களுடைய கவனத்திற்கு கொண்டு சென்று இந்த மருத்துவ உதவியாளர் பணியிடங்களை தமிழக அரசின் மருத்துவத்துறையிலும் ஏற்படுத்தி அதிலே சேர்வதற்கான வாய்ப்பையும் உருவாக்கி, அதோடு மட்டுமல்ல இப்பொழுது 11 மருத்துவக் கல்லூரி மருத்துவமனைகளில் இயங்கிக் கொண்டிருக்கிற இந்த பாடப்பிரிவுகளை தமிழகத்தை பொறுத்தவரை இன்றைக்கு 36 அரசு மருத்துவக் கல்லூரி மருத்துவமனைகள் இருக்கிறது, 34 தனியார் மருத்துவக் கல்லூரி மருத்துவமனைகள் இருக்கிறது. ஒட்டுமொத்தமாக இந்தியாவிலேயே அதிகமான மருத்துவக் கல்லூரி மருத்துவமனைகள் இருப்பது தமிழகத்தில் மட்டும்தான். இன்னமும் கூட ஒரு 6 மாவட்டங்களில் முத்தமிழறிஞர் கலைஞர் அவர்கள் 2011ஆம் ஆண்டு சட்டமன்றத்திலேயே உரையாற்றினார்கள். தமிழகத்தை பொறுத்தவரை ஒரு மாவட்டத்திற்கு ஒரு மருத்துவக் கல்லூரி வேண்டும் என்கின்ற ஒரு தீர்மானத்தை கொண்டு வந்தார்கள். அந்த வகையில் இன்றைக்கு தமிழகத்தில் ஒரு 36 மருத்துவக் கல்லூரிகள் இருந்தாலும் இன்னமும் ஒரு 6 மாவட்டங்களில் தென்காசி, மயிலாடுதுறை, ராணிப்பேட்டை, திருப்பத்தூர், பெரம்பலூர், காஞ்சிபுரம் ஆகிய 6 மாவட்டங்களில் மருத்துவக் கல்லூரிகள் புதிதாக தொடங்கப்பட வேண்டிய அவசியம் இருக்கிறது. அண்மையிலே கூட நாங்கள் டெல்லிக்கு சென்றிருந்த போது மாண்புமிகு முதல்வர் அவர்களுடைய அந்த வழிகாட்டுதலை ஏற்று ஒன்றிய அரசாங்கத்திடம் அதை தொடர்ந்து வலியுறுத்தி கொண்டிருக்கிறோம். எனவே கூடுதலாக எத்தனை மருத்துவக் கல்லூரி மருத்துவமனைகள் வந்தாலும் எல்லா மருத்துவக் கல்லூரி மருத்துவமனைகளிலும் இந்த மருத்துவ உதவியாளர் பணியிடங்களையும் அதற்கான தனிப்பிரிவுகளையும் பாடப்பிரிவுகளையும் உருவாக்குவதற்கான நடவடிக்கைகள் எதிர்காலத்தில் எடுக்கப்படும் என்கின்ற அந்த உறுதியினை உங்களிடையே தெரிவித்துக் கொள்வதில் நான் மகிழ்ச்சி அடைகிறேன், பெருமை அடைகிறேன். மரியாதைக்குரிய ஜோசப் சொல்லும் போது சொன்னார், இந்த மருத்துவமனை ட்ரிபிள் எம் என்பது இன்றைக்கு அம்பத்தூருக்கு ஒரு அடையாளமாக இருக்கிறது என்று சொன்னார். அதிலிருந்து நான் சற்று மாறுபடுகிறேன். இது அம்பத்தூரின் அடையாளம் மட்டுமல்ல, சென்னையின் அடையாளம், ஒட்டுமொத்த தமிழகத்தின் ஒரு பெருமைமிகு அடையாளங்களில் ஒன்றாக இந்த மருத்துவமனை இருக்கிறது. இதை நாங்கள் நீண்ட நாட்களாக கவனித்து வருகிறோம். அந்த வகையில் இந்த மருத்துவமனையின் மருத்துவ சேவை தொடர வேண்டும் என்று வாழ்த்தி, இப்பாடப்பிரிவுகளில் பயின்று ஒரு 30 ஆண்டுகள் தொடர்ச்சியாக இந்த பாடப்பிரிவுகள் இங்கே தொடங்குவதற்கும் இந்த மருத்துவமனையில் காரணமாக இந்தியாவுக்கே இந்த மருத்துவ பிரிவுகள் இங்கே தொடங்குவது, இந்த பாடப்பிரிவுகள் இங்கே தொடங்கி இதற்கு ஒரு அடையாளமாகவே இந்த டிபிலம் இருப்பதற்கு என்னுடைய மகிழ்ச்சி நிறைந்த பாராட்டுதல்களை தெரிவித்து வாய்ப்புக்கு நன்றி கூறி விடைபெறுகிறேன். நன்றி, வணக்கம்.
மானிட வாழ்வில் மகத்துவம் மரணம் வரைதான் என்பதால் இன்பம் துன்பம் சாதி மதம் ஏற்றம் தாழ்வு என்று எந்தவித பேதமும் பாராமல் மருத்துவ சேவை ஆற்றிக் கொண்டிருக்கும் ஒவ்வொரு மருத்துவத்துறை ஊழியருக்கும் வீர வணக்கத்தையும் நன்றியையும் தெரிவித்து, தங்கள் பொன்னான வார்த்தைகளுக்கும் பொன்னான நேரத்தையும் எங்களுக்காக செலவிட்ட அமைச்சர் அவர்களுக்கு நன்றி ஐயா. அடுத்து கேட்லாப் துறை தலைவர் மருத்துவர் லக்ஷ்மணதாஸ் அவர்களை நன்றியுரை வழங்க தாழ்மையுடன் அழைக்கிறோம்.
இந்த இனிய காலை பொழுதிலே இங்கே கூடியிருக்கக்கூடிய பெரிய கூட்டத்தை பார்க்கும்போது எனக்கு ரொம்ப சந்தோஷமா இருக்கு. ஏன்னா காலையில் ஒருத்தரும் இந்த பக்கம்லாம் இருக்க மாட்டாங்க. எல்லாரும் அவங்கவுங்க வேலையை பார்த்துட்டு இதெல்லாம் காலியாக இருக்கும் சாதாரணமாக. ஸோ இப்படிப்பட்ட ஒரு பெரிய அரங்கிலே இருந்து ஒரு நல்ல நிகழ்வினை ஃபிசிஷியன் அசிஸ்டன்ட்னு சொல்லக்கூடிய ஒரு ப்ரோக்ராம் வந்து நான் ஆஸ்பத்திரிக்குள்ளே என்ட்ரு ஆனதுல இருந்து ஒவ்வொரு நிமிஷமும் அப்போவே ஆரம்பிக்குது நம்ம தொழில். என்னுடைய மருத்துவக்கலை நண்பர்கள் பிரிட்டோ, அனிருத் எல்லாருமே முதல்ல ஆரம்பிக்கும் போதே அவங்ககிட்ட தான் ஆரம்பிக்கும். இப்படி ஒரு நாள் முழுவதும் முடிகிற வரைக்கும் கூட, பின்ன முடிஞ்சு வீட்டுக்கு போனதுக்கு அப்புறம் கூட என்னுடைய பேஷண்ட்டுடைய கேர் ஒவ்வொரு நிமிஷமும் இந்த மருத்துவ உதவியாளர் என்று சொல்லக்கூடிய ஃபிசிஷியன் அசிஸ்டன்ஸ், தே ஆர் பார்ட் அண்ட் பார்சல் ஆஃப் மை ப்ரோக்ராம். அது மட்டும் இல்லாமல் எல்லா துறைகளிலுமே அறுவை சிகிச்சையோ இல்லை மருத்துவத்துறையோ, இன்டென்சிவ் கேரு, எக்கோகார்டியோகிராம், எல்லா துறைகளிலுமே அவங்க செய்யக்கூடிய அவங்களுடைய திறமை, தே ஆர் மோர் ஃபோக்கஸ்ட். அதனால அவங்களுடைய தேவை, அவங்களுடைய உதவி வந்து எங்களுக்கு இன்றியமையாததாக இருக்கிறது இன்றைக்கு. அப்படிப்பட்ட ஒரு ப்ரோக்ராமுக்கு என்னையும் கூப்பிட்டு ஒரு நன்றி உரைக்கு கூப்பிட்டதற்காக நன்றியை தெரிவித்துக் கொள்கிறேன் முதல் கண். இரண்டாவது, நம்முடைய மாமன்ற எம்எல்ஏ அம்பத்தூர் ஜோசப் சாமுவேல் அவர்கள், அவர் நமக்கு புதியவர் அல்ல, ரொம்ப பழக்கமானவர். எப்பவுமே ஏதாவது உதவி வேணும் அப்படின்னு சொன்னான்னா இந்த தொகுதிக்கு இந்த ஆஸ்பத்திரி சம்பந்தமான வசதிகள் உடனடியாக அவர் உடனே அதுக்கு செவிமடுத்து அதை ஏற்று செய்யக்கூடியவர். அவர் இங்கு வந்து இந்த நிகழ்ச்சியை சிறப்பித்ததற்காக ஐயா உங்களுக்கு நன்றி. அடுத்து முன்னாள் மாநகர தந்தை, இந்நாள் மக்கள் நலத்துறை அமைச்சர் மா சுப்பிரமணியம் அவர்களை பற்றி சொல்ல தேவையில்லை. அவர் மருத்துவத்துறைங்கிறது வந்து ரொம்ப ஸ்ட்ராங்காக இருக்கணும், ஹெல்த்தியாக இருக்கணும். அதற்கு வந்து அவர் ஒரு எடுத்துக்காட்டு. வரும்போதே சொன்னாங்க 100 மாரத்தான் கண்ட மாவீரர் அப்படின்னு. அதுக்கு ஏற்ற மாதிரி இந்த மருத்துவத்துறையை வந்து கட்டுக்கோப்போடு ஆரோக்கியமாக இன்று நடத்தி செல்லக்கூடிய, இங்கு வந்து இந்த நல்ல உரை அறிவித்த அந்த நமக்கு மக்கள் நல மருத்துவ உதவியாளர்களுடைய அந்த கோர்ஸை மாநிலம் முழுவதுமாக எடுத்து செல்லக்கூடிய, வேலைவாய்ப்பை அதிகமாக்கி கொடுக்கக்கூடிய முறையிலே அவர் முதல்வருக்கு எடுத்து செல்கிறேன் என்று சொல்லியிருக்கிறார். அதற்காக அவருக்கு நன்றி தெரிவித்துக் கொள்கிறோம். அது மட்டுமல்லாமல் இந்த நிகழ்ச்சி நடப்பதற்காக உதவி செய்த எல்லோரும், மேனேஜ்மெண்ட், எலக்ட்ரிசிட்டி, காவலர்கள், நம்ம போட்டோகிராஃபர் எல்லாருக்கும் சேர்த்து என்னுடைய நன்றியை தெரிவித்துக் கொண்டு இந்த உரையை முடித்துக் கொள்கிறேன். நன்றி, வணக்கம்.
நன்றி ஐயா. புதுநாளில் உதயமாகும் கீதம் கேட்டு தென்றலில் வீரமாய் பறிக்கிறது தேசிய கொடி. அடுத்து தேசிய கீதம்.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता, Punjab, Sindh, Gujarat, Maratha, Dravida, Utkala, Banga, Vindhya, Himachala, Yamuna, Ganga, Uchchala, Jalati, Taranga. Tava Shubha Name Jage, Tava Shubha Asisha Mage, Gahe Dava Jaya Gada. Janagana Mangaladayaka Jaya He Bharat Bhakya Vidada. Jaya He, Jaya He, Jaya He, Jaya 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 He.
Please be seated.
அடுத்தபடியாக மருத்துவ உதவியாளர்களின் வரலாறு மற்றும் மைல்கல் பற்றி நம்முடைய எடுத்துரைக்க வருகிறார் மெட்ராஸ் மெடிக்கல் மிஷனின் இதய அறுவை சிகிச்சை பிரிவின் இயக்குனர் மருத்துவர் ராஜன் அவர்கள்.
வா ஸ்லைடு நீ மாத்திரையா நான் மாத்திரமா? இல்ல இதானா? Good morning, everyone. Even though it is a little bit delayed, I don't want to delay further. And I think most of the youngsters won't know how this program started, what all the turmoils we faced, and especially why we are here after 30 years. It started with a very small spark. In 92, after long discussion, we decided we should start the physician assistance program. Of course, no university was willing to take up this program. Hence, Council of Madras Medical Mission decided to start as its own course in Madras Medical Mission. It was a one-year diploma in PA, that is post-degree course, and 3 people joined that course that year. And 2 of them are still working in MMM. One is working in Hyderabad. So subsequently, we had Dr. Ramakrishnan, who is a biochemistry doctorate from BITS, and he helped to set the program. And in collaboration with BITS, we started in 93 MES-PA program, which is 2 years. Subsequently, it became MPhil PA program 3 years. All these are all post, after undergraduation, we were doing this program, and these were the initial batches. Then we started taking +2 candidates as undergraduate program. It was a 4-year BS-PA degree gets given by BITS Pilani, and because of government stopping all the offshore programs, it has to come to a stop. even though BITS felt very bad about stopping this program because it was running so well with the MMM. Last batch of MMM BITS completed in 2017. And meanwhile, when these things were brewing up, we wanted this program to continue. So we approached Dr. MGR Medical University in Tamil Nadu and started simultaneous physician assistant program along with MGR Medical University. The first batch of students started in 2010. Initially, it was only a 3-year program. Then we made it 3-year plus 1 year internship, because without internship, the program was incomplete, we felt. And MGR Medical University accepted and implemented that. And also, MPhil and PhD are offered to the PA graduates who are interested in pursuing higher studies and able to get into various universities in the abroad. And meanwhile, MMM itself evolved gradually into the academic area. Initially, it was the Council of Madras Medical Mission, which became MMM BITS Training Center, which was only training PA candidates. Subsequently, we started a lot of allied health courses, become MMM Academy of Medical Sciences. Then few of the non-medical health related courses also started, and it became 2009 MMM College of Health Sciences. This is the evaluation of Madras Medical Mission in offering so many other health related courses. And we have about 412 graduates passed out of MMM BITS program. And so far under MGR Medical University, we have 161 graduates passing. A small video about this program. Me and my mentor, Dr. Cherian, visited US in the early 90s. Dr. Cherian had spent time in US even earlier. So he knew about the concept of physician assistant program, which is well entrenched in US. So he wanted to start the same thing in India. So in the early 90s, then we devised a concept and started the physician assistant program in our own institute as our own program initially. And then we started as a off-site campus combination with the Madras Medical Mission, the physician assistant program, which became one of the biggest hits in Indian scenario.
And you still train PAs here?
Yeah, we have a program now with MGR Medical University. We take about 20 plus candidates every year, which is a 3+1 program, 3 years of course, but plus 1 year of internship now. And we train regularly physician assistants along with MGR Medical University now.
This is all more than 10 years before any other university recognized it. And we in Madras Medical Mission were the first one running this program, and the program became very popular among the students, those who could not get into medicine, but they had good marks, motivated, very energetic, very intelligent boys and girls. So we started that, and 95, the first batch completed. And I was lucky that my good old friend, Professor Christian Bernard, agreed to come for that function. And I used that opportunity to request him to give off the degree certificates for the first batch.
So this is mainly the initial stages. We started this program mainly to cater the needs of the cardiac division, all cardiac surgery, cardiac anesthesia, cardiology, everything. But they initially worked as first, second assistants. They harvest a vein, radial artery, lima, and prepare homographs. So many other things they do. But now they are now spreading into all other specialties and other areas, which I'll show you. And these are all the initial mentors in the PA program. Professor Ramakrishnan played a very key role in shaping up this program and taking to the next level. Dr. Emmanuel succeeded him, and later Dr. Philomena Mariadas, and presently Deepa Philip heads this program. And these are all some pictures. Some of the convocation. This is Christine Bernard. And this is the first batch of PAs. This is Dr. Donald Ross during the graduation ceremony. These are all the initial batch of students. The Professor Taniga Chalam, who came for a function in PA program. And they harvest veins. These are all the recent batches of students who passed out. And apart from that, they take part in so many other days, social activities, games, music. See, they are versatile students. And this is a new theatre complex, what we have started, where all these CPS get trained and work. And this is the inside of the theatre. And if you see the physician assistant, not only they help with that, now they do a endoscopic vein harvesting and help with robotics, TAVI, and endoscopic radial harvesting. These are all the few in cardiac, but there are like this tens of other things in other specialties. So now various universities and institutes have started physician assistant program. More than 50 institutes in India offer PA program in collaboration with more than 110 universities. Initially started, as I told you, exclusively for cardiac related work. Now they are spreading to all other specialties: general medicine, general surgery, trauma care, orthopedics, obstetric gynecology, oncology, ENT, and emergency medicine, to name a few. Presently, allied healthcare bill had been passed by the central government, and they are recognized as physician associates in India after a long, hard journey, and which is a real landmark in their career. And apart from clinical work, they involved in various research programs all over the world, like clinical embryology. Then they go for hospital management, medical IT, pharmaceutical and medical devices, and other specialties I told you. Even the government have recognized their work, and Government Stanley Medical College recently had recruited 14 physician assistants for their program. So PS play a very big role in research activities, help in scientific paper publications. PS in India have contributed to more than 300 scientific papers till date, which are published in leading national and international journals. Jobs that a trained PA can do is not only limited to the above, and the list is long and diverse to be mentioned here. And this one slide will show you what your PA can do. Maybe I leave it for 30 seconds so that you can read the slide. See, now the PA's role is expanding like anything. They can merge themselves into any kind of role because they are integrated. Their course and the training makes them suitable for any kind of work in healthcare. So we are very proud to start this program. When we started, we were not sure whether this program will sustain, how students are going to take, how the medical industry is going to take. Because I know initially in Cardiac Surgical Association, when we talk about the PA program, there was a big opposition because all the cardiac surgeons thought they are going to take away the junior surgeon's job. But 30 years down the line now, every cardiac surgeon wants a physician assistant to work with him. Every week I keep getting a call whether we have a trained physician assistants in the OT or theater or echo lab or so many other things. Now things have evolved, and you should know your importance, and you should cultivate your training and further knowledge seeking so that you become a very important and pivotal role in the cogwheel of healthcare delivery. So with this, I'll finish my talk, and all the best to all the PAs and all the future students. Thank you.
கடந்து வந்த பாதையை கண்ணெதிரே காண்பித்ததற்கு நன்றி ஐயா. Thank you very much, sir. With a great privilege, we welcome Dr. Mullasari Ajit, Department of Cardiology, to the dais to give us a talk on the role of PA in the healthcare.
Good morning, my good friends. Most of what I expected myself to talk, Rajan has so beautifully put it in slide format. What I want to also say is when we started this program, there was one gentleman, Mr. C.V. Ramakrishnan. We should not forget him in this whole program. He, along with Dr. Charin and most of us like Rajan, Suresh and myself, we all got together to start this program, which has blossomed today. And I would say it is so good that today, I think the cutoffs is, I'm not sure, Deepa, but it was some 96% or something this year, which is very close to something who will get into medicine. So I really think we are the brightest people here who are doing this program. We get the best out of the people. And I was very happy to have met Dr. Ramakrishnan a few years ago at the hospital. He came and his 96th birthday was last year. People may not know C.V. Ramakrishnan. His claim to fame is not only that he was a biochemist from Vikram Sarabhai Center from Baroda, and he came here, but his son, Venkat Ramakrishnan, got the Nobel Prize for Chemistry in 2009. And you would not believe the simplicity of the man, because his wife, CVK's wife, Rajalakshmi, was admitted in our CCU when Venkat came here. He looked like a very simple man. And a few years later, he got the Nobel Prize in Chemistry. So he played a very important part in putting the program together and getting everything together, along with obviously Dr. Charin's push and all of us putting the program together. But I really think this is possibly the best medical paramedical program we have created. And I think as an institute, we should be very proud of the students we have created. And in one AHA, American Heart Association meeting, I was sitting there at the ward, went for basic science to one of our own PAs who had beaten all the doctors in that presentation and got the award. So really, I am amazed at the ability of our PAs. And I agree that they should be well rewarded in accrediting them as part of the health system. And every political attempt to get them on board should be done. So with these few words, I thank the PAs to have started this program and run the program in such a good way so as to be really a blessing for this organization. Have a good meeting today. Thank you very much.
Thank you, sir. A leader is one who knows the way, goes the way, and shows the way. As the saying goes, we welcome our Honorable Secretary, Mr. M.M. Philip, onto the dais, please, to share a few words. Thank you, sir.
Good afternoon, everyone. This is a difficult task for me to speak to you now because my speech was prepared with a lot of other dignitaries that I was supposed to honor. So I have to reword my speech. Anyway, it is a proud moment to see all of you sitting here to celebrate this event. I think I want to talk a little bit about our vision going forward. Madras Medical Mission, with its mission statement that says, reaching the unreached, walks this talk. We're proud to be part of so many beneficial schemes of the Tamil Nadu government. And, today, treatment in our hospital, I believe that you people have a very, very pivotal role to play in terms of interfacing with the patients. So it is, I do want to sort of correct something that Dr. Rajan just put in his last slide, saying that you're authorized to do a lot of things, which I want to correct. I'm not sure that that is right. I think we have not yet, the PA program is not fully recognized for you to do a lot of other things. In fact, that was one of the things that was told to me that in the NABH audit that there are certain, I mean, obviously as PAs, you are qualified to do it, but it's also the recognition that needs to be there, which will make your position a little more strong. In fact, I've also requested the minister to see that it's officially approved that there are a lot of things that the PAs can do, which assist the clinicians. Anyway, I wish you all the very best. And it is definitely a proud moment for Madras Medical Mission. Thank you.
Thank you, sir. In today's environment, hoarding knowledge ultimately erodes your power. If you know something very important, the way to get the power is by actually sharing it. We have our next speaker, Dr. Rajiva Lochana ma'am, consultant nephrology, to present us on the topic, role of physician associate in nephrology and kidney transplant. Over to you, ma'am.
Sorry to interrupt your talk, Rajiva. I just wanted to announce something. Our PA program is so good all over India that we have got All India awards. Mrs. Bharati has got the best OPD educator award, All India award. Where is Miss Bharati? She's not here. Okay. And Angel Jennifer. She's got the Emerging PA Award all over India. It's an All India award. Congratulations. Thank you. Sorry, Rajiv.
Thank you, sir. And a very good morning to one and all. I thank all of you who invited me to give this talk. And I'm really heartened to give this talk because PAs in our OPD play a very major role in running the department fairly smoothly. So how many of you are interested in nephrology? Can I have a show of hands? Okay, that's quite sad. But yeah, so this is how I was when I was in my MBBS. Had no knowledge much of nephrology actually. Then I did my MD medicine where I realized it incorporates so many things of medicine actually. No other department actually has so much of medicine also involved in a super specialized subject. So we had a talk during my MD from one of our senior nephrologists, Dr. K.S. Nayak, who had come to my institute and really inspired me to take up nephrology. So I'm hoping that many of you will start doing nephrology after this, okay? So basically, nephrology services provides the most critical of patients. These have cardiovascular disease, they have kidney disease, they have anemia, you name it, they have it, and they are one of the most complicated set of patients we deal with. So our workforce is always much lesser than our patient needs. So basically, if you can see that in the US, in the Canada, and all the Western countries in Europe, it's much more in India. Okay, so and nephrology as such is slightly under-recognized because so many patients do not even have symptoms. So when they do present to us, they are fairly at advanced stages of kidney disease. And most nephrology patients have an average of 5 comorbidities. So, and diabetes being the most common cause of kidney disease, all of them will also have hypertension. 50 to 70% of them also have cardiovascular disease, and so on and so forth. So, and they are on multiple medications, which needs to be seen at point and point again. So over the last 2 decades, the involvement of the nephrology PA in all aspects of nephrology has definitely increased. So the demand for nephrology PA is definitely on the rise. This is a paper which was published in one of the American journals, where it shows that nephrology practitioners, both in the dialysis areas, hospital areas, the hemodialysis, look at the graph, hemodialysis, hemodial PD, which is peritoneal dialysis, in nephrology related education, as well as office related work and research facilities, the PA is everywhere. So there are two people who are even more important than the doctor currently in nephrology. One is the physician associate, and the second comes the nurse practitioner. So nurse practitioner system is still to take off in a big way in India, but PAs are definitely a very important cog in the entire wheel. So the Western world has recognized the critical need for PAs and nurse practitioners and giving them more and more things to do in terms of nephrology related services. So when I trained for my fellowship in Canada, we had a guy called Mike. Mike was around 50 years old. And initially, I thought he was a nephrologist himself, but he was a nephrology PA and he was just superb. So he used to do so many things. He used to prescribe dialysis prescriptions, get everything ready for lines, even permanent catheters he used to assist. He used to work up patients for kidney transplants as well as counsel patients so well. He was more well known than the doctors there. And that is the level of importance they are given in the West. And I think that culture is slowly coming in India, and I think it should only improve. So from a patient education to managing patients on dialysis, you guys are a very versatile member of a medical team. So what I have put here is basically in the US, where 92% of them are mainly in dialysis centers, 70% treat CKD, 67% provide access management, and of course, help in the daily hemodialysis as well as daily ward rounds. So as I told you, it's a very critical subspecialty, extremely sick patients, and PAs are probably the ears, the nose, and the fingers of the nephrologist, making a very positive impact in patient care. And a great amount of time and skill is needed to take care of these patients. So these are the surveys done way back in 1999, where a lot of dialysis related things as well as examination is done by these patients, by the PAs. So what do we do in our nephrology OP? I think that should be the interesting aspect. So our PA, in concordance with us as well as our other doctors, that do the initial assessment as well as issue basic investigations after talking to us. The ultrasound as well as fundus examination is done by our PA. Nephrology related procedures, they assist pre and post kidney transplant assessment, and that has come a long way now. Research work, and the scope is just endless. So we provide access management, perform hospital rounds, assist in the diagnosis and management of all aspects of kidney disease, as well as ordering and following up lab and imaging studies under the nephrology guidance. So the first OP, the PA receives the patient feels much more comfortable rather than meeting the doctor directly. Detailed history and physical examination with the doctor, charting of medications, recognize any urgent indications for emergency transfer, and coordinating patient care with the doctor. And this is done on a daily basis in our OPD. So this is an example of the assessment chart that we have. So we have a very detailed history taking this one, and this basically goes in our database so that we have more amount of data to do research with. So every time this is a new assessment, look at it, we have a vaccination history, a surgical history. So at the end of it, when the PA has seen the patient with the doctor, he or she already knows what exactly has happened with this particular patient. So they can make a lot of difference by re-explaining patient prescriptions. Our patients have polypharmacy, so important. Keeping a tab on pending investigations, calling back patients for review, data and record maintenance, and vaccination schedules and reminders. So all our set of patients require a lot of vaccinations to prevent infections. Most of them are pre-transplant patients. So all of them require all this. So we have a review too, where we again sort of assess them quite well. And this again is the PAs play a very important role in this. The other important aspect is called as a focused ultrasound, which we do in our OP. Almost every patient gets an ultrasound. Every time there is some worsening of kidney function, we do an ultrasound. Every transplant patient gets an ultrasound. Though we are not allowed to issue reports, we do a focused examination. And to be fair, we have picked up things like tumors and things like that with our PA screening them with an ultrasound alone. So we do it in normal patients with kidney disease. We do transplant kidney screening. In peritoneal dialysis patients, we screen their tunnels and exit sites. We even screen the IJV as well as the subclavian, as well as the, for lines, as well as the retina screening is done. So this is actually done in our own OP where we put a few pictures. The far top left corner, we have a normal kidney, and we have a contracted kidney right in the middle. Then we have a kidney with hydronephrosis. There you see the bladder in the right corner. And then you have this with a lot of cysts, it's basically a polycystic kidney disease. All this picked up in an OP setting. This again is a transplant kidney. It's such a pleasure to see those colors on a transplant kidney. Shows that the blood flow to the kidney is amazing. And it basically aids us even in doing kidney biopsies. The picture we have put here basically shows that transplant kidney is generally kept on the right iliac fossa. So again, this is an ultrasound which we have done in our OP where we have scanned the tunnel of the PD to see whether there's any collections. This is so important, and the importance of ultrasound cannot be emphasized enough because it's such an important part of diagnosis in the present era. So this is our PAs doing retinal scans and ultrasound, and they assist in many procedures. We do kidney biopsies on a routine basis in the OP. Bone marrow biopsies, we do wound dressings, central line insertions, ascitic taps, IV lines, you name it, and the PAs have to be there to assist as well as help us. So pre and post kidney transplant, if you see, our patients are all chronic. They come many times to the OP, they may come many times to the dialysis. So they form a bond both with our technologists, with our nurses, as well as the PAs. And so it's so easy for you people to counsel them much better, of course, with a good understanding and aid from us. Detailed workup of the patient as advised by the transplant nephrologist, opinions from different specialties pre-transplant, conducting transplant meetings, which again is being done in our department on a regular basis, and providing follow-up care for kidney transplant patients, including scans. So we do an entire, so there are so many patients, we have to follow so many creatinines, we have to follow drug levels. So all that is being silently done by our OP people so efficiently that it runs well. So there is a lot of scope in research. There's data collection and entry, statistical analysis, if any of you are interested, collecting relevant articles and flagging relevant information, helping in manuscript preparation as well as manuscript submission. So this is our own center where we have our PA in our papers where she has helped us collect data. She has helped us write this one, and she has actually valuable inputs to give as time progresses. The scope is a lot. I think the future for PAs in nephrology is extremely good, as it is in a cardiac or a cardiac surgery site. The patients are extremely complicated and very, very interesting. So I think this is something all of you should explore for the people who are yet to finish. So we have a lot of recruitment areas in GH, in private hospitals, in research centers, as well as universities. You can always go in a more research-oriented direction, or you can go in a more clinical-oriented direction. Actually, the world is your oyster here. So basically, this is the patient education decreases wait times. You can assist in procedures and surgeries, patient assessments along with a doctor, ordering tests again along with a doctor. You can actually diagnose things, and that basically is a skill which even doctors get only over time. It's not like overnight you get up and you diagnose something. It's only with experience and time that comes. And of course, right now you cannot prescribe, but it is allowed in Canada and the US. Some amount of drugs they are allowed to prescribe. I think slowly times are changing, and you will also be kind of involved more in the prescribing part of things. A very special thanks to my PA. Hopefully she is in the audience for helping me in putting this PPT together, and all our team members in the nephrology, OP and dialysis who help us in running things smoothly throughout the year. And right in the middle is our team. And I would like to request you to give them a big hand. So coming back to my original question, have I changed anybody else's mind in joining nephrology as a PA? Okay, good. Okay, thank you so much.
Thank you, ma'am, for the informative session. A cup of tea is a cup of peace. It's a tea time, and kindly make use of it at the side of the hall. Since it's a hospital sector, kindly maintain the decorum. I request all the PA students to get back to the auditorium after the tea time for the innovative talks to be conducted ahead. Rest of the students can resume your work. Thank you.
LHS guys, girls, எல்லாம் listen பண்ணுங்க. On the occasion of PA day, except PAs, CT, CPPT, DT உங்க எல்லாருக்கும் தீபா மேம் லீவ் கொடுத்திருக்காங்க. So no clinicals today.
You all can have your tea and snacks and you can leave the auditorium. You can go back to your home. Okay, except PA, first year, second year and third year. Please have your tea and please go back to your homes. We don't have any theory and clinical training today. Please inform others also, those who are outside.
All the students are requested to occupy the front seats. I request all the students to get back to the front seats. Please occupy the front seats. I kindly request all the students to occupy the front seats. I request all the students to be seated. I request all the students to be seated. I now call upon Dr. Suresh Kumar to present a talk on ABC of infectious disease.
Good afternoon. So this specialty of infectious disease, see a lot of bugs, a lot of animals also there. For example, chicken pox, bird flu, swine flu, COVID, monkeypox. So all animals we are dealing with it. People are wondering whether I'm a veterinary doctor or a physician. I'm not a veterinary doctor. I'm a physician, infectious disease doc. We send a lot of cultures and we react to the cultures in a sensitive manner. So we are all cultured persons we can call. That's why infectious diseases. Pertaining to this talk, I don't have any disclosures. I don't have any conflict or anything for pertaining to this talk. Straight away, I begin with a case here. This is a case I'm getting daily from my residents there. 56-year-old male, diabetic, complaining of chest pain. So the cardiologist making a diagnosis of myocardial infarctions. Now planning for coronary angiogram. We want to plan coronary angiogram. Patient is not having any fever. Basically, he came for chest pain and planning for coronary angiogram to check which vessel or the blood vessels is blocked. On examination, the patient is normal. Urine culture sent that grew 5 hours time. Gram-negative bacilli and gram-positive cocci, GNB and GPC means gram-negative bacilli. Bacteria we divide into 2 types, gram-negatives and positives. Started with an antibiotic called piperacillin tazobactam. The cardiac nurse calling you, the coronary cardiac nurse is calling my PA, IDPA. Can we shift the patient to the cath lab? Find out the errors. I think some quiz program is there today evening, no? Those who answer properly, you can get straight away wildcard entry. Find out the errors. Who's finding the maximum errors can give the quiz wildcard entry. But stand and tell. Not sit and tell. You should stand one person and tell. Can you tell some errors? None of them. Post-prandial state or pre-prandial, lunch is served. What do you think? What is the error here? No error. Everything went well. Okay, I'll give some choices. Planning coronary angiogram is an error here. Doing 5 hours urine culture is an error. Starting piperacillin tazobactam is an error. Calling the PA is an error. Asking this question to you people is an error. For me, I think the last question is correcting there. Because none of them are opening a mouth. So the last question is an error for me there. So what is the error now? Second one, sending 5 hours urine cultures. Starting antibiotic is not an error. Patient is not having fever. So patient is not having fever, but starting antibiotic. Patient is not having any urinary symptoms, sending culture. So almost all are error, except the angiogram, all are error. So in infectious disease, it's a war. Infectious disease is a war between you and your bacteria. Most of the time, we underestimate our enemy, bacteria. We think our enemy is nothing. This is very small, microscopic. People know what is the impact of microscopic thing. If you got microscopic, this bacteria in a hospitalized patients in ICU, enters the blood, that's called sepsis or septicemia, that kills you. So you are underestimating your enemy so far. So how the war is conducted, this is what we need to do. We need to know 3 things in the war. I need to know my enemy, that's called bacteria, bug. I need to know the weapon. The weapon is antibiotic, that is called A. antibiotic. B stands for bug, bacteria. And C stands for the environment or the host where the problem is happening. That's a culture we can call where it is happening. If you know the three things well, you can win the you can win the battle most of the time. If you know only one or two, sometimes fluke, you can win, but you fail. Sometimes one win, one fail can happen. If you doesn't know anything, invariably will fail. But these things, unfortunately, it is impossible for doctors to keep up. So the doctors is not going to keep up. Who is going to keep up? Physician assistants. The doctors doesn't know what to do. So you can learn and you can teach your doctors what to do there. That's what the doctors, this is an art of war. So that's what I'm going to teach you, how to fight the war with the enemy. The enemy is your bacteria, how to fight. So who is physician assistant? Medically trained to save the life of the person is called physician assistant there. So you are medically trained to save the life, but for you need to know three things, A, B, C. A stands for antibiotic, B stands for your bacteria, C stands for the culture. The culture is very important. Which host or which environment, we need to think about it. This is called the cultures. These things are not available in Google. If you find the Google will not tell the answer. So don't expect the answer in Google. We need to come, attend, you need a round, then only you can learn what is ID basics for you there. So the first thing, when you encounter a patient, not only in infectious disease, encounter any patient, the first rule, we need to know whether the patient is stable or patient is unstable. How to know whether patient is stable or unstable? When the patient is not able to stand, not able to walk, not able to give history, the patient is not stable. When the patient is not stable, don't try to ask so many things and don't try to examinations. What we need to do, stabilize the patient first. The rule is stabilizations. When a patient is sick, we need to stabilize. This is a mantra. When a patient has got heart attack, we need to massage. When the patient has got cardiac arrest, we need to resuscitate and we need to revive the patient. Similarly, when the patient is not stable, we need to stabilize the patient first. So how to find patient is not walking, patient is not talking, patient is not giving history. Second thing is called altered mental status. If you ask any question, the patient will not tell the appropriate answer. See the breathing pattern. When the patient is breathing fast, the patient is breathing fast, not able to complete a sentence. If you ask the patient to 2 sentences, 3 sentences, simply you can do it. If you ask the person to speak, he's not able to complete the sentences. Third thing is called circulations, systolic BP. If you just put your hand on the pulse, see the pulse volume, we can able to say whether the patient is stable or not. So this is called one scoring system called quick SOFA. SOFA means sequential organ failure assessment, whether the organs is failure or not. So what organ I'm assessing? Brain I'm assessing with mental status. Heart I'm assessing the BP. Lung I'm assessing the respiratory rate. So this we can do within 30 seconds to assess whether the patient is stable or not. So this is a first dictum. Whenever you encounter a patient, whether cardiac, neuro, gastro, vascular, uro, wherever you encounter a patient, we need to decide whether the patient is stable or not. So this is our algorithm. When a patient comes to you, assess whether the patient is sick, whether the patient is stable. That's most important thing. I'll give a history next patient, 23-year-old female, engineering college student, no comorbid. She's not having any sugar, BP, heart problem, kidney problem, nothing. Fever for 1 year durations. No other symptoms. No weight loss. On examination, she is looking comfortable to me. What will you do? This patient is a stable patient. What will you do now? Always when you give the choice only, the answer happen. Start paracetamol. How many lift your hands? All pre-prandial. How many awake I need to see? Send cultures because we are highly cultured people. Okay. Start antibiotics. Nobody. 1 year fever. Couple of hands. Okay. Lift 2 hands. Check COVID flu. This is a year of COVID. Unless COVID is ruled out, call. How many want to call? Nobody. Very good. So you want to solve 1 year fever on your own when you're looking stable patients. The dictum is when the patient say a lot of things, patient will say a lot of things, but whether we need to know whether the patient is really having fever or not. 1 year fever, no other symptoms, no weight loss, looking stable to me. I'm not able to identify anything on my examinations. Does the fever real? Why you want to send cultures? Why you want to start antibiotic? Why you want to do COVID? So unnecessary things we don't want to do. We don't want to do any unnecessary thing. So when the patient is a stable patient, you are not able to identify something wrong in the patients, you need to elicit whether the patient is really having fever. Monitor the temperature. Don't shoot the gun. Measure the temperature. Gun shooting is useless. Measure the temperatures. Ask him to record the temperatures, right, in the paper. They will say 98.4 is my temperature. So fever means 100 degree. Most of the people, they do not know. But some people, for example, elderly, the patient is very elderly, they don't have fever. Don't think infection means fever will be there. Sometimes without fever also infection will present. For example, people above the age of 80, 90, children, young people taking paracetamol, fever won't be there. So we need to find out whether the patient is really having fever or the patient is not having fever. So this is number 2. First thing, the patient should have stability. Number 2, whether the patient should have real fever, not false fever. This is a third case here. 24-year-old male, marketing guy is going around Chennai. Fever of 8 days durations. This is a real fever. Constipated because the other symptoms also. Headache is present, mild constipations. Cough, dry cough is present, no comorbid. He does not have sugar, BP, heart problem. On examination, his vital parameters. The 3Q SOFA score is normal. Whatever points I'm telling, I'm applying it. Whatever you learn, you need to apply. That's more important. So conscious oriented. For examination, spleen is alone is palpable. So what are you going to do for this man? CNS examinations you did, there's no neck stiffness. So I given choices. Now start antibiotics. Now this patient is a stable patient. My second case was not having fever. He's mimicking the fever. But here the patient has got real fever. Right now, what will you do? Start antibiotics. Investigate. Check temperature. Already temperature check is more than 100 degrees. All of the above. Start antibiotic, investigate, check the temperatures, or refer to ID department. Now, how many want to refer? Nobody still. Good. Fine. So, how to solve the problem of fever? Solving the problem requires proper history taking. It doesn't require any major investigations like echo, angio, nothing. For me, I need to listen to the patients. I need to listen to the patient's history. What you did. This person, I given a lot of clues. Any clues you got it? So what is the diagnosis, likely diagnosis here? What is the likely diagnosis? I know the diagnosis here. I don't want any test, any investigations. I know what this patient is suffering. I do not know how to fortune telling, I do not know, but I know what is going on in this patients. I give this history only there. What is the reason? So the patient is a young boy, young male, 25 years old male. He's a marketing. Marketing means he goes to different places. He's eating different foods. Pani puri is a favorite food. He got fever, constipation. So constipation means something going wrong in the bowel. So it's a mild headache, body pain, anything can happen. So the patient is a young boy, young adult with no comorbid conditions, fever of 8 days durations, along with some constipation, new onset, eating outside food. What is the diagnosis? Typhoid. There's no need for Vidal, no need for blood cultures. What I did, I just listened to the patients, examined the patients, I did correlated a thing. That's what I did. So we don't want any special investigations to find out. Most of the viral fever, for example, can it be dengue, that can it be COVID, can it be H1N1? No. Why? The fever subsided within 5 to 7 days. When the fever crosses more than 7 days, it is not virus. So this is not COVID, this is not H1N1, this is not dengue. So we need to know certain thumb rules along with the proper clinical history. Listen to the patients. So what is eating? What I need to ask, what you are eating, where you are eating, where you travel, any sick contact. For example, virus infections, somebody in the family has got cough and cold, any sick contact in the family. And we need to know sharp onset of fever. When a patient has got sharp onset of fever, yesterday 3 p.m. I developed fever, that is viral. Typhoid, malaria, they won't say, doctor, I got fever for 5 days, 7 days. What is the time? They don't tell. Yesterday 3 p.m. means sharp onset virus. So this is how we need to listen to the patients. Whether you're swimming in the water, walk in the flood water, you got bushy areas. So this history is very important. What sort of host, whether the patient is coming from the home or patient developing fever in the hospital. With fever, you come to the hospital or develop fever in the hospital. After coming to the hospital, you develop fever means I need to say the venous site, venous access, venflon, urinary catheter, surgeries, line, I need to check. Suppose the patient's coming from the community means either malaria, dengue, typhoid, viral fever. whether the patient is taking steroids or not. Comorbid, sugar patient, diabetic patients, heart problem, kidney problem. Sometimes it pass the thing there. Vaccinated for COVID, unvaccinated, taken flu vaccine, not vaccine. Recent hospitalizations, recent antibiotic exposures, where he travel, what sort of activity he is doing, occupation, what sort of farmer, standing in the water, chances of getting leptospirosis, rat fever, bushy area, scrub typhus possible, food, home food or outside food, how often eat, once in a while, chances of typhoid less, weekly 3 times pani puri, typhoid is more on the card. Cooked, uncooked food, animal, pet exposure, what are the animals exposed, allergy, what allergy are having it, sick contact, in the family anybody, in the workplace anybody has got fever. So this is called history taking. So to figure out the problem, we don't want echo, we don't want angio. I need just listen to the patients. If you listen to the patients, you can make the diagnosis in infectious disease. There is no need for any specialized doctor to come and solve the problem. Only thing we need to listen. But people won't listen. This is what people talking and listening there. So you invert the telephone. This phone you are not seeing there. People are using mobile. Unfortunately, I don't have good mobile phone to show, but this is how people are talking in the telephone. So the difference between a good and indifferent physician is how much time you spent on taking the history. If you tend to spend a good time on history, you solve the problem. You solve the problem. So second thing is examinations. We need to examine the patients. Unfortunately, the culture of examining the patient is not present among the doctors itself. That's a problem. So they're not examining the patients. We need to examine the patients from head to toe. That's it. If you do the proper head to toe examinations, you can figure most of the problem. I'll show a couple of signs. Those who want to really win the quiz competitions, you can answer this one. What is this one? Except IDPS, others can answer. What is this? Black necrotic thing that is called eschar. This is people who go to the bushy area. Usually it is happening below the breast, armpit, in the genital area. If you strip the patients, examine the patients complaining fever, headache, going for 10 to 12 days, is from the rural part of Tamil Nadu, lot of bushy areas. The typhus, the diagnosis is called scrub typhus. I need to strip the patients, examine the patients. If I find this one, no need for blood cultures, no need for anything, simply one antibiotic called doxycycline. The patients, doxycycline costs around 5 rupees a day. So this is called examinations. What is this one? Patient has got sharp onset of fever. 3 days back, he's got fever, severe body pain, headache, pain behind the eyes. What is this one? What you are seeing? Redness in the eye. It's called conjunctival congestion. That is due to dengue. Just examine the patients. Just push your hand, eyebrow, push down the eyebrow, push down the lower eyelid. We make the diagnosis of dengue. So I don't have a pointer here, but below the right side of the neck, some swelling are able to appreciate. Patient has got fever, weight loss, this swelling. What is the diagnosis? TB, lymphadenitis. The patient has got lymph gland enlargement. This is called TB. What is this one? I think a couple of PharmD students are sitting here. They know what is going on. We need to ask what medicine is taking. Patient has got a black tongue. What is this? What antibiotic? This is because of after taking antibiotic, the color of the tongue has changed. That's called linezolid. So put your tongue out. What is this one? Candidiasis. What do you think when the patient is a young male, oral candidiasis? He's not a diabetic. He's not taking any steroids. What disease you suspect? HIV. We got a lot of HIV patients here. Just putting the tongue out, we can make a diagnosis of it. What is this one? Skin and bone. Muscles wasted. Young 25, 30-year-old. What is the thing? TB. The disease make you like a weak, thin. This is called TB. Advanced HIV, the patient has got wasting syndrome, we call. What is this one? All small vesicles we can call. Muttu appeals. One area it is there. What is this? Herpes zoster, Aki. Viral infections. So we need to know, just examining. I don't do anything there. Just examining the patients, you can make it. Lot of black itchy lesions. Keep on scratching the feet. This is called papular pruritic eruptions. Patient has got HIV. These presentations can happen. So this is what we need to know what we are doing with it. So if you do proper examination, What is this one? Rash. But in between normal skin. Rash is there, normal skin is there. That's called area of island. Dengue, just put your fingers, leave it, it blanches. Dengue. So if you do a proper examination, these things require no any echoes or angios or nothing. Only thing you need to examine the patients. Be watchful. A, ask the patient. B stands for watching the patients. Observe the patients. But most of the time we don't observe. So in sick patients, what I need to observe? What line is going on? Where is the monitor? What is the BP? What is the output? I need to check where is the patients. I need to check the monitor. What is the FiO2? What is a PEEP? What is a mean arterial pressure? So this is what I need to do in a sick patients. This is called the Glasgow Coma scale. Whether the patient is opening the eyes spontaneously, whether he's obeying my simple command, whether he's obeying my commands, whether he's speaking or not. I know what is the conscious level. So this is what we need to do in a ICU patients. We need to observe what line is getting, what is Foley is getting. So observation is the power. I don't want any major investigations in my ring. So we need to know symptoms and signs. For example, fever. The sign is febrile, pain, tenderness, swelling, edema, redness, erythema, shortness of breath, tachypnea, palpitations, either tachy or brady. So collect the symptoms from the patients, try to see for the signs, put together symptoms and signs, make a diagnosis. Fever, headache, seizures, loss of consciousness, weakness. What is pointing? Something wrong in the brain. What causes brain? Infections in the brain is called encephalitis or meningitis or meningoencephalitis we can call. Patient has got fever, running nose, sore throat, upper respiratory tract infections or pharyngitis. Fever, ear pain, ear discharge, otitis media. Fever, cough, shortness of breath, tachypneic, patient is breathing fast, pneumonia. Fever, abdominal pain, abdominal distension, something wrong in the abdomen, intra-abdominal infections. Fever, diarrhea, dysentery, gastroenteritis. So this is called syndrome. Combining the symptoms plus signs, that is called syndrome. Once you write the syndrome, we need to know, for example, if the patient has got upper respiratory tract problem, fever, cough, running nose. What causes upper respiratory tract infections? Virus. Don't write antibiotics. Fever, loose stools. Most of the time without blood and mucus, there is no fever, gastroenteritis, virus. So it avoid antibiotics. We don't write antibiotics. That is more important. So we need to know what test. For example, if you want to find out any infections in the ball, we need to send 4 bottles. That is called 2 sets of cultures. Similarly, malaria means we need to do a smear. We can't make a clinical diagnosis. We need to demonstrate the malaria. Dengue, typhoid, I can make suspect, but to prove the diagnosis, I need to send appropriate sample. So what is appropriate sample? To make a diagnosis of infections in the blood, 4 bottles. 4 bottles, each bottle should contain 7 ml to 10 ml. And this is your bug. So the bug stands for gram positive, gram negative. In the gram positive, we need to know whether it's a bacilli or cocci. Similarly, gram negative, bacilli or cocci. So usually we need to know the bacteria name, because gram positive, the antibiotic is different. Gram negative, the antibiotic is different. But for example, if the patient has got urinary tract infections, what syndrome? Fever, dysuria, burning sensations, urgency. What causes UTI? Gram negative. Fever, cough, shortness of breath, pneumonia. What causes pneumonia? Gram positive. So my antibiotic, this is called the microbiology. We need to know brain infections, what causes? Gastroenteritis, what causes? It is easy, but we need to know whether the infection is happening above the diaphragm or below the diaphragm. Above the diaphragm means meningitis, pneumonia, endocarditis, gram positive. Below the diaphragm, gram negative. So the antibiotic choice depends upon positive or negative. So antibiotic depends upon ask proper history, be watchful, examine the patients. See, we need to think about comorbid and risk factors. This is called antibiotic classifications, studied in pharmacology. Cell wall acting agents, acting intracellularly. What are all the classes of antibiotics? But we need to know whether the bacteria covers the antibiotic. The antibiotic covers the bacteria or not. So we need to know little bit of antibiotics. So no major test, no major investigations. If a patient comes to us, ask proper history, do examinations. If you know a little bit of your bacteria, a little bit of your antibiotic, you solve the problem. The patients go back vertically. Final thing is, we need to know your preparation. Who is this person? Same or different person? Same or different? Same. Correct? So this is delivery conducted by nurses and delivery conducted by doctors. So this arm, the red one is delivery conducted by doctors. The below one is delivery conducted by nurses or physician assistants you keep. So when the doctors conduct delivery, the mothers are dying. When the nurses or some other person is conducting delivery, the mothers are going back home. Why? The doctors are incompetent. So this man find out the doctors go to the mortuary room, come back without washing the hands, conducting the delivery. So this man find out, ask the doctor, stand in front of the thing, keep a stick with the person like this one, the blue lady. That person needed. If you do not do hand rub, they will kick. So what happened? After implementing this one, the number of deaths happening in the doctors come down to 99% reductions. So what he did? Just ask you to wash your hands. If you wash your hands, 99% of death is averted. Simple washing the hands, saving the life. 99% of the time it saves the lives. But unfortunately, we are not doing it because we don't have this lady. That's a problem. We need to give it 2 kicks. So he changed the behavior before this intervention, after interventions. Keep on asking the people, wash, 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 wash. People say this is a psycho, he needs to go to the mental asylum. He died in mental asylum there. People send him to the mental asylum because he's keep on asking the people to wash, wash, wash. Who is this? So changing the behavior is most difficult thing there. Changing the behavior is most difficult thing. The look will go away there, definitely there. So those who want to join ID department, think about your looks there. So what's the error here? So 2 things. One is an hand hygiene. Second thing, we need to know proper protective equipments. So the nurse is wearing a mask and the patient is also wearing. A patient is a TB patient. So for a TB patient, what mask you supposed to wear? N95. If you put this N95 mask to the patient, he's already breathing fast. Put this mask, you will intubate the patients. So you'll put in ICU. So we need to know what PPE I need to use it. That's most important. So the C stands for you need to know the culture of protection yourself. Unless you protect yourself when you encounter the patients, making a diagnosis, solving the problem is more important. You need to know how to protect yourself. So if you want to protect yourself, you need to learn ID, infectious diseases. Then only you can learn it. So ABC stands for ask proper history. Be watchful, examine the patient. Be watchful, examine the patients. Strip the patients, examine the patients thoroughly. Listen, your history is here, but you are looking at something else there. You want to see the CBC, cultures, everything. Patient himself giving the history. So that's the history there. And we need to wear appropriate protective cover. If you want to protect yourselves, appropriate cover is required. So this is what we need to do. Huge gap. Infectious disease specialist not available everywhere. But infectious disease physician's assistant can be created there. So you can solve the taking history, examining the patients. You don't want echo. You don't want to do anything there. If you listen properly, you become a physician there. So you can learn, you can solve the problem. You need to know about antibiotics. You need to know about bacteria. If you do, you can do a lot of tele-IDs also coming up. We can do the thing because ID physicians are not available everywhere. In Chennai right now, 10 physicians are available for a city. But if you see the cardiologists, hundreds of cardiologists, you can find out. So that's what the scope is there for you people. I don't think so. Other specialists are sitting here. So any questions? Happy to answer. Thanks for the wonderful opportunity. If you want to grade to best, we can do it there. Thank you for the wonderful opportunity.
Thank you so much, sir, for such an impressive session. If there is any questions, we can ask.
When will be the lunch served? Any questions?
Excuse me, sir.
Yes, sorry.
Sudha, physician assistant, sir. So this is about, my babies are actually, how to treat infection in babies. Like how long you can wait for the fever to subside, when to take her to the doctor or what else?
I supposed to show on WhatsApp video circulating on the actor Jairam. Everybody knows that it's circulating virally there. So the person who takes the patient to the actor saying that I given paracetamol, I given amoxicillin, clavulanic acid, I given Zysol, everything I given there. So he says he give the chocolate and send the child home there. So nothing, already you finished everything. So I don't want to do anything. Most of the time, the fever will settle by 5 to 7 days. When the child is active, playful, eating, sit tight. Just give paracetamol, hydrate the child, give the food. No need for any antibiotic. Most of the time, school-going children, One child has got fever means it's viral fever, sick contact. So they will get it there up to 5 to 7 days, provided the child is eating, taking food, playful, active. Just keep monitoring it. No investigations, nothing required. But frequently they're going to get school-going children, they're going to get 6 to 8 episodes, sometimes 12 episodes also possible. So don't treat.
But how about the running nose?
Running nose is a sign of viral fever.
There for 1 month. Like for
Yes. Their immune system is not good. So they can have cough, they can have running nose, they can't sneeze, but active, playful. You give your mobile phone, the child starts playing, the child is doing well.
So how you take this immunization things, the vaccination?
Yeah.
Like, for like our older generation, they don't, they have not vaccinated as we do for our kids. How do you see that?
No, that time vaccines also not available. For example, chickenpox vaccinations, when I was a child, it is not available. But right now, chickenpox is available. Similarly, the cost of hepatitis B vaccine, when I was a child, it was very huge cost. But now the cost of hepatitis B vaccine is cheaper. So the proposal, two things, availability is not there, cost is very high, that's why they're not vaccinated. But now availability is there and new vaccines come. For example, pneumonia vaccines came into the market from 2000 onwards. So as a child, I don't expose to pneumonia vaccine. Right now, vaccines are available. Following, thanks to the COVID, a lot of vaccines is going to come, a lot of vaccines in pipeline. So vaccine is a way forward, not only the mask, vaccine is a way forward. We need to take vaccines as much as possible because it gives at least 80% protection, not 100% protections. Thank you. Any other questions? Nothing. Thank you.
Thank you very much, sir. Now I would like to call upon Dr. Supraja to present a talk on approach to examination of patients.
So good morning, I'm Dr. Supraja, pulmonologist. So I'm standing between you and the food, and as far as the information came in, the hall was full in the morning and is now thinning down. So I'll keep it short. Two things when I came to M. Okay. The concept of physician assistants, completely new to me. I was a little wary. I was like, what course is this? What are these people doing? But over the years, what I have realized is it's an excellent course. Whoever has taken it, kudos to you. A lot of things, because you get to interact with patients, you get to start diagnosing patients, treatment to a certain extent, which is a very big thing. Okay, and today, from 2016, I've been having physician assistants in my department. And without them, Bhuna came here for the course today here, and it's already, handbroken in the department. So we depend on physician assistants in a very big way. Okay. But why did I choose this topic? Because I'm not here to do a PR exercise as to you come to my department. No. Pulmonology is, see, every specialty is vibrant. You can choose whether you want to go into, like any MBBS student, into medical or surgical, you can choose. But wherever you go, the first thing is when you see a patient, I do not know how much of you are trained in assessing a patient or while approaching a patient. So when I came here in 2013, the first thing that they did was I was sharing the same room with the physician assistant, which I protested a lot because one, there is no privacy to the patient. So you should understand, how do you want to be treated when you go to the hospital? You go, I don't know how many of you have gone to GH? Raise your hands. Yeah, a lot of people. So how is the room there? Is it a comfortable single room with only one patient doctor? No. So I have studied in GH. I know how it is. It's like a 150 people line queue and you're the only doctor. You just want to finish it. So even before they come, we will write the prescriptions and keep. And absolute no privacy to the patient. Okay, we wouldn't even half a time hear. Like what Dr. Suresh said, you should hear. Probably the patient is right there in front of you telling you the history and the diagnosis and everything. You just have to hear. So one thing which I didn't like in terms of OP here setup initially was sharing rooms, taking history side by side, never agree to it. Would you want to be treated that way? No. And second thing is why I'm even saying this in this forum, because I take it this platform as the area where I can tell you this message. Cardiology, patient comes in at 7 a.m. And then the cardiologist refers the same patient to me at 5 p.m. saying that this is absolutely not cardiac and this is only a respiratory issue for which the patient has come. Now, how could this have been avoided? History taking. If you had listened to the patient, identified it, asked the appropriate investigation. Why again and again we are concentrating on history is only if you know what you're dealing with, you're going to ask the appropriate investigation. So each specialty, cardiology, IKOT, the kidney, nephrology, urology, everybody, you are all becoming super specialist PAs. It is not how things will work. You should have a basic knowledge, and then apart from that, the specialty, niche things will come in. Okay, so coming to history taking, as I said, the patient is right in front of you, giving you the history and the diagnosis. Just open your eyes, and this holds good from 1849 to till date. Today, a patient came just now. A patient came to me. X-ray was glaring with a big cavity and a big mass. Maybe I should have put it here. Went through cardiology, and then it was referred to me. Kindly avoid all these things, because the patient, at the end of the day, would you like it? Go to one specialty and then realize, okay, this was not his specialty, because patient will not know, because this patient came in with a left-sided chest pain. It is our duty to identify what the patient has, and his other symptom was cough. So cough, what is the most common investigation that you do? Cough of more than 2 weeks? Chest X-ray, simple chest X-ray. Please learn how to read it and refer the patient. And most important, all of you are kids, okay? According to us, you're all kids. By 22, you finish your physician assistant course, right? And then you all come into the hospital setting. So if you want people to really admire you or look up to you, you're all being treated as junior doctors, right? How many of you are being called doctors? Almost everybody is being called as doctors. So the point is how you present yourself. That's first thing. And rest, the knowledge and the confidence, because by dressing up, half the confidence comes in. The knowledge gives you the rest of the confidence. Okay. And preferably avoid these tattered jeans and other things, which is not appropriate for the occasion. All of you look good in it. That's a different story, but no, this is not the area. Okay. And most important, again, when I used to sit in the T block OPD, if I had by mistake sat in a workup room, what happens? Open the door, come in, ask for a bag, ask for this, ask for that. The patient needs the privacy. Okay. Because sometimes they'll be crying. Sometimes they'll be opening up. We are nobody to keep doing that. Even sometimes we do that. We go into anybody else's consultation. We just open the door and then start talking. Ideally, it's not supposed to be done. Okay. And introduce yourself, tell them what they have come in for, and then listen to them. Like Sir said, full attention to the patient. One phone call here, writing notes here, and then talking to somebody. Don't do that. And other thing, how many of you use a couch? The patient couch, is it there in your OP rooms? Couch use pandringla? At least in the system we use couch. Most importantly, Anirudh, Brito, tell me which system? Gastro. Okay, at least for an abdominal examination. Okay, vairu valikidunu sonna, at least touch them. They need to be felt. You need to understand. Touch is half the solving the symptoms. Okay. And cardiology, how many of you are doing the manual palpation? Pulse feel pandrathu? Wonderful, wonderful. Very good. Okay. Very important. The patient needs to be felt. And how many of you carry your steth along? Especially in medicine. Whether you use it or not is a different story. Carrying it along. Okay. Kadalavai. Simple things, because you will pick up so many information from that simple thing. And do you tell your patient what they are suffering from? Do you talk to them? Yes, very good. I think all the senior PAs are all very good, because the ones which I had are also like, in fact, half the information would have been conveyed by the time they come to me, half the information is conveyed. So you take a detailed history, you write it down, each system, see, there is a uniform history taking for all, and then the specialty history will start in. Okay, at the end of it, tell the patient probably, sir, I think this is what you're having. And this is the thing that we would like to get to do. I know the OP is very busy, extremely busy in all specialties, but please talk to the patient. In fact, now the PA notes are excellent in the cardiology OPD. You know, it's fully detailed, everything. In fact, we sometimes, okay, note it down from that. So the detailed history is very good. Please make a note of it. And please ask the patient to talk, not the attenders. Half the time attenders will jump in. They can get to talk, but ask the patient to talk first. And ensure that all these are all general history taking. This is not considered to only one specialty. Somebody was asking about immunization. How many of you have elders at home? Elders is above 65. Have you vaccinated all of them? The COVID vaccinations, the pneumonia and the flu. Okay. How many of you are aware of it? Adult immunizations. How many of you are aware of it? In the side, adult vaccinations are pneumonia, like what the ID specialist was talking. We have pneumonia and flu. Okay. So you need to know that above 65, all patients have to be vaccinated. Below 65, with any comorbidity, they have to be vaccinated. அது நம்ம கேட்டாதான் அப்போ வந்து தெரியும். அப்போ நம்ம எஜுகேட் பண்ணணும் பேஷண்ட்க்கு. சார் வேக்சினேஷன் பண்ணிட்டீங்களா? பண்ணலனா சார் these are the 2 vaccinations available. Please get it done. Whichever specialty, any pneumonia, any flu, any viral, we are just getting flooded in the hospital with viral infections. They'll go into heart failure. They'll go into rhythm abnormality. They'll go into cardiac arrest. So any infection can precipitate a major organ failure. So complaints, of course, in the chronological order. Do you know the order? What is any symptom? What is the mnemonic that we use? Socrates, site, onset. What is the aggravating, relieving factor? Radiation. Okay. And what is the severity of your symptoms? So all that you have to ask so that you identify it. And the chronology. Chronology is, which one is first? Longest is first and the shortest is at the end. And medical history. All medical history, please try to find it out and document it. Cardiac, respiratory, neuro, everything, please document it. Only if you do that, the medications will be appropriate. Because drug-drug interaction is there. And number medications already, only if you write, so my PA is here. So how many medicines does any patient in this hospital have? You tell me. Random number. Anything above? They'll have around 8 to 10 medications, right? So you sit down, don't start. So the point is, on top of it, we are going to write again medication. So unless you have the whole list, you're not going to know how many medications a patient is taking, and sometimes you'll be writing the same prescription. See, and as you all grow, as I have become dependent on my PA, your doctors are going to become dependent on you. Okay. And you have to understand, patients will start calling you directly for simple ailments. They'll start calling you medications. So always ask them to send the current prescription and then discuss and then write the medications. Okay. It's very easy to write a paracetamol. It's very easy to write a lot of things. Over the counter, nariya kadaikum, but nariya drug interaction, they'll get complications. And smoking. How many of you have smoking history? Alcohol. Very important. Okay. Why? Every organ will get affected in smoking. Okay. And alcohol. Fine. And previous investigations. This is very sad to say because our own doctors, okay, not that we are all gods. Investigation done on particular date. 2 days later, patient gets admitted. And the whole set of investigation was repeated to the patient. The cost of this investigation was 8,000 rupees. You and me will be spend again 8,000 rupees. Okay, but unfortunately, the profession is considered like, in a very big way. They didn't question at all, but it's very sad. So please go through the previous investigations. If it's already done, don't keep repeating it again and again. And the most important part, physical examination. How many of you do it? Huh? Pandringla, pannanu. Pannada, the examination is complete. Simple to start with. paler, icterus. This is pickle. Pickle we call it. எல்லாத்தையுமே பார்க்கணும். தலையில இருந்து கால் வரைக்கும் எல்லாத்தையும் பார்க்கணும். அப்பதான் வந்து you will know whether there is an anemia, whether there's a cyanosis, and கையில ஏதாவது இருக்கா, edema இருக்கா, lymphadenopathy. How many of you see? You'll easily pick up everything. Everything, and abdomen examination, and your legs and everything you have to examine. And patient while they walking in, if they are coming in a wheelchair, please make them walk into the room. Wheelchair ode உள்ளார ஷிஃப்ட் பண்ணாதீங்க. அப்பதான் நடக்கறாங்களா, என்ன நடக்குதுங்கிறது தெரியும். So this is all specialty. Inspection, palpation, percussion, auscultation is for all specialty. I'm not going into the details. I don't want to bore you. But the point is you need to be observant. Stripping the patient is very important. Remove. Only then you will see scars. Only then you will see sinuses. I don't know how many of you had, I don't want to take the name of the patient, a recent patient who had come in, elderly with so many comorbidities, complications. All of us were hunting where the site of infection was, but it was a simple procedural device and the suture associated infection. Okay. Unless if somebody had opened the dressing, they would have noticed that there was a sinus which was there and the pus was coming out. So then it's simple, no? Munnade sort out பண்ணிரலாம். எல்லாருமே we could have sorted out why this happened, and that. And when you do any interventions, இவங்க நீங்கெல்லாம் எந்த surgical side ஆ, medical side ஆ? First year PAs. Okay, that's why you're all so quiet. Okay. So why did you take physician assistant course? Why? I'm very curious. Tell me. You start. Madam, you start the first one. Why did you take PA course? Sit and talk. Mask. It has various fields. Ninga? Next to doctors. Wonderful. Okay, specialties then. Okay. 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 இதெல்லாம் சொல்லிட்டு அப்புறமா மெடிக்கல் டிரான்ஸ்கிரிப்ஷன் போக கூடாது நீங்க. See, that is another thing which I wanted to address in this, because it's so passionate to be in medicine. Okay, it's an addiction. So just choose your specialty. In fact, I see a lot of kids who joined here, who have continued here, and they've really come up very well. Please don't switch. Why do you become a medical transcription? Adukapra innona pharmacy, they go into pharmaceutical research. Okay, if you wanted to do pharmaceutical research, please do a clinical research, a clinical pharmacy, go into research. Physician assistant, as you all rightly said, we have multiple specialties. You're next to doctors. You have, it's a wonderful experience to be with patients. Nothing like that. They can never bore you. Okay, so please stick on to the specialty, continue, and the country is just now witnessing. Okay, I think Dr. Rajiva would have showed what is it to be abroad. To share a small experience, I was doing a medical legal assessment for case sheets from the US. Okay, அதுல பாதி நோட்ஸ் பாத்தீங்கன்னா physician assistant. நான் நினைச்சேன் அவன அளவுக்கு கூட நம்ம வந்து இங்க டாக்குமெண்டேஷன் பண்றதில்ல. As doctors we don't document. Beautifully they'll document everything. In the US is physician assistant based தான். அதுக்கப்புறம் தான் the clinician, because the signing as the doctor comes in, then the doctor அதுதான் மெயின் அங்க. So the notes by the physician assistant is so good, so elaborate. In fact, they would have covered everything. Beautiful, they would have covered everything. So at that point in time, I realized, wow, what a recognition they are getting. India la varudhu. It will come up in a big way. So don't leave your course. Stick on. Okay, choose which doctor you want to be associated with. Multiple opportunities. Carry on. எல்லாரும் ஒரே காலேஜா? எந்த காலேஜ்? ட்ரிப்ளம் தானா? Okay, fine. How come we have not seen them at all? Okay, fine. Okay, wonderful. So don't go away. Stick on to the same specialty and continue. And this is most important for all of you. If you want, you guys can come to the OPD. I'll take a detailed, elaborate history taking, because that is the basis. அது தெரியாத patient கிட்ட பேசாத ஒண்ணுமே நடக்காது. Okay. And Triplum is a vast experience. Only thing, we have all super specialties here. Very difficult to catch up. but you guys are really good at it. I don't know how you suddenly become vascular surgery. I don't know how you guys cling on and beautifully perform. I'm extremely proud of you guys. Fine. Thank you. So I don't think you will have any questions on this. If it is there, then I'm happy to answer. Any questions? There are people who also try to do MBBS after physician assistant, but I don't think that is a great idea. You guys have a great future. MBBS திரும்ப நீங்க முதல்ல இருந்து ஆரம்பிச்சு திரும்ப போயிட்டே இருக்கும் அடுத்த 14 வருஷம். So don't do it. Don't try to do it. Yeah. No questions? Okay. We'll join for lunch. Come.
Thank you, ma'am, for such an informative session. Now it's time for lunch break. I request all the reps of PA students to come forward and to collect the tokens. The representatives, all the PA students, first year, second year, third year, and the final year, please come forward of Triple M College. Any one representative from other college can please come forward. The other college students, you have your reps, right? Any one representative, please come forward. Those who got their tokens, please go to the right side of the auditorium for the lunch.
I request all the students to get back to the auditorium by 2:30.
Now we'll move on with the next session. It is a privilege to welcome our next speaker, Dr. Jacob James Raj, Senior Consultant, Cardiac Surgery, to present us on the topic, BioValve AVR in Young. It's an honor to welcome you onto the stage, sir. Thank you.
Thank you. So all of you are comfortable, enjoying yourselves, had a good lunch? How many of you are feeling sleepy? They've given me a boring topic, so I don't know what to do. I don't know if I'll make you more sleepy or less sleepy. How many of you think we should put a biological valve in a young patient? What, Sudha? You agree? Okay. She agrees. So I think it'll be okay. So we'll steer the discussion towards what Sudha has agreed upon. Okay. So what are the different biological valves that we have available? Stented bioprosthesis. We have stentless valves. We have a Ross procedure. And now we have this Ozaki procedure. Okay, so stented valves, we have valves from which we can take from a pig, which we call a porcine valve. Bovine valve is we take the pericardium from the cow and we make a valve. So that's a bovine valve. If we take from what animal is equine? Horses. Okay, we also had a kangaroo valve. So all these are different stented bioprosthesis. Stentless valves is the most common is the freestyle porcine valve. Okay, there is no stent. So if there is no stent, it will have much wider orifice. So it will have lesser gradients. Okay. The other one which we can use is a homograft. Homograft comes from fellow human beings. Ross procedure is another way of doing a biological valve. And this Ozaki procedure where you use the patient's own pericardium or sometimes the bovine pericardium, and you use a template and you cut out the leaflets and sew the leaflets onto the aorta. So that's usually done by the pediatric surgeons for younger patients. Okay, good. So there are certain truths which people don't challenge. Bioprosthesis degenerate faster in young people. Okay. Bioprosthesis degenerate faster in the more active people. And anticoagulations have their own complications, both due to thrombosis and due to bleeding. Okay, good. So many of these things, how do we know many of these things? By reading papers, which are actually studies done by people who collect the data, analyze them, and then know the truths. So by reading these papers, we come to know these things. Okay. So this was a paper which was which told us about the Carpentier-Edwards valve. Okay. And it told us that we could use the valve in younger patients because they said almost 8 years freedom from valve degeneration was there. But their young was 60. Their mean age was 51 and 81% of the patients were male, which probably meant that they had bigger aorta and lesser gradients. So 3/4 of their valve was size 23 or bigger, which means they put bigger valves. And their index orifice area was more than 0.85 in 93% of the patients. Okay, so no patient prosthesis mismatch. And 73% were in class 1 or 2. So we know from these graphs that this valve actually did very well and it lasted almost 18 years in young patients. But let us look at this paper for a change. Okay, this paper also had young patients, the same young patients, 60 years old, but they said that it had more structural valvular degeneration and more chance of reinterventions in the younger age group. So there are some limitations when we look at these papers as well. Okay, so that is what these two papers contrasting tell us. Okay, so now we'll look at the recommendations. What is the American Heart Association recommendation? They tell us that less than 50, you need to put a mechanical valve. And more than 65, it is reasonable to put a biological valve. They're not even saying you put a biological valve. They're saying it's reasonable to put a biological valve. But less than 50, they say you put only mechanical valve. And in between, the decision is by discussion. Okay, good. The European Society recommendation is more than 65. And that was their recommendations in 2007, but they reduced their age by 5 years by 2012. So we don't know if they will reduce it further or what. Same thing happened with the American Heart Association. Between 2007 and 2010, they said 65, then they reduced it to 60. And now in 17, they said maybe 50. They haven't said 50, they said maybe 50. So what is young? It's a very debatable question. So if you say maybe 50 years, I think most of us would agree that less than 50 for a bioprocesses would be young enough. Or maybe if we talk in terms of life expectancy, somebody who is expecting to live more than 20 years, maybe he is young. And level of activity, that decides on the structural valvular degeneration of the valve. So that is again something important that we need to consider. Somebody who is very active, you probably put him as a young guy. You're somebody who is more lethargic and not much of activity, he would qualify more to be an older person. Okay. So when you talk about life expectancy, most of these papers come from countries like UK or Canada, where the life expectancy is 15 years higher than us. So when they say young, we have to subtract 15 years from their young to come to our young, isn't it? So maybe 45 years. Would you put a bioprocesses in somebody less than 45? That seems to be the question, isn't it? And when it comes to choosing this, these young, considering it in young brings about a lot of complexity, because young means they have a lot of years to live, and that valve is subjected to a lot of the stress and strain for a longer time. So that's what we need to consider. Okay. So now if we look at this paper, it's a 10-year comparison between tissue valves and mechanical valves. Okay. It's a propensity-based trial. So it's a good thing that we can, rely on it. They have said there is definitely a reduced midterm survival in bioprosthesis. Valve-related complications, no difference. Mechanical valve has a better hemodynamic performance, and because of that, lesser ppm and more mass regression. So when somebody has a hypertrophied heart, you want their hypertrophied heart to regress. And you get that by putting in a valve, which is a larger orifice area and lesser gradient. So that is how you will be achieving this. Okay, good. So these are all the things that tell us that. So now, in spite of this, in spite of what? In spite of reduced midterm survival in a bioprosthesis, why do patients want a bioprosthesis? A lot of people, they ask for a bioprosthesis. Why? Because they think they have a better quality of life without anticoagulants. Why go every month, poke your hand, get INR done, then, address the, adjust the dose and keep on doing these things. So they think their quality of life is better if they just don't have to worry about that. Noise of the mechanical valve, better long-term durability of the newer prosthesis. So they think, oh, okay, we are getting better prosthesis now anyway. So why don't we go for them? A lower operative risk. Even if you need to have a redo, the operative risk is lower. So why not just have it? And now a lot of people say, we'll put TAVI. So anyway, go in for a bioprosthesis. Okay. So these are all the reasons maybe why people would say, let me have a bioprosthesis and let me have an anticoagulant free life. Okay. So what are we balancing? We are balancing the structural valvular degeneration of bioprosthesis versus anticoagulant related problems of a mechanical prosthesis. Okay. So now this is another meta-analysis from the same, from Australia. Okay. So this tells us that there is no difference. So it was a comprehensive analysis from 6 electronic databases. Middle-aged people, there was no difference in mortality, and bioprosthesis had a lesser anticoagulant-related complications, probably because they needed lesser anticoagulation anyway, and that was obvious, and a higher structural valvular degeneration. Okay, so there is really nothing to learn extra from this paper. So these are the curves which show us pretty much the same between mechanical and bioprosthesis. Okay, good. And another meta-analysis, and this meta-analysis tells us the median time to structural valvular deterioration was 17 years, which is quite good. And a median time to reintervention was the same 17 years, which is actually very good. And for a 45-year-old adult, it translated to an expected life expectancy of 21 and freedom from reintervention of only 20%. So 80% he is going to have a reintervention done. So structural valvular degeneration of 71%, thromboembolism of 12%, bleeding 5%, endocarditis 9%. So all these things are there. Okay. So looking at this, probably it's not all that rosy. Okay. Okay. So this is the last paper. Okay. Paper's a little bit boring for you, isn't it? Okay. So this is in patients aged 50 years or younger. So this is really young patients. Okay. So they start by saying that it's a complex decision to put in a bioprosthesis in a younger patient. And firstly, it demonstrated a 3.8-fold increased risk of major bleeding events in mechanical AVR because they were all anticoagulated, and an 8-fold increased risk of reintervention in biological AVR. Okay, but they say it did not translate into survival benefit or survival disbenefit. Okay, okay. Then the other reasons, the other complications immediate post-surgery were the same for both. So that there is no difference. And they also found out that more and more people were having more and more valves, especially biological valves, especially in redo. So whenever people are redoing it, they're going in for more of biological valves. Okay. And the type of valve did not matter as far as mortality goes. Okay. And when you use anticoagulants, so why do they use anticoagulants in biological valves also? A lot of CT scan studies showed that there were microthrombosis on the leaflets of the tissue valve, which may be predisposed for an earlier structural valvular degeneration. So they thought if you anticoagulate even the biological valve, they will last longer. So if you anticoagulate them, that advantage of no anticoagulation again is lost, isn't it? So then why not just have a mechanical valve? So these are all the things that go through our mind when we make up these decisions. So their paper's conclusion was whichever patients, some patients may be okay with a biological valve. So who are these patients who it may be okay to put in a biological valve? How do we do the balancing act? Okay, so these are the two things, as we discussed, that we should weigh out. And one more important thing, which probably is the pivot of what we should think about, is the hemodynamics. If you put in a bioprosthesis in a smaller valve, in a smaller aorta, and have a higher gradient, more ppm, lesser LV mass regression, there's no point. So unless you have a reasonably good sized valve in a bioprosthesis, there's no problem. So meaning there's no point. So hemodynamics is also another thing that is very important. And anticoagulation again will complicate the issue, especially if you say anticoagulation is better off even in a bioprosthesis. Okay, so what are the things that, for surgical things that we think about when you put in a valve? Coronary obstruction, residual gradients, patient prosthesis mismatch, LV mass regression, and requirement for anticoagulation. So these are all the things that pass through your mind. The use of bioprosthesis will continue in the young, and even more and more people will be demanding it. So when that happens, what do we think? We look at life expectancy. If somebody's got a severe LV or some other comorbidities, and we think their life expectancy is less, you should probably say okay to a bioprosthesis, because anyway, they're not going to live that long. But if somebody is absolutely fine, healthy, and they're going to, exert themselves and have a high level of activity, you should probably dissuade them from having a bioprosthesis. And when you put it in, you ensure a sufficient index orifice area. Use the later generation valve. Don't use the more older ones, which probably people would be selling it at a lesser price. Use a later generation valve that it will last longer. And it should be friendly for putting in a valve-in-valve TAVI at a later date, and maybe a little bit of anticoagulant. Maybe you don't need to have it at the same level as a mechanical valve, but a little lesser. So what are the things which push the age recommendation this way and that way? A mechanical valve can be extended more into elderly age group because Maybe you have valves with lower INR targets, so you don't have to anticoagulate them so much. And with newer anticoagulation, probably you don't need to do INRs and stuff. So more and more older people can have mechanical valves. Younger people having bioprosthetic valves, you have a TAVI backup, and valves which last longer. That's probably the more important point that makes people say, okay, fine, valves are better. Why not I have it at a younger age? So that is the sort of thing that can push the recommendation age-wise this way or that way. Okay. Done?
Thank you, sir. We have our next speaker, Dr. Satish Kumar, consultant intensivist, to present on the topic intensive care management. We welcome our next speaker, Dr. Satish Kumar, consultant intensivist, to present us on the topic intensive care management. Welcome you onto the stage, sir. Thank you. Let's give a round of applause.
I'm just going to wake you up from your good lunch. Okay, thanks for inviting me to talk about sepsis management. How many people have seen sepsis? I think here it's full of physician assistant, am I right? I need some feedback, otherwise we'll be sleeping. How many people have seen sepsis? Yeah, 2 down. Yeah, theater team, excellent. And where is Mahalakshmi? And he's not present here today, isn't it? Infectious disease team. And who else? Still people are having their lunch, is it? Okay, they all gone home, is it? Okay, nothing to worry about. So my talk is going to be basically, what is the role of physician assistant in management of sepsis in any hospital? You may be working in cardiac, theaters, CCU, ICU, or anywhere, but what is your role? Do anyone define sepsis? What is sepsis? The commonest cause of death in the world now is not MI or cardiac conditions, road traffic accidents, but the first one which present is sepsis. So what is sepsis? It should be like a discussion rather than me just chatting around. What is sepsis? Pushkala, fantastic. Tell me. Infection. Come on, stop playing with your phone. Is the sepsis and infection same? You got a prize now. Is infection and sepsis the same? What is the difference then? Someone said no. Excellent. Who is it? Come out. We'll just have an open chat rather than me blabbering around here. Yeah. Extreme form of infection, which means what? What is the extreme form? Systemic. What else do you see in a septic patient? Excellent. Multi-organ failure. When a patient comes to multi-organ failure, what do you do? Sorry. A little bit louder because we just had lunch. Come up. Easy, very easy questions. Investigations. What sort of investigations do you do? Please don't start with blood culture. I'll be shocked. Okay. Fever. What is fever? We'll start from the base. Rise in temperature. What temperature? Do I have temperature now? So when you say the temperature, what is the normal range? The reason why I'm asking is when you go to the ward and any place, 37. Okay. So you have some criteria to say the patient has got some infection. That's it. So you say 37.3. Amazing. What else? That's what? Very easy. It should come from your mouth. That's it. What the heart doesn't know or the brain doesn't know, the eyes doesn't see. This is what my teacher taught me when I went to the second year of medical college. Pressure. What is pressure? Blood pressure. Okay. I want some from other side. What is blood pressure? What blood pressure do you say it's normal? When do you get alarmed? When do you get alarmed? Can I say 100 systolic? What else? 160 and above. Okay. 140. Okay. What about diastolic? Okay. So there is some criteria to say when the temperature goes up or when the temperature goes down or the BP goes up and the BP goes down. What else? So you talked about 2 parameters. What else do you see? Very common. Respiratory rate. Excellent. How much we breathe normally? So when do you get alarmed? More than 22. So collectively, what do you call all this called? You say vitals. So all these 4 vitals, what is it called? We called systemic inflammatory response syndrome, SIRS. So that's what here. Yeah. So when do you call sepsis? Very simple. It's like max 2 + 1 3. So when you have 2 SIRS and 1 confirmed or suspected infection, what is confirmed and what is suspected? Who is working in microbiology here? Anyone? Do anyone work in microbiology? Okay, no problem. What is confirmed and what is suspected? How do you suspect? With the symptoms and with the chest X-ray, with those things. And you see, isn't it, like cellulitis? What is severe sepsis? Another one more. So the reason why I'm asking you is when you go to the rounds with the doctors on your own, you see all these things. You have to differentiate. At the end of this scenario, like the talk, you will definitely know why I took all the slides to you. See, this is called severe sepsis. When sepsis with signs of organ damage, hypotension, lactate. What is lactate? Do anyone check on the ABG lactate? Okay, I will reverse the question in a way. How many people check blood gas? I know my colleagues here check. I know Pushkala checks. What about infectious disease team? She's gone, so no problem. Who else checks blood gas? Okay. If I was you, in your situation, the first thing comes to my mind on any patient who has touched these 2 syndromes like SIRS and sepsis, my hands goes directly to taking a blood gas or who has taken it, just check over. So what do I check there? There's so many parameters coming on an ABG, but my eyes goes on one thing. What is the thing? Lactate. Okay. What is lactate? Is it a good or a bad? So we should know whether it is a good or a bad. A lactate is a very bad because it comes through anaerobic metabolism, not through aerobic metabolism. What is septic shock? Shock. What is shock? Patient is on shock. So many times we said this word shock. So the patient on fluid, the patient on inotropes, the patient on everything, but still we couldn't able to bring the blood pressure up with hypotension on 90 and end organ damage. What do you mean by end organ damage? So where will your eyes fall on when you want to see an end organ damage? Excellent. Who said this? Amazing. Brilliant. Urine output. So what is a normal urine output for a human being? I get this call every day. Okay, what is it? Okay, what else? Any differentiation from what our colleague said here? 1 ml per kg. What else? Is it a pediatric or an adult? So I will say 0.5 to 1 ml. I always say there's no definite answer. So 0.5 to 1 ml per kg. So this is what sepsis is. So the definition of sepsis, see, my talk is basically from NICE guidelines, UK guidelines, okay? So this is how we differentiate severe organ dysfunction and with hypotension is septic shock. It can be reversible or non-reversible. And they say if more than 1 hour, if it is not responding to fluid, then we say it's called refractory shock. And if it is more than one organ which is getting dysfunction, then what is MODS? Multi-organ dysfunction. So this is how we define sepsis. So what is your role here in finding sepsis? So there comes my question. Why did I choose this sepsis for you people specifically? Pushkala. Why did I choose this one? You were with me in the rounds every day. Common cause, easily treatable, easily identifiable. What else? So before I come for my rounds, Pushkala goes and sees all the patients in CCU. I use Pushkala because I know only her and few people here. She goes to the rounds and all the patients and she writes everything in the chart. If you go to CCU, ICU2 and ICU3, you could see in the chart, they could see everything, they will write it up. They will write about urine output. They will alarm me if something goes on. And when the rounds comes in, she will let me know these are the things I'm missing, okay? So, what is SOFA score? Excellent. Why do you do it? Then, what did they say? It says something the patient is not well enough. So you have to alarm your consultant, alarm the team that something is happening to the patient, which the SOFA score goes up and the mortality goes up. So it's an alarming score in a CCU and ICU setup or in any setup to alarm the patient, to alarm the team. When I say team, we all work as a team. Am I right? So it alarms you and you have to alarm me saying that the SOFA score is very high and my concentration goes deep inside the SOFA score, okay? This is the red flag sepsis which we use in European countries. Everywhere you go in Europe, in nearly 27 countries in Europe, we use it uniformly. The reason why I'm showing you this one is many people will go abroad for your higher studies or training. So this is how we do. And this job is done by you, not by me or any staff nurse. Sorry to say this. The personal assistant does this work in emergency department, ICU, ward, and what they do is when the red flag sepsis starts, it can be in the GP. GP is general practitioner bundle, which we follow in European countries. That is outside hospital. And there are personal assistants who work there, who are trained in hospital, and they go outside and see this patient in the general practice. They alarm, they call the ambulance, and they send directly to ER. So I want to show you this. This is how we do. Age. Could this be an infection? You could easily tell it could be an infection as long as you know it's SIRS. Any red flag present. Systolic BP more, heart rate more than 130, and respiratory rate, whether the patient needs oxygen. You could easily judge everything. And any recent chemotherapy, cyanotic, blatching, anything, and not passed urine in 18 hours. So 1, 2, 3, 4. When you have this criteria, yes, go for it. and start the GP bundle. This is what they say. How many bundles of sepsis you know? There are 3 bundles. Who works in ER? Anyone? Have you heard about sepsis bundles? Bundles is nothing but the treatment or the protocol we follow right from first hour, third hour, sixth hour. That's called sepsis bundle. It's very important because if you find out the sepsis and treat in first hour, 80% of the mortality of the patient goes off. The next 6 hours, if you treat the patient, 90% of the mortality goes off. You could easily prevent. And the last 6 hours is the basic thing. The last 10%, and you could easily treat the patient. The first 1 hour is the golden hour. Like what you say in cardiac, sepsis is first golden hour. What is the 6 steps of sepsis? The first 6 steps in the first hour. What will happen when the patient comes to you, tachypneic? What do you do? What do you do? You just stand there and blink like it? Like what do you do now? Is it what you do? Oxygen. How much of oxygen? Can I say 2, 3, 4, 5? Why do you want to start with low? Kill the patient. Kill it first. You want to kill it, isn't it? So give 10 to 15 liters of oxygen straight away. So what do you want to have? You want to have something as a parameter. What parameter do you want? A saturation of more than certain thing. So I will say more than 94. Yeah. And what else do you do? You put a cannula. And when you put a cannula, what will you do? You take the blood. Okay. When you take the blood, why do you take a blood? To send for a blood culture. How much bottles do you take? Yeah. Why do you do that? Why can't I send only 1 bottle? I'm a layman. I don't know anything. You just tell me to take blood culture. I've taken it. Why should I send 2? Excellent. We need to know what is aerobic and what is anaerobic. So we need to have 2 sets of bottles as far as my knowledge concerned. I don't worry about the 3 sets and 4 sets. That's all IDs. Okay. Most important. What else do I do now? Give antibiotics. Why should I give antibiotics? Should I do blood culture first, antibiotic second, or antibiotic first or blood culture? Why? I'm going to ask you this question because when you go out of this room, this thing should be in your mind or in your heart. Yeah. Why? Why antibiotics and not? Okay, I put 1 cannula here. I put 1 cannula here. I take blood here. At the same time, I give antibiotics where? What will happen? Excellent. That is the answer. Yeah. So that is the right answer. Okay. Fluid challenge. What fluid do you want to give for a patient who is septic? What is challenge? I challenge you. What do you mean by? I could say, give fluid, but I usually say fluid challenge. Why? Anyone on that side? Anyone on the front seat keeping mum? Why fluid challenge? Have you any time challenge fluid? And what fluid to challenge? Okay. So usually I say 20 ml per kilogram, but now you could say 100 or 200 mLs. And I usually choose normal saline rather than any other fluid, that because every fluid has got their plus and minuses. Okay. Measure lactate, very important. First 6 steps is measure urine output. Why do you measure urine output? Again, I'll come back to you. Why? It says end organ damage. Excellent. The first hour bundle, very important. So blood culture 2 sets. They say you should draw before antibiotic and within 1 hour after time of presentation top is. IV broad spectrum antibiotics, lactate, and IV fluid. See, they say normal saline, 30 ml per kg. I say 20 ml. And start within 1 hour and complete within 2 hours. The first 1 hour, you have to do all this thing. This is going to prevent the patient from dying. Yeah. within 3 hours and within 6 hours. This is called 3 hours and 6 hours sepsis bundle. Measure lactate again, obtain blood cultures, check which is broad spectrum antibiotics, check over again, administer 30 ml of fluid again and again, check lactate, and within 6 hours, apply vasopressors if it is hypotensive, and make sure the minimum, they didn't say systolic or diastolic, they said, what is MAP? What does it mean? What does it mean? Difference. Okay, that's all. I'm a layman. I already told you I'm a layman. I don't know anything what you're talking about. But what does it tell me when I go and see MAP? What does it tell me when I'm in the rounds with you all? What does it tell me? So arterial pressure, a mean arterial pressure, which keeps every organ filled up. I don't worry about systolic. I'm not worrying about diastolic. I want a mean, okay? Because each organ has got a mean arterial pressure, which keeps the blood flow, yeah? Renal, heart, brain. So we need to know what mean arterial pressure is required to keep all the organs working. So that is why I always check it. And I always say, reassess again and again and again, so that you check everything, so that you don't miss anything. Now comes the most important part of yours. Why did I talk about all these things? Okay. What is your role? What are you going to do with sepsis? All you people, is it going for the rounds? You go with cardiologists, you go with pulmonologists, yeah? And then you go with everyone. She taught you about auscultation and all this stuff. You did everything. Now, what is your role? So, early identification. You are the people who are going to identify early, oh, there is a sepsis. So what else do you do after early identifying all these things? You're going to keep quiet? What are you going to do? Now you're going to tell me what you're going to do. Otherwise, I can't go to the next slide at all. What are you going to do? You're going to do SOFA score and flat tug. You can do it when I can do it. You can do it. What is flat ug meant by? What is SOFA score? You learned about SOFA score. What is flat ug? Like we usually do it in, yeah. It's just a mnemonic. Yeah. Yeah. Why do you do it? In the rounds, when I started this in 2022 Feb in our ICU, everyone asked me, why do you do it? Why do you want to do it? Why do you want to do all this mnemonic? Why do you want to? What is your role in that? That's my question. Very simple. What is your role in that? See, this today is your day, not my day. It's your day. So my question is very simple. By teaching all this, what is your take-home message today? When you go out of this room, you should take one message in this 20 minutes what I taught you. Okay, I'm going to ask you that question at the last minute of my talk. One thing to keep it in your mind. You are the most important person in the team. We are all part of a team. As a consultant, I'm just last 5%. You are 80% or 50%, and the staff nurses are 50%. I'm the last 1% to come and write the diagnosis and come and write the medications. That is only my role. You're going to do all this. Okay. So as I told you, you should know what is happening. Then you should alert me. Alert. You're alerting me. And by knowing all this, you're going to call me and say, there's something wrong with this patient. You need extra attention. Just don't chat with us and go off. Yeah. Many times, Pushkala has told me, don't you? Communication. How are you going to communicate? Most important part. How are you going to communicate to me? Documentation. What else? What are the 3 modes of communication we do in this hospital or anywhere? Verbal, excellent. Written, excellent. Third one, social. We don't do it here, but sometimes we do it. Yeah. Checklist. Who has done a checklist in your day-to-day activities? What checklist have you done? Checklist. Every place where you work, they should have a checklist. In ICU, we got a transfer checklist. We got separate checklist for drugs, bundles. Excellent. The last I want to come up with delirium. Have you ever heard about delirium? What is delirium? How many patients, how many people of you have seen delirium? Why did I bring it at the last, at the end? I could tell this word, sir, our romba gudikkarar sir bedla, pudikka mudiyala kaiya kattirunga. How many people have told me this? Kaiya kaala kattiruvom sir. Yeah, I'm very happy that you openly came out honestly. Why do you want to tie a patient in the bed? I even don't tie a patient who has got some psychiatric problem. I don't tie them. But this is a patient who has come to us, is in CCU, is acting in a bizarre way, and you're tying it up. What is the mode of communication is going to do to you? I don't understand. Now you have to tell me, if it is your patient, what is the mode of communication the patient is going to do? Either they have to openly tell us what is happening, or they have to do some signs and tell us the patient has got some pain. They're going to hold the hand wherever the pain is and communicate. By tying up, we're just stopping everything. Yeah. So this is FASTag bid. What is FASTag? Nothing but food, analgesia, sensorium. Why do you bring this one? Why did I bring this one to you? This is for sepsis. When you go to ICU, CCU, or any critical care, you have to note all these things on it. This is called checklist. We always do for every patient. When you have time, just go around to CCU, ICU2 and ICU3. I'm not very sure about adult ICU, whether they follow it, but these three places, by doing this, I honestly say, we have brought down sepsis very well down by identification because of your support. Just by bringing a few things which I learned. This is the definition of delirium. It is an acute. It is not a chronic one. It is acute, which happened today or tomorrow, which has got an impairment of consciousness and disorientation to the surroundings. Very simple. Patient is coming with acute confusion, disorientation to surroundings, not know what's happening. Why? The first cause is sepsis. The second cause is pain. The third cause is taking oral medications or whatever extra. Third, when the patient comes from cath lab, we take the spectacles, we take the ear, or what you call the hearing aids. So the patient will be completely lost. You won't know what is happening and you get very delirium. Have you ruled out all these factors before tying the patient up? Always check, check, check. Any questions? I put this picture because many times I don't know the answer. Only out of 100, 10 times I know the answer. 90 times I'll go and read and come back. Okay, so don't hesitate. The reason why I put this slide is, don't hesitate to ask questions to anyone. No one will feel down. When I'm at this stage because I used to ask a lot of questions again and again. That's how I improved my knowledge. Keep on asking questions in the rounds, okay? Any questions? Now, common questions on sepsis. No questions? So what is the take-home message? Tell me one take-home message. You are in a septic ward or you are in a CCU, critical care. What do you do? First thing. Excellent. What will you do? Whatever. Okay. What will you do? You have to tell something. 20 minutes talk. What is your thought? Take one message home. Good. Communication. Excellent. What else? Excellent. So you have taken so many messages today. So I'm very happy. This 20 minutes of my time is not wasted. Thanks a lot.
Thank you so much, sir. That was quite an interesting session. Now we have Dr. Nitya, consultant IRM, to have an interactive section.
Hello. Yeah. Okay, so I do not have any slides to bore you guys today. So let's have an interactive session. Okay. So, okay, before that, good afternoon. It gives me immense pleasure to be here and talk to you today. And I would like to thank the organizers for giving us this opportunity to talk with you all. So let me keep it very simple. Like, as you know, the Department of IRM is Institute of Reproductive Medicine, which we also see gynec patients and obstetrics and also infertility patients. We don't call them infertility anymore. We call it as subfertility. So let's just keep it very simple. I don't have slides. So how many of you here would be interested to take this specialty? Obstetrics and gynecology? The hands can go higher up. Okay. How many among this? I can see many girls, but are there any boys? Okay. Anybody else? So all you guys would have gone one round of clinical postings in the department, right? So what scares you the most to take up this department as a specialty? I think the boys should be able to answer. Tell me, what is scaring you? Handling who? 2 lives. Okay. And then I can see 3 boys sitting here. What is scaring you? Okay, so what are you interested in? Nephrology. Okay. Others? He's put his mask tight on, so he doesn't have to speak. You don't have to come. You haven't done. Okay, so that's fine, but you can tell me what you are interested in. Cardiothoracic. He won't answer from there. He will come here and answer. Okay. So so basically the first thing I want to tell you guys is, few years ago, though we did our undergraduate and post-graduation in a medical college, we were not really aware of what a physician assistant or a physician associate is. So this terminology and this was very new to us few years ago, especially when I saw a lot of physician assistants in from small nursing homes to hospitals and big corporate hospitals. All of a sudden, I can see them everywhere, like in every department. They're replacing doctors everywhere. They are, working with the nurses, they're working with the doctors and everywhere all of a sudden. So this has become like a new advancement in the medical field. So like how there was one period where there were, all the software engineers used to go abroad for their higher education. It's like a golden opportunity for you guys, because you are at the peak of the time where you can create an opportunity to go abroad if you wish to, because working abroad, who wouldn't want to go abroad? Okay, but choosing a specialty at this point of time is very, very important. So when I was doing my undergraduation and when we went to the internship, so one thing I was definitely sure is that I wouldn't want to enter this OBGYN department, because we had the surgery department, surgical postings, and then after which we went to the gynec postings. And you know how in surgery department, everybody is super fast and everybody is running around and there's a lot of energy. But all of a sudden there's a shift to gynec department and I see the department is very slow. Everybody is walking so slow and the pregnant women don't want to walk. They're all, with fatigue and very tired. And to put them on the cot and examine and to bring them down takes 15 minutes. You have to be very, very patient. I thought I would definitely not be able to do this in my life, because sitting with each patient for so long, you can't even scold at them to get on the bed faster or to speak faster. And they have so much to whine about, every day telling back pain, leg pain, head pain, every pain. And you have to have so much of patience to listen to it that I thought I would definitely not have that patience. But to my surprise, I actually ended up in this department where I didn't want to. But now the things have changed, you know. So what I'm here to tell you about is, so each of you will have different interests. You will have, some might want to specialize in nephrology, ortho, whatever department it may be. For those people who want to take up gynec obstetric as a specialty, or for those of you who are still confused on what to choose, so I'm here to speak about it, so that you can decide and choose this as like an opportunity to know more about the field, because it is very, very important that you decide what you want to do later in life. Okay, there's no point in regretting later. Okay, so coming to so we deal with obstetrics, gynecology, and infertility. So the basic thing that is required would be taking a history. So taking a history, what is different in this department, taking history from other patients, is that so you can't ask them on their face about their sexual activity. Okay. So what are the basic things that you would ask in a history taking, which is different? The medical history, the surgical history, all that is fine. It's the same format. But what is different in gynec? Can you all tell me? Okay, so the menstrual history. Okay, then obstetric history is okay. They will tell you. Then? Yeah, okay. So asking about if they had a cesarean section and all that. Okay, fine. Then asking them? Yeah, contraception history. Yes, definitely. So we are in this era where you have to ask contraception to everybody, be married or unmarried. You have to ask them. You can't just feel like, she's unmarried. Should I not ask this question? Will she think I'm a bad doctor? No. You have to ask them. It's now like, we are asking smoking, alcohol history to everybody. We have to ask about coital history to everybody. So that plays an important role. And one more important thing is, these history taking will, give you an idea about the patient, not to be judgmental, but, to know more about them and know what they want. Okay. So contraception history. Yes. Then hysterectomy is okay. Another very important one, which I want to address, is asking about the sexual history. And before you ask that question, you have to look around. You can't asking it to anybody else. How you had BP, sugar, whatever, all that. You cannot ask like that. You have to ask who's sitting next to the patient. You have to see who is sitting. Mother-in-law is sitting, mother is sitting, father is sitting. You have to make sure about all that. Take the patient to examination or send the whoever the attender is out before you ask these things. So these are the basic things that we have to first learn. Now the books will give you hundreds and pages of things to mug up and knowledge and everything. But if you lack in these basic things, then we are lost. Okay, so that's most important. So we have had one patient who is married for 9 years, and they come to you for infertility workup. So without asking the basic history, so you give them the semen analysis, you give them the scans, you give them the hormone test, you tell them IVF, everything. And then later you find out that they have not had sexual intercourse. So how stupid is that? So we will have to first know the basics. Okay, so you might be surprised that the patient does not even, somebody does not even know about it. No, there are a lot of patients who don't even know about it. It's a basic reproduction, but they don't know about it. They don't know about ovulation. They don't know about having a regular intercourse. None of that. So you have to ask them. It is very intimate. You have to, these are very, sensitive things which you have to address. Ask them how many times, it might just find, others might find it very weird to ask, how many times do you have intercourse in a week? How many times do you have intercourse in a month? All that. But, it is our duty, because initially it might be a little difficult, but after a point, you will know the importance of all these. So unless you ask this, what is the whole point of making the patient have an IVF and spend so much? So So that's very, very important for us while taking a history. And what else do you guys do in the gynec postings? What else have you all learned? So nobody has learned anything. So there are all first years here. Okay, so first years have faithfully come today. Or what about the others? They've not turned up. All you guys? Which year? Third years. Okay, then you would have finished the clinical postings, right? Tell me. Now, if you all don't answer, I'm going to pick each of you and I'm going to ask you a question. It will be a good ragging session today. Okay? Guys, okay? Huh. They have a very safe answer. Pap smear. Okay. What is pap smear? What is that? What? This I can see, but what is pap smear? It's a diagnostic test? It's a diagnostic test or is it a screening test? Mass answer we will give and get 100 out of 100. Okay, I can see a bunch of boys there. Which year? Intern. Okay. Okay, so what else do you all do? Pap smear and then? What else? Nothing. What do you do? Huh? HVS and LVS. You all know what is HVS and LVS? What is that? High vaginal swab, low vaginal swab. What is the difference? How does it matter? Tell me. Yeah, don't whisper your answers. It's okay. Come on. They don't even want to open their mouth. So you all can at least answer. Okay, so you guys, what I've realized is that you guys have a syllabus which is this is exactly what an MBBS student would study or a postgraduate study. Do you agree with me? Yes or no? Okay, so you all study the same data and everything. Yes. There's an answer for me from Siri. Okay, so you all read exactly the same topics. Okay, so what is your role in the department is that, so these patients, before they come, they Google, they surf, they want to know everything. Nobody wants to wait. They will want to come, get their work done faster. Before they leave, they want an answer. And they will cross-check with the Google to make sure that your answers are correct. And if you don't give them the correct answer that they are expecting, they will come back and ask you for doubts. Am I right? Yes. Okay. So now what is your role here? So the doctor is saying, patient is coming. What are we doing in between? Okay, so for any department to function, now that the practices have changed. So say in olden days, when there is a doctor and there's a patient coming, there's a direct interaction with the doctor and the patient. Okay, now everything has become a group practice. Now there is a team for everything. So there is a team, we have specialized nurses, we have a physiotherapist, we have an anesthetist, concerned to the department, we have a specialist in infertility, we have obstetrician, we have a gynecologist, we also have physician associates in the department, and we have some specialized nurses as well. So this brings a continuity in the care. Okay, so each patient, imagine you as a patient, you will have lots and lots of doubts. You want to ask somebody, the doctor might not be available for you. Yeah. Because they're seeing so many patients, it is our duty to respond to the patients and answer everything that they're asking, not just about the money, not just about the consultation that they're giving you, that you have to give an answer. We have chosen this department. We have chosen to be in the medicine field to make sure that we clear their doubts, explain it to them. After all, it is their body. We can't just judge whatever we want. We have to explain to them. They will ask you suggestions, options, questions, and it is our duty to explain everything to them. But even if a doctor is, their clinical judgments are good, and if the doctor is, very good, he's the topmost and everything. But if you don't explain things to the patient is just going to call you, useless. They will just say the doctor doesn't even talk to me. Why should I go back to them? So now this era is like the patient wants to talk to you more, feel like a family member. They want to ask you doubts. They want you to clarify. They want to, talk to you more. They want to talk. They want to ask questions. It's ultimately, it's either going to be a normal delivery or it's going to be a cesarean section. It's only one of the two. They're okay with it. They're fine with it. But at the end of the, 10 months, and imagine all these patients are going to be repeatedly coming to you. Every visit, they are going to keep coming to you. It's not like in the other departments where, you do a surgery or you keep them in touch for the chronic infections that they have. They will come to you for every 6 months or every 3 months for follow-up and all that. Here, they are going to come and see your face every other week, every once in 2 weeks. And if it is a patient who we are going to do an infertility workup, it's going to come and see your face every alternate day. They will have every alternate day, they will Google and ask you questions, and you should be ready to give them the answers. So what I'm trying to say is that you are no lesser, okay? So you should gain the knowledge and ask questions. Ask how much ever questions you all want. And if you don't want to ask questions, nobody wants to answer. Why will I walk forward and, try to explain you something? You might just think like, what, I already know the answer. This person's coming and giving me an explanation. So why would you, why would anybody come and talk to you if you don't want to talk about it? Ask questions, whatever doubts you have, talk to the patients. They will teach you so much more. They will ask you something that you will feel guilty, that you will want to go back and read, or you will want to go back to your consultant and ask them, what is the explanation? Why should we do it this way? Why shouldn't we do it this way? And doing a thesis might just, sound very funny. Like, why should we even do a thesis? We can just manipulate whatever we want. Google is giving everything. You can just copy, paste and write whatever numbers you want. Who is going to come and cross-check? You think anybody who is going to come and cross-check your numbers? Nobody is going to. But I'm telling you, when we were also a postgraduate, we also did thesis and we didn't take it seriously. I swear to God, none of us took it seriously. Even the head of the department in all the departments, I'm sure we didn't take it seriously. But the importance you will learn only, later, say 10 years after you finish your post-graduation. By then it becomes very late. You want to do things, you might not have the patient load to do it. Now you are all of a sudden you are, alone. Nobody is going to come and teach you. Even if I do a thesis, there's nobody to come and check if it is correct or not. What I think what I've done is correct. That's all. If it's not, if it's not correct, somebody is going to make fun of me. So, take it seriously. The 4 years of, your studying course, take it seriously. It doesn't matter. I mean, you don't have to sit and study every day. That's my most important. You don't have to sit and study, mug it. At least when you are in the hospital, when you are in your clinical postings, give your 100%. Try to know about every department. Try to go into every room, ask them questions, find out only then you will know what you are interested in. Okay. So now the departments, each department has various specialties. Say even, it was once only a gynec department, an obstetrics and gynec. Now we have so many specialties in it. Now we have, high risk obstetrics, we have onco, we have gynec, general gynec, we have, breast specialty, we have infertility, we have fetal medicine, we have scans, we have so many varieties and so many specialties. And I'm sure very soon all of that will become in each department by itself. So before that, you will have to choose one department or one specialty, which you have to start choosing now. It doesn't matter. You don't have to choose it later. From day one, you should know what you want to do. Only then you will actually know if you will be able to do it or not. Okay, so in the department of obstetrics, gynecology, and infertility, what is the basics that we expect from a physician assistant? A proper history taking. Doesn't matter. So we had the COVID. Do you think it was only the doctors who handled around the world? Everybody, whoever was qualified. There were so many hospitals which were run by only the physician assistants. The doctor used to just come for rounds, tell them the orders, and they would leave. So we don't know what else is waiting for us in the future. Anytime we might have to step inside. You might be the acting doctors very soon. You're probably one. And I can tell you, you should be very proud of it. Some physician assistants, they might know about the patient even better than the doctor itself. They would know everything, from, where she's coming from, what is her family background, what is her expectations, like, what is she going through, everything, be it, every time this patient comes, she comes with her mother-in-law and is scolding and she's been abused and she's been bruised and whatever, all that, everything from outside to inside, a physician assistant, we have seen people who've known about it much more than a doctor does. This anybody will be able to do. So y'all should be the person who is in between, bridging the gap, and should be able to, give the continuity of care. Okay. So history taking is a very basic thing, and we should be able to do it, and should be able to, do it in a very sensitive manner. You can't just be like, what is your past medical history? What is your sexual history? What is your, contraception? What do you use? Not like that. Your tone has to change. You have to mellow down. You have to look if there is anybody around. And you also have to address other sensitive matters in that. They might be married, might be second marriage. Imagine you asking about it in front of her second husband. He's going to kill you. Okay. So, you will have to, sensitively deal with the history taking. Now, next comes the examination. So what do we expect from you? Examination, you are checking for the baby's heart rate. Okay. Ultrasound, we're checking with the Dopplers. At first, you have to check if the baby is alive, right? And then they might tell you, you gave me a TT injection, that's why my baby died. So you should be able to do all that. You should be able to, even in place the doctors are not present, you should be able to examine and confidently tell the patient that you and your baby are fine. Okay, so that, and then the vitals. Vitals is very, very important. Okay, and doing a pap smear. It's as simple as doing a pap smear. You should be able to give counseling to the patient. Most of the time, 5 out of 10 patients will come only for talking. They will pay you. They're ready to pay. They just want to get a counseling. That's all. They will ask you about contraception counseling. You should be able to provide. Very soon, we might have contraception clinics everywhere. Abroad, there is already one. We still don't have that, running a separate contraception clinic, running a separate sexual health clinic, running a separate, pediatric gynec clinic everywhere. Now, if we are going to diverse like that, we are short of doctors. Okay. Now, not everybody can't be everywhere. Now, you will be very soon put in that situation where you will be asked to deal with all of this all alone. You might have somebody to supervise, but you will be pushed to that situation very, very, very soon. Abroad, it is already a big thing. Once upon a time, being a software engineer, everybody wants to fly abroad. They all want to settle in US and, Australia. No, do you know how important physician assistants are in those countries? Everywhere, there is so much of wanted. They all want physician assistants. Doctors are there everywhere, but this field is such upcoming field, I tell you. You start visiting the other small hospitals, small nursing homes and corporate hospitals. Everywhere it is filled with physician assistants. I can bet you on it. And the hospitals now in South India, they have every corporate hospital has been replaced by all physician assistants. We don't have any more junior doctors or any duty doctors. No, there's directly a specialist, And under them, there are only physician assistants. They are only explaining. The patients are coming and asking doubts. You should be able to tell them. Examination, ultrasound. Do you know that various hospitals, the physician assistants are itself doing the basic ultrasound? You should be able to show the heartbeat to the patient. You should be able to show them, simple scans. You should be able to perform. And even, like I told you, very soon we will be having contraception clinics running everywhere in every, city. So at that point, you will be appointed in one clinic. You should be able to explain to them, put a copper T, remove the copper T, everything. Unless it is, complicated, you should be able to deal with all this. And I'm telling you, note it, very soon it's already becoming like that. Abroad, it is already like that. Now, India is also starting to become like that. For every specialty, there is a diversity, and every single specialty or, subspecialties are going to start having physician assistants everywhere. And I personally found this very recently, not many years ago. Where I studied, I have seen a lot of physician assistants. I know I had friends in allied health science. They were all studying, and I didn't know the importance. But I didn't expect that, you would be given such importance. It's only because you are wanted everywhere, be it any department. Okay. And, infertility patients, there are a set of workups that you have to do. You should be able to do all of that. You should be able to. And now say a patient is coming, they're waiting for the doctors for hours. They don't want to just sit and wait. Meanwhile, they are asked to, do the blood test. They are asked to do the hormonal profile. They are given the ultrasounds. They are giving pap smears. All of this will be done. And at the end of it, with the reports, they go see the doctor. Would you not, be happy as a patient doing it that way? Or do you want to sit for 4 or 5 hours and go see the patient, go see the doctor, and then he gives you a list of blood tests, and then after which you will go see the blood test, and then after that you have to take another appointment, and then you have to come back to the doctor, again sit for another 4 or 5 hours, again have to sit, wait for him. Will you not be bored? Don't you want this fast track everywhere? Everybody wants fast track. Nobody wants to sit and wait. Everywhere they're doing video consultation also. They will be very happy. They're all only going to be talking, right? Unless it's an examination, you can have a video consultation. So you should know what investigations, what, blood tests, what workup has to be done for each patient. And nobody is going to find faults with you. You should start doing it. There are fellows who are doing it. You should assist. You should put forward. You should like, ma'am, can I try, take the investigations which I want to do it. And when the patient is coming, we will see it. We will be very, very happy if somebody is, putting in an extra effort and wanting to do. Nobody is stopping anybody. Okay. We are all in the learning phase. We are all learning and we are still learning. Okay. So is there any doubts that you guys have in this department, or you have some obstacles, or you think, you are, half-minded, not knowing if you should do this or not? Or is there any other difficulty? And deliveries, how can I forget about it? Deliveries. When the Anganwadis and the eyes are able to do the deliveries, will you not be able to do it? You've, after all, read the same book as we all read. It's the same book. It's the same knowledge all of us are sharing. All of us are giving exams. All of us are giving vivas. All of us are doing thesis. What is stopping? It's only the interest that stops. And it is that, one moment where you would be like, should I just step inside, or will they think I'm acting too much? Should I just refrain myself from, going forward and putting myself forward and saying, please go and see deliveries. Go and monitor the patient. And no delivery is going to happen just like that. They will be sitting for 10 hours and 12 hours and they will still be waiting. The next day they will deliver. They're all waiting. You can go and learn, see what is happening. Everywhere it is being replaced. Very soon you will be left to do normal deliveries yourself. And there might be days where you'll be doing surgeries also. Now you are assisting, which is an amazing thing. You assist more, you learn more. So There are doctors who want their particular assistant only to come and assist them for the case, because that assistant knows what the doctor expects, what the doctor wants in the surgery. Okay. So, make it very clear. I don't want to, you've been reading in your books, you've been having lecture classes, you've been attending your postings, everywhere it's only about the theory on and on and on and again. I don't want to talk to you anything about the theory. Let's just, have the practical aspects. If you have any doubts, or if you are, having second thoughts, you can always come and talk to us. Okay. Is there anything else that I can say? Or am I done? Yes, counseling is very, very important, especially going for an, infertility. There is a lot of scope for counseling. We're definitely having, very soon we will be having counselors, and already all the fertility centers everywhere, there are counselors. And it is even more better for, you see, getting a random person to get into the field and explaining to them about the IVF and making them learn about counseling for an IVF is different from a person in the medical background to do the counseling yourself. It will be a very good opportunity. You should learn about it. You should know about it. Just go and sit down when somebody is counseling a patient regarding an IVF. 2 counselings, you will be knowing what to talk. And then you can specialize in it. It is a very upcoming. And embryology, I tell you, it is the most upcoming field right now. Although we have some laws now saying that, you should have medical recognition, you should have a specialty. I mean, you should have a degree to get into the embryology field. It is not applicable for physician associates as of now, but we never know. Things might change. But counseling is definitely yes, a big, big yes. Embryology? For physician assistant, which I'm saying is will be replaced very soon. So we are having laws saying that, you should have a medical degree. You should have an MBBS. You can work as a junior embryologist, but you cannot be, an embryologist, a proper embryologist. You can just be, helping them. That, yes. But to become a specialist in that field is not it. Because previously they used to do. A lot of them used to do. Anybody, BSc, whatever, they used to do BSc botany and zoology, and they used to end up in embryology. But now the law has changed. It's very recent. And I think it's around June. They have, the law has come saying that you cannot practice embryology that way anymore. So the embryologists who are already existing, they're all, on the boat already, not knowing what to do. So embryology might just be a little doubtful. Yeah. Yes, definitely. Cord blood banking is a lot more of research. It's more of a research. So not all the doctors who are, are interested in research, but they want researchers. So they are open to all the medical fields. They are open to anybody in that medical field for that matter. So research is definitely yes. Research and scientific research is definitely open for everybody. But embryology is not now. Maybe in the future, but not now. Okay, is there anything else that I can say? Okay. Okay, thank you.
Thank you, ma'am. We have our next speaker. We have our next speaker, Dr. Naina Sri, to give us a talk on the topic role of physician associate in gastro department. Over to you, ma'am.
So good evening, everybody. I am Dr. Nainshri from the Department of IGLD, and I'll be talking about the role of the physician assistant in gastroenterology. Does anybody know the lady on the screen? This is the first lady physician assistant, Miss Joyce Nicholas. Okay, in 1970, she got her degree. So, who are physician assistants and what do y'all do? Okay. That will come to later. First, we'll know what gastroenterologists do. It is the study of the alimentary tract with along with liver and pancreas. So it involves evaluating, treating, and preventing gastrointestinal diseases. So the most important part, I think the previous speaker has dealt in detail about the importance of a good history taking. So you have to take a good detailed history of the symptoms, the bowel habit, diet, medication, and look for any recent stress, which is a very important factor when it comes to gastroenteric diseases. The alcohol intake, we have a lot of questionnaires for this, which will help us in identifying what treatment the patient will need, and also a family history of malignancy and other such things. Okay. So some of the common symptoms in GI disorders are loss of appetite, swollen belly, nausea, vomiting, heartburn, pain, indigestion, ulcers, loss of weight, dysphagia. The list goes on and on. Okay. So you need to know how to differentiate. The patient will come and say indigestion, but what form of indigestion? Is it a heartburn? Is it dyspepsia? Is it belching? Is it burping? Is it bloating? Is it postprandial fullness? So there are a lot of other things that you have to clearly define, because it's a very broad term and the layman's version of it might be different from the actual medical version. Okay, so you have to differentiate between hematochezia, and melena, between hemoptysis and hematemesis, between a typical cardiac chest pain and a chest pain caused due to heartburn. And gastroenterologists are very fond of scales and gradings and scoring system. So much so that even for stools, they have a Bristol stool form scale. So when a patient complains of constipation or diarrhea, you can show them this picture, ask them how their stool is, and then decide if it's really so. It's gross, but somebody has to do it. And alcohol, it's been so common that everybody is now taking alcohol, but you have to define how much alcohol they're taking, what units they are taking, in what quantity and how frequently and for how long. Okay, then we go on to examination. You start with the general. There are a lot of signs of general examination with respect to liver and other gastrointestinal diseases. Vitals is very important to know if you're going to keep the patient in the OP and continue your examination, or the patient has to go to the ER. And then abdomen examination and per rectal. Okay. Now we'll just go through some of the few symptoms. And as you can see, most of the disorders will have similar symptoms. So that's when the history becomes important to know the chronology and how severe the symptoms were, so that you can club it into one syndromic diagnosis. So causes of dysphagia can be from minimal GERD to even an esophageal carcinoma. What is GERD, by the way? Yeah, so what happens is the lower esophageal sphincter is quite lax and there's reflux of acid from the stomach into the esophagus. It can be just the lax LES, or it can be the herniation of the stomach into the thoracic cavity known as hiatal hernia. And then you have inflammation. I'm just showing some of the diseases that we usually see in our OP. Then you have inflammatory bowel diseases. So if you see the symptoms, it's almost the same. Abdominal pain, weight loss, rectal bleeding. Here also you can have bleeding, blood in stools, and weight loss you can have in both. So that's when your history and trying to identify what kind of a disease becomes important. So because both of them, although similar in presentation, will have different medications and different surgical treatment. Okay. Then we have something known as irritable bowel syndrome. And you can see the cause here now: stress, anxiety, depression. So all this, if you fail to take that in your history, you might not think about irritable bowel syndrome. And celiac disease is due to the gluten hypersensitivity. So what happens is your intestinal villi is unable to absorb the proteins because it has become atrophied. So people will ask, why so long I was able to eat roti, chapati and all that, but now if I eat, I can't digest it. So you need to know some basic pathophysiology of the diseases so that you can explain it to the patient, so they understand the disease better and adhere to the treatment. This is some of the signs of liver disorders. And acute pancreatitis, the patient will come with severe pain, and here your history of alcohol becomes very important. Okay, just an overview of what we see in the OPD, nothing too heavy. And the most important part is the informed consent. So usually you will see the patient before any procedures, because gastro is dependent on a lot of scopies, tapping and all that. So before procedure, it is important to obtain an informed consent. Why do we need it? It leads to greater patient satisfaction and safety, and you have reduced risk of litigation. Tomorrow, the patient cannot go to court and say, I was not told about it or anything, because you have a document with the proof that you've been told all this, and they also have signed the document. And with this, and because we have the document, you also make it a point that you definitely do it, so this step is not skipped. So eventually, in the long run, it will save you time and money. Okay. And what does an ideal consent consist of? The diagnosis, if you know it, the nature of the treatment or the procedure, the risks and benefits should be clearly explained. And you should let the patient know if there's any alternative available. And it should be dealt in the patient's language, like the one they understand. And if you guys don't speak the same language, then get a translator. And always allow time for questioning and make sure the patient has understood what you're trying to say. Okay. So, and then you can also obviously assist in endoscopy. The one on the left is me right now, holding the scope, not knowing which is head, which is tail. Eventually, with your assistance, maybe we can do greater things. The other is tapping, which you all can do under ultrasound guidance. It's a very, very simple procedure. You just have to prick and draw the fluid. Nothing much is required. Obviously, just aseptic precautions. Okay. So this is what you all are capable or all are allowed to do. Patient education, you empower the patient with knowledge. You assess the patient, you can order tests, you can formulate a plan of how to treat the patient. You can discuss with us, and the same can be told to the patient, or we can make changes according to what we feel. You can even prescribe some medications and procedures and interventions like we just saw. And obviously in the surgical field, you can assist with surgery also. So doctors have Doctors' Day, physician associates have Physician Associate Week. So that's how important you guys are. Thank you.
Thank you so much, ma'am. Now I would like to call upon Dr. Manoj Kumar, sir, consultant diabetology, to present a talk on understanding the diabetes mellitus.
Good afternoon. Yeah. Didn't have lunch? Okay, good. I can hear some more voice, no? Thank you. So, like, I would like to congratulate the team for pulling out such a beautiful event in a short span of time. So let's give a hand to them. And I will not take much time because I think you have been waiting since morning, right? So the topic today is learning to educate. Okay, it is like we all are diabetic educators here. Physician assistant, they can become a good educators. Okay, because you are the first person who will be meeting the patient prior to meeting the doctor. And most of the time, no, the patient, they are more friendly to the educators or the physician assistant rather than being friendly to the doctor. Okay. So that's why I tell you, let's learn and then you educate the patient on the same field. What I'll be talking about lifestyle disease. I think lifestyle disease means diabetes, hypertension, dyslipidemia, obesity. Okay. And this is one topic, no, which many of the patients, they forget it. When do they remember? It's like our exams. Everybody writes exams, right? When do you remember exams? Just when you get the timetable, right? Yes. Similarly, diabetes, hypertension, and dyslipidemia, it is remembered only when there is some disease aspect, the patient gets heart attack, the patient gets kidney problems. No, that is the time when the patients remember diabetes. Okay. So our work is to remind them about diabetes every 3 months, every 4 months, whenever they come to visit us. Okay. So we should know about metabolic syndrome, what it is. It is basically a syndrome of visceral adiposity, the insulin resistance, hypertension, and then dyslipidemia. Unlike whenever you say dyslipidemia, no, we have got a high LDL cholesterol. But for metabolic syndrome, no, it should be low HDL and high TGL levels. Okay. And we all have come across COVID-19. Okay. But there is much more bigger pandemic than COVID-19, which is obesity, and which most of us, we really forget about that. Okay. So, and that is one thing which has to be addressed. Why this is very important? No? Because when you are born, you have got lean adipose tissue. And because of the genetic, because of environmental, because of excess of calorie intake, I'm sure everybody had a good lunch, right? So again, there's a calorie excess there. Okay. And then we are all sitting inside the room, sedentary lifestyle. All this will predispose to the fat cells can become obese. So they are the first one to get obese, not the human body, the fat cells. Okay. These fat cells will undergo some changes. There'll be increase in your inflammatory markers. You will have decrease in your adiponectin level and increase in your leptin levels. Okay. Now always remember, no, even your adipose tissues are also called as endocrine organs. Okay. And adiponectin is one hormone which is beneficial for weight loss. So in obesity, that adiponectin level comes down, and that all leads to inflammation. Okay. What does inflammation do? It creates something called insulin resistance. Okay. Now, whenever you think about insulin, you always think about diabetes. But whenever you have insulin resistance, it leads to 3 defects in metabolism, which is cholesterol metabolism gets defected. As a result, you have dyslipidemia. Then you have got endothelial dysfunction, increase in arterial stiffness, and that can lead to hypertension. And then finally, for glucose. So yes, there'll be decrease in glucose uptake, increase in the production, leading to diabetes. And all these 3 things, they are called in Hindu mythology, Tridev, we'll say, right? Tridev, Brahma, Vishnu, Mahesh. Similarly, here also you have got one. Dyslipidemia, diabetes, and hypertension, they lead to cardiovascular disease. Now, ironically, what happens is the patients are worried of cardiovascular disease rather than worrying for the dyslipidemia, diabetes, and hypertension. So at your aspect, it is important to make the patient get knowledge about that. They should get a bit sense of taking care of the body to take care for diabetes, hypertension, and dyslipidemia. Okay. It's a very busy slide, and it can, I'm sure, your obesity, it can lead to any of the organ damage. And probably that is the grade 1 organ dysfunction which can happen. Okay. So this is a very important slide, which will tell you, that at the same BMI, the risk of men and women getting diabetes is high. So you see that at the BMI of, let's say, 25 to 28, the females are at least 4 times higher risk of getting diabetes when compared to men. So this also points out to another fact that the female health has to be taken at utmost importance. Okay. Now, even in a family itself, okay, when a female is getting sick and a male is getting sick, who takes the major care? Male or female? Male, right? But who should be getting the better care? Female. Okay. So I think that has to be reversed. You should ask the females to take more care. Okay. So now let's come about diabetes, because you have already heard about all the disease by now. So let's talk about diabetes. And this is the data. Right now we have 537 million people, and by 2040, we are going to increase the numbers. Okay. And in India itself, the prevalence of diabetes is around 9%, which is somewhere around 80 million people who are diagnosed of diabetes. Okay. So now life expectancy, why are really important? We have got two age. One is chronological age and metabolic age. Okay. So when you suppose a person is going to live to the end of life, okay, when the patient gets diabetes, his life is already decreased by 6 years. And if the patient already has got diabetes or stroke, the life is going to get decreased by 12 years. So metabolic age is going to get decreased. Okay. I think Akshay is here. No. Okay. So she had done a study just to tell you what is the age difference between the two generation of two generation getting diabetes. So what happened? What we saw was the next generation gets diabetes 10 years earlier than the previous generation. So if a father gets diabetes at 60 years, the child can get diabetes at 50 years of age itself. So again, your role comes importance there also, no? Because if the patient comes with diabetes, you should look into the family members also. Okay, so genetically, everybody is born to get diabetes because we're born in India and everybody's family history is there, right? Anybody whose family is not diabetic? Diabetes, hypertension, dyslipidemia. I have got my family history. Okay, so all of us are at risk of diabetes. Only thing is we can delay the progression. So Akshay said 10 years. If you take care early itself, you can delay it to, let's say, 3 years, 4 years also. Okay, so why we are worried of diabetes is because of the complications we have. Okay, so people are at higher risk in stroke, MI, heart failure, CAD, and overall cardiovascular disease. Again, Sneh had done a project in CCU about the admission rates, like how many patients get admitted with heart failure or CAD, and we saw that around 26% is higher chances of patients getting admitted with heart failure in diabetic patients, okay, when compared to non-diabetic. Okay, so, and we all know that if a patient gets heart failure, the mortality risk is on the higher side, right? So this is about our Indian scenario. Okay, so 4 out of 5 people are diabetic. That is 75 to 80% of the patients are diabetic, and okay, in India, uncontrolled diabetic in India, and only 20% of the patients are on insulin. Okay, and if you see the average A1C in Indian population is around 9.2%. Again, one more study which Ms. Priya had done, our first PA, just to look into the average A1C in our hospital, which is 1,000 patients, 1,000 patients, and in tertiary center, the patients HB average A1C was around 8.3%. Okay, so we have got high liver fat, high waist hip ratio, high TGL level, high CRP, and all this puts you at risk of cardiovascular disease by 2 to 4 times, premature death. And everybody works in the cardiac center, right? You're working here, no? You see, like many patients come with younger age patients come with heart attacks, right? So we are at a higher risk, okay? And almost a good number of patients are diagnosed of diabetes less than 50 years of age itself, okay? So, this was one good study which was done, like just to look into all the 3, hypertension, diabetes, and dyslipidemia, how much patients have got control in all the 3. ABC. Today you learned about ABC with the infection, right? Yeah. So in diabetes, ABC is A1C. In A1C is for diabetes, B for blood pressure, C for cholesterol. Okay. So you see, like out of 419 patients, no, only 7% of the patients were under all the good controls. Okay, so either the dyslipidemia will not be under control, or diabetes may not be under control, or hypertension may not be under control. So, yeah, this is one of the most important things. Is like, oh, many patients, they say, right, can diabetes be reversed? We are come to the question. Once we start with medications, we have to take medicines lifelong or not? Okay. Yes, we have to take medication lifelong because 80% of your beta cell is lost when you're diagnosed of diabetes. Okay, so 10 years, 80% beta cell loss. So if you are able to diagnose them early itself, you'll be able to prevent or delay that progression of diabetes. Okay, so now everybody will ask, what are the symptoms of diabetes? Let's go behind. Yeah, what are the symptoms of diabetes? Okay, so my student is answering more. So yes, is polyuria, polydipsia, polyphagia, weight loss, and tiredness. These are the major symptoms of diabetes. Okay, and weight loss is one major symptom, because if the patient has weight loss, no, I think again the peer role will come there to tell the patient about insulin. Okay, that is the patient who requires insulin, and if the patient takes insulin, even if for 2 to 3 weeks, no, it will help them. Okay, so always tiredness, frequent urination, your weight loss, wounds. Some people's wounds will not heal also. Okay, and they will have that vulvovaginitis, balanitis, and all can happen. Okay, you can have blurry vision. They'll have thirst. So okay, and tiredness. Okay, so these are the levels. I'm sure you know the levels. 100 fasting, 120, 140 postprandial, and A1C should be less than 5.6. So any patients who has got fasting of blood, fasting more than equal to 126, postprandial more than equal to 200, or A1C more than equal to 6.5, you term them as diabetes. Okay. In between this pre-diabetes, you're seeing, no, 100 to 125, 140 to 199, 5.7 to 6.4. Now they are a pre-diabetic patients. Okay. Now most of us, no, will say that you are pre-diabetic, right? You are just in the borderline. Just leave it. That is not supposed to be said. These are the patients whom you can pull them towards normal side if you have a good lifestyle modification for them. Okay. So complications. Okay. So you have got, as your blood sugar starts going on the higher side, no? Yeah. So you have got 3 or 6 major organs which can get affected. One is your eye. The blood sugars will go and get deposited in the eyes, kidneys, your nerves. It can go and deposit it in your brain, heart, your peripheral vessels. Okay. Each time, whenever the blood sugar shoots up, like patient is eating well, patient blood sugars are normal, patient goes for a function, Diwali comes or Dashera comes, no, patient takes good amount of food, sugars will shoot up, right? It will not, sorry, it went away. So it will not remain in the blood circulation. It will go and get deposited in all your organs. Okay. And it is that deposited blood sugars which are going to cause complications. Okay. Now this concept, you can explain the patient even to take HbA1c, because if you want to see what is the level of blood sugars in all the organs, no, you have to take it each and every organs. But if you do HbA1c, it will tell you an average for last 3 months, no, what is the level of blood sugars which is accumulated across. For example, you want the blood sugars to be HbA1c to be somewhere around 7%. Okay, and if the patient comes with HbA1c of 10%, which means for last 3 months, no, there are 3% blood sugars which is deposited in all the organs. Okay. So these are the complications what the patient has, and ideally you should screen for the complication when the patient comes to you. For eye, you ask the patient to go to the ophthalmologist once a year. Okay, that is, you ask them to do retinal scan, cataract, and for glaucoma. Okay, more commonly you will have retinopathy which comes into. For kidney, you ask them to do urea creatinine, but more importantly, you ask them to do a urine microalbumin, which will detect the kidney damage at the early stage itself. For your neuropathy, which is at the foot level, no, you ask them to do foot examination, like you ask them to do biothirsmetry, monofilament, and all. Okay. For stroke, you really cannot. For stroke, you can not detect anyways. Okay. But for cardiac, we all know you do ECG, echo, lipid profile, TMT, and then go forward. For shoulder, when the patient comes with the PS shoulder arthritis, that time you can ask them to get evaluated. Gastroparesis. Okay, again, that is the symptomatic the patient comes with, so you don't have any screening test for that. Okay, but you do test for autonomic neuropathy and all. Okay, that can detect gastroparesis. And for peripheral vascular disease, you ask them to do an ankle brachial index. Why these things are very important? Because again, the way you detect diabetes early, you prevent the severity of the disease. Similarly, if you detect complication early, you'll be able to prevent the severity of the illness. Like we have got Nandini doing a small project, like using a tuning fork. You know what is tuning fork? Where do you use it? Where? Huh? We use it in ENT, no? ENT. They use the tuning fork to see whether you have got hearing loss or not, no? So same thing, we are trying to use it for peripheral vascular, for neuropathy, to detect whether we can detect neuropathy at the early stage itself, at the mild stage itself. Okay. So now this was one good study which is done, like 26,000 patients were done, and most of them, they said that I have no idea that I can get diabetes from my parents. Okay. And I didn't know that diabetes can be prevented. Yeah, if you are in the pre-diabetic stage, no, you can prevent diabetes itself. Okay? And I had no clue that diabetes can cause heart, kidney, and nerve damage. Okay. So most of the patients, they don't know that diabetes is harmful. Okay. So I saw one patient today. He came after 3 years. Sugars were fine. Everything was normal. Okay. But his microalbumin on the higher side. So then I told him that because of the diabetes, your microalbumin is on the higher side. So you have to be careful. So the problem is, like most of the doctors, no, they are not so free enough to see the patient over the time. Okay. And this disease, it needs more of a communication. Okay. So you have a role in preventing all the complications, just speaking to the patient. So that is the place where you get a major role to play. Okay. So how can I help the patient to understand the condition? So you should understand the condition first and then explain to the patient. Okay. And how can a patient be supported? And the first beneficiary when you start educating a patient is who? Who is the first beneficiary when you start educating a patient? Is you yourself. Because the more times you say, okay, you should not eat this food, you should walk for this distance, no, it gets incorporated in your mind. So you starts following the same pattern. Okay. So the aim of an educator is to improve the patient motivation and awareness, okay, about diabetes management. Okay. And it will help to improve the behavior of the patient and adoption of therapeutic lifestyle. Okay. So lifestyle modification is basically diet and physical activity, both. Okay. And then finally, no, once everything is maintained well, no, the patient will have a better diabetes control and improved health. Okay. So AAD, no, which is the American Association of Diabetes Educators, they have given few guidelines about 7 principles of diabetes education. Okay. It starts with being active, healthy eating, medication compliance. Most of the patients are not compliant with the medications. Okay. Monitoring about all the blood sugars and all the risk factors. Okay. And then problem solving. Okay. Like when the patient goes for hypos or hypers, or if the patient has got some foot infection, how to tackle those diseases. Okay. And then reducing the risk. The patient already has a cardiovascular disease. What other organs has to be screened for? Okay. And then living with diabetes. Many patients, they feel that, okay, diabetes is a curse for me. I have to go along with it. Okay. And they go into depression. So the role of educators, no, is to uplift them in the morale also, so that the depression part is avoided. Okay. So whenever patient comes to you, they'll come with 4 A's. One is avoid denial. Most of them, they don't accept that they have got the disease. Okay. Anger. Okay. We had a small fight in the OP today because of the rush queue and all. So every time you'll have, I'm sure. Okay. Anxiety, like what is the doctor going to say? Okay. And then found apathy, because nobody really thinks about them. Okay. So you need to have some motivational interviewing with the patient. Okay. So that the motivational interviewing should be patient centric, and you should understand the patient well there. Okay. And the patient expression, desire, reasons, and all should be assessed properly. And then that can cause some behavioral changes. Okay. So it has to manage with 5 A's. Okay. One is arrange. You should plan what are you going to speak to the patient, what the patient wants. Okay. assess, you should see the belief of the patient, the behavior of the patient, whether the patient, whatever you are going to say, the patient is going to accept that or not. Okay. Advise the patient. Don't give too much of information. Okay. Because if you give too much of information, the patient may not be able to carry the same information home. Okay. So we all know that you give some 3 to 4 information at that visit, so that when the patient comes next time, no, you can add some more information to that. Okay. And then agree. Sometimes, no, if you try to argue with the patient, no, it's going to cause more harm than benefit. Okay. So try to agree with some sense, disagree with some. Okay. And then assist the patient. Whenever patient comes with some barriers, like for insulin, if the patient comes, no, sir, I don't want to take insulin, then assess them, make them to believe that, okay, insulin is important, it is useful and all. Medications, adherence to the medications is important and all. So you have to assist the patient. Okay. So this was one example of behavioral modification which was incorporated. No? We had got 6 patients here, A, B, C, D, E, and F. So one of the pilot group, no, every follow-up they were interviewing the patient and assessing the patient whether they're doing or not. So proper follow-up was done. In control group, no, not proper follow-up was done. So what you saw that the patient who achieved goal was patient who was counseled regularly. And if you see the patient A, no, even if they were dipping, once they had re-counseling done, their motivation improved. Okay. And I'm sure like that's what happened in sports also, right? If the patient is, if the sportsman is not motivated, you motivate him so that no, he'll be able to perform well. Okay. So just 3-4 slides more. Okay. So it is about COVID. And I think that was one important factor which always kept in our mind. Okay. Why it is very important? You see that the mortality or the death rate with patients with COVID, no, is on the high, with the diabetes on the higher side when compared to non-diabetic. Even in a hospital, also, Sarah had done a small data collection in the second wave, where we saw that there was higher incidence of mortality with diabetic patients when compared to non-diabetic patients. And any of us who have worked in the COVID center, we would have seen the same thing. Okay. Also, not only about mortality, is also that the rate of the days in the hospital also increases. You see, like patients with let's say non-diabetic, normoglycemia, the average stay in the hospital is 6.3 days, and it goes to 10 days. The patient has got admitted with hyperglycemia. Okay, so the duration of hospital stay also increases, and with every day of increase in the duration, no, you see that the cost of therapy increases, the burden to the family also increases, right? So. And again, this also tries to show you that the mortality is on the higher side with diabetes when compared to non-diabetic. Okay. So this is only about COVID-19, but in general population also, we see that people with diabetes, no, they stay a bit longer when compared to people without diabetes. Not to mention about hypoglycemia. If hyperglycemia is going to cause complication, hypoglycemia can kill the patient at that moment itself. How many people are working in ER? Nobody? The most common admissions, the patient comes with diabetes is hypoglycemia. Okay. So they will come with blood sugar of 30, 40 and all. Okay. So what it is basically, because it is a triad, okay, Whipple's triad, no, where patients come with hypoglycemia with numbers of less than 70. Okay. And the patient will come with all the symptoms like neuroglycopenic symptoms. Okay. They'll have hunger, fatigue, sweating, shivering, and all. Okay, dizziness. And then when it goes to neuroglycopenic, when the blood sugar goes less than 40, no, your brain will not get glucose. So you'll have neuroglycopenic symptoms, which is confusion, slurred speech, blurry visions, and all. Okay, it's like you go on the night, right? Your night when you're walking on the street and you see a dog coming to you. What will you feel? You'll feel scared, right? Okay, the shivering, sweating, and all will come, right? That is the autonomic symptoms gets activated. So same thing will happen with diabetes also. Sometimes the patient can get angry. Okay, like OPD is going on, it's almost 2:30. A patient starts shouting, no, check sugars for them, because sometimes in anger also, no, in hunger they can have anger. Okay, so and then it can be caused because of either because of medications, patient not eating well, patient not well, diarrhea and all. Okay, so and you should follow rule of 15. Okay. It is like you test glucose. If the glucose are less than 70, you give them some dextrose or give them something to eat and then recheck the sugar again after 15 minutes. Okay. Glucagon is the treatment of choice, but in India, we don't have glucagon in the hospitals. Okay. So the best thing is to give glucose. If the patient is eating well, patient able to eat, give juice or some sugary items. If patient not eating well, patient unconscious something, then give them dextrose. Okay. So you have got outcomes. So learning, that's what I told you first. You learn and then you try to educate your patients and then incorporate some behavioral changes, which already I have listed out. Okay. When you incorporate all these behavioral changes, you'll have some clinical improvement, which is your, in terms of A1C, your blood pressure, your cholesterol levels, your weight. Okay. And then all the complications, you skin for eyes, nerves, your kidneys and all. Okay. And overall, it will help in improvement of your metabolic health. Okay. So you'll be able to prevent complication. The work left in the hospital, work off from the office will be reduced. Okay. So you measure, you monitor, and again, you manage. So we are working in triple M, right? Yeah. So again, here also you've got triple M here. Is you measure, monitor, and manage for the patient. Okay. So these are the roles of PS. Actually, it is about improving the communication between the patient and the physician. So I think PS, no, they form a link between the physician and the patient. So you have got a role there. Okay. So it also helps the development of knowledge based on the global aspect. Okay. And then you have to practice based on comparison research. Now everything is based on data. So you have to practice based on that. Okay. And ability to share information. So whatever information you have got, it should match with the patient and the physician. Okay. So you should be able to share them. Okay. Communication should be there. Okay. So you are the source of communication between everything. Okay. And then documentation. For everything, you need to have a proper documentation. The last slides. Okay. So the take home message is like lifestyle disease is on rise and it has to be addressed at the earliest. Okay. Patient, they lack the knowledge of metabolic syndrome. Okay. Not only because you have got lots of information. You go to internet, no, you just write some things, write about diet. You'll get thousands of slide of website opening up, and most of them they will just be misguiding you. So lack of knowledge. Okay. Education is the key for better health. Okay, for our patients, and hence, no, your role is very, very important. And you should follow this triple M strategy. Okay, for to keep our patients healthy and make them some behavioral changes. Okay, and it's time to move from treatment to management. Now, many of us can ask, what is treatment and what is management? No, treatment is looking at the blood sugars. A patient comes in, a doctor sees the blood sugars, give the prescription, goes off. That is treatment. Management, no, it is a team effort. Okay. Patient comes in, meets an educator, see what all tests to be done, extra tests to be done, meets a dietitian, meets a physician assistant, physiotherapist, a person who can give some physical activity exercise, counseling, and then sees the doctor, go to the pharmacy. The pharmacist will ensure that all the medications are given, and then patient goes home. In between, relatives also taken care of. So that is called management. Okay. You cannot play lawn tennis here. You have to play cricket or football here. You need all the players to get involved, and all the players are equally important. I cannot say doctor is important in controlling the sugars. It is not like that. It is each and every member, be it dietitian, be it educators, be it a pharmacist, nurse, lab technicians, all are important in managing your lifestyle diseases. Okay. Thank you. Anything to be asked? Everybody wants to go home.
Thank you, sir. Now we'd like to welcome Mr. Shivakumar, President of Indian Association of Physician Associate, to give us a short talk. We welcome you, sir.
Good evening to all of you. Wish you all a very happy physician assistant day and week. How many of you are from first years and third years? So the rest are from second and fourth years, right? So you all might have seen me in Delhi. Okay, fine. The purpose of me coming here is to inform you all that the responsibility has increased. Okay, see, you all are happy that you have been recognized by the government. That is good. And there's a change in nomenclature from assistant to associate. So what does that mean? The speaker after speaker has emphasized the fact that, you know, you guys are capable of doing this, you should do this, you should do that. I was listening patiently from behind. So what does that mean? That means your responsibility in the healthcare system has increased manifold. There's a lot of expectation from a physician assistant graduate. So as students, what is your prime responsibility? No, somebody can answer. What is your prime responsibility as a student? You don't have any responsibility. You'll come, you will sit in class, play with friends, go for a movie and then finish. That's all. See, the most important thing which as a student one should do is to acquire knowledge and skill. Getting marks alone is not enough. That is the reason why I'm asking this question. Because many people commit this mistake. They think that their job is to get good marks, get a degree and push off. See, the whole idea is if you don't have the knowledge, if you don't acquire the skill, then it's going to be difficult. So make use of the available opportunity. Because 20 years back, 25 years back when the course started, we never had this many number of opportunities by way of workshops, seminars, webinars and all those things. Today you have everything. And in fact, when I was a student, even Google was not there. I mean, we never had even internet. So we belong to that age where, you know, we had to literally go to library to search for each and every piece of information. So now you people have everything at your disposal. So you have no excuse to say that, you know, I didn't have this, I didn't have that. So it's your duty to ensure that you equip yourself with knowledge and skill. And it's also your responsibility to teach your juniors. If you're in third year or fourth year, then probably you'll have to teach the first year students. If they are going in the wrong direction, it is your duty to counsel them. That's why I said the responsibility has increased. See, very soon, you know, you'll be getting a license to practice like any other healthcare profession. So please ensure that the code of conduct is being maintained. Professional ethics is very important. So all these things, you know, cannot be taught. All these things will have to come over a period of time. You mature and you get to know what is to be done and what is not to be done. So just have all these things in your mind and ensure that all of you attend conferences at least. See, we conduct annual conferences in different parts of the country. The whole idea is to ensure that the healthcare professionals as well as the bureaucrats and other people in that part of the country also is aware of the PA program. If you do everything in MMM, then I mean nobody outside MMM will know what is a PA program, right? So that is the whole idea of organizing conferences in Delhi, Calcutta, and Bombay and other places. So it's also your responsibility to attend conferences. And see, we do have a lot of workshops being conducted during conferences. Some of you would have participated in these conferences, at least fourth years, and second year students probably would have attended and taken part in some conference and workshops. So make use of those opportunities. Going forward, we'll be doing many more such workshops, and our focus right now is on research methodology. So many do not know what is research, how to do a research, how to do a meaningful research. So we will be focusing on research also. So we'll be conducting some workshops on research methodology So you guys should participate. And apart from our programs, we are also liaising with other professional organizations, requesting them to, give concession for our people. Like, right now, the Royal College of Surgeons conference is happening, and we got 70% discount for PAs. And today I got a call from a doctor requesting for a discount. So the situation has gone to that level where a cardiac surgeon is calling me for a discount. I said, it's not possible. I mean, the dates are all over, so it's not possible. So what I'm trying to tell you is, we are doing that much to, ensure that people participate in such conferences, gain knowledge. And the other thing is, you will be able to meet up with your, colleagues in other hospitals and people working in other cities also. So you get to know about what is happening in the other college. As if you're a student, then you'll know what is happening in the other college. If you are a staff, you'll know what your colleague is doing in his department in some other hospital. It's an opportunity to network with people, and later on, you want a job elsewhere, you can easily speak to your friend in that city and try to get a job. So it becomes all the more easy. So it's an opportunity for you to network with people, understand what is happening, good, bad, and ugly, whatever it is. So you can exchange views, and over a period of time, it will be easy for you to get jobs also. And if somebody is going abroad, you can definitely, reach out to him or her, find out what exactly he or she has done, and that is going to be useful for you people. So attend all conferences. Don't give any excuses for not attending a conference, especially second year, third years, and fourth years. We are not very keen in calling first year students because they would have just entered the PA school, and hardly 3-4 months into the system, they might not understand anything, and it will be a waste of time for them. So, but at least second years, third years, and fourth years should definitely attend all conferences. And once you are done with your clinical postings, once you are about to complete your course, the next important thing is that you should take IAPA membership. Everybody is quiet. Why should you take IAPA membership? I think fourth year students can answer. A lot of you are here, right? Kamali is here. The most vocal intern in the group, I think. Kamali, why should one take IAPA membership, Kamali? So that is one aspect of it. See, first and foremost thing is that, we all are professionals. If you are a professional, you need to be associated with a professional body. Just like how a doctor is associated with IMA, Indian Medical Association. Okay. Likewise, nurses have their own professional body. So IAPA is our professional body. So how will an organization grow? Do you think the organization will grow just because of one person, or just because of some, office building bricks or cement will, do the needful? No, it's the members who contribute, not the monetary contribution, the physical contribution of every member. See, when you go and approach a minister or any official for that matter, the first and foremost thing is, they will ask you how many members are there in your organization. See, if there are around 10,000 people who have passed out from various colleges in this country, and you have only 1,000 people in your association, that means you are only 10% of the total passed out people, right? And fortunately or unfortunately, this is the only professional body. So only this professional body can approach a regulatory authority. And if this regulatory authority has only 10% of the total strength, then do you think those people will respect you? That is the problem. That is the first and foremost reason why everybody should take membership. And once you take membership, tomorrow there's any problem, we will be able to collectively represent to the concerned body and take care of the grievances of the individual member also, if it is genuine. So that is the next reason why you should take membership. And other thing is that, we have our own internal expenses also. Where will we go for money, right? So the life membership contribution from the individual member actually helps us to do certain activities. Because without money, you can't do that. So that is another reason. The next thing is that, you want to go abroad, you want a good standing certificate. It is the association which gives you the certificate. So that is one more reason why you should take IAPA membership. So likewise, you have few more things also. I don't want to extend my talk on that. So as a professional, the golden rule is that, you should take membership of the professional body. And ideally at the time of internship, when you are done with your clinical work, when you are doing your internship, that is the time when you should actually go for the IAPA membership. Because post that, you will be going out of city, out of state or out of country also. So then it will be very difficult for you to reach out or even for us to track where you people are. And if you are a member, then your database is with us. So we can reach out to you anytime when we are conducting some conference or if something important is happening in the country, we can, reach out to you, inform you that, such a thing is happening. So for that purpose also, we need, membership of each and every one of you, because the database is very important. So that's it from my end. And thank you so much for patiently listening to me. I wish you all a happy Physician Assistant Week. Again, I would like to end by saying that knowledge and skill are inseparable. They are like, Siamese twins. And I wish each and every one of you gives utmost importance to acquiring knowledge, because this is the time when you can acquire knowledge and you don't have any other responsibility. See, once you graduate, you'll get married, you'll have to look out for so many things. So you may not have that much of time to go out and do certain things, but especially when you are in your college, second year, third year, and fourth year, you have no other business other than to acquire knowledge and skill. Wherever there's an opportunity, wherever there's a conference, wherever there's a workshop, wherever there's a seminar, go and attend. You will definitely gain something. Okay, thank you.
Thank you very much, sir. We ensure that every one of us enroll ourselves into the association and grow together and reach heights. Here we go with our final session by Dr. Anusha Rohit, HOD Microbiology, to give us a talk on goals of PA in infection control.
So good evening, everybody. Thank you first for the invitation. I know I'm the last talk and all of you want to go home, but I will continue with what the previous speaker was speaking about. Always something that I learned doing my MD was that every year I should present one paper at least. And this is what I promised myself. And to this day, it is now after my MD, I have finished my PhD also. And in the last 12 years, every year I have managed to present at least one paper in an international conference, because you have to plan for doing that, because work has to be planned. You have to have data which is authentic, and it teaches you a lot. So point number one by the previous speaker. And then connecting it to what my talk is today on setting up an effective infection control program. How many of you are students here? Can I have your hands up, please? Okay, nice. That's a sizable number. How many of you want to go into infectious diseases or infection control? Okay, one. Ovia alone. Okay, anyone else? No. Okay, fine. Let's see then if there is something that I can tell you on a prospect that you probably never explored. How many of you have thought of infection control as a profession at all? To be in charge in infection control? Nobody has even thought about it. No? Okay, so then let me see if I can help you out. The previous speaker also said golden words to you. That is, knowledge and skill is what you acquire. I'll add a third point to that. Common sense, which is so uncommon, right? We think we know everything. We are so smart. Yet you know that common sense is most uncommon and is not utilized. Infection control is nothing but common sense. It's not rocket science, but it is so uncommon that you will still stand out if you're able to do something basic in that. Okay, so going forward to that, you know who this is? Have you seen him before? Okay, to those of you who don't know, I'm going to go right in and tell you he's Ignace Semmelweis, the father of infection control. Okay, we always have fathers in everything, right? You all can, change that aspect. But you know why he became so famous in infection control? He did something very, very important. Okay. He was, in that time, there was no super specialization. You either were a surgeon or you were a physician. And he was a surgeon in Vienna, working in the maternity unit. Okay. And in Vienna that time, you're talking about the 1850s, 60s, that time, there was a big dichotomy in the people there. They were either very rich and they were able to afford to go to the hospitals, or they were poor and they had midwives coming to help them for delivery at home. Okay. Now, what he noticed was that the number of people who died of puerperal sepsis or sepsis after delivery was much higher in the hospital among the rich patients where the doctors were treating them versus those of the patients who had been treated by the midwives. And he found that very intriguing because the doctors are so much more skilled to handle so much more complications, like, for example, abruptio placenta, etc. But here, they were not able to do anything. The death rate was much higher. And then he realized that the doctors were overstressed. There were very few people who were trained to be doctors, right? So they were dealing with multiple patients and they were also going and doing autopsies, coming back and conducting deliveries, whereas the midwives would finish one delivery, wash up the patient, wash up the whole, baby, and then wash themselves up and then go to attend the next delivery because midwives were not that uncommon, right? And so he introduced a single measure called washing hands with chlorinated water. Okay. And with that one measure, he brought down the rate of death among patients to equal to that of the midwives. One single measure. But anybody who says the truth and keeps badgering you at it is bad. Today, somebody I took to the CEO and he was wearing a mask and they said, mask, I want to see your face. He said, ma'am, tittuvaanga. So he didn't want to remove the mask in front of me. Whereas I have moved away from the mask now since the CDC has, told us that it's okay to not be with a mask. Yeah, I've had COVID twice. So I thought, okay, fine, let me give it a break and take a break here. So coming back to this topic here, what we were talking about, patients were able to have better quality of care with just a single measure. Now, hand washing is such a simple thing, and he tried to force it on everybody. So he kept walking around looking at everybody, whether they were washing hands. Ultimately, he was put into a mental asylum and he died in a mental asylum. Today, we call him the father of modern infection control, but the man was really tortured in the last few years of his life because all he asked to do was wash hands. Okay, so don't put me in a mental asylum. I'm not going to get you there. But nonetheless, let's look at the history of infection control. It's a recent concept, as recent as the life of a physician associate so far. So in the 1950s, modern hospitals had this first program in England called to reduce incidence of hospital-acquired infections. It used to be then called nosocomial infections. And then in 1968, the first document came up from the CDC called Infection Control in the Hospitals. Following that, the JCI, that is the Joint Commission for Hospital Accreditation, they said that there has to be organized infection control facilities. And then there was a growth spurt in the 1970s as Staphylococcus infection spread, right? MRSA Methicillin was introduced in 1960, and 1960 itself, the first case of methicillin-resistant Staph aureus was reported. Okay, so it was just so immediate. So by the 1970s, infection control got a little better. 1970s also in the US, 10% of the hospitals had an infection control program going on. By 76, that went on to close to 50%. And then they formed the Association of Practitioners, which had an organized branch called Hospital Infection Branch. Okay. Now in 1985, and the reason I'm telling you all of this is because you would think that, you know, physician associates are, you know, a young field for that matter. And I'm trying to give you a parallel field right now, which has grown along the same lines as your field. So how far have you been able to come, and how you can actually integrate yourself into these fields is why I'm actually putting you here. So they have said that by just forming an infection control policy and having a program in a hospital, you can reduce hospital-acquired infections by 1/3. Okay, you still cannot eliminate them. Trust me, you cannot eliminate bugs. They've been on this earth for many, many years longer than all our programs. So millions of years longer, they know better how to survive, right? So they found that one infection control professional is required for every 250 beds, and an effective infection control physician is required. And the rates of reporting, when you give it back as a feedback to the surgeon, you would know whether you have to change your technique, whether you have to do something that may be different. All of these are very, very important. So you need a hospital-wide surveillance system. And essentially, what are the challenges that we have? Now, as you know, there is when there is insurance, when you have infection, you will, if you, especially in the West, you will not get reimbursed if it is a hospital-acquired infection. So who pays that? The hospital pays that. And when hospital, it costs money, essentially it's translated onto your appraisals and all of that. Here, it is yet not become that stringent, but otherwise it's very, very important. Increasing emerging infections are there. For example, now we just finished almost at the fag end of the COVID-19 pandemic. The H1N1 is raging on right now. Ebola came in Gambia, right? Last week, there were cases that were reported. So there's emerging infections everywhere. Monkeypox was spoken about recently. And Nipah virus came in Kerala before some time. And you're all healthcare workers. If you don't know what is emerging and how to take care of yourself to avoid those infections, how are you going to be able to work in a healthcare environment? Next is drug-resistant organisms. When we were initially studying, we were thinking ampicillin, amoxicillin, drugs of choice, right? Now, when you go meropenem, piptazo, colistin, phosphomycin, ceftazidime, avibactam, tigecycline, antibiotics that we had not heard of are coming into play because organisms are getting more and more resistant. Increasing drug costs. For example, one dose of meropenem, as you all know, is equivalent to 2,500 rupees, and you have a patient on a TID dose with a normal renal function, for example. So that is almost 10,000 rupees a day for only the antibiotic of the patient, right? So that is very important. And then you have nursing shortages, healthcare, legislation because of healthcare associated infections, and multiple benchmark systems, and the use of single-use devices. So most of our cardiac facilities reuse devices because of the cost, especially in a country like India. So first is, can you reuse or not? Second, if you can reuse, how do you sterilize? Do you sterilize or do you disinfect? Okay, what do you mean? What's the difference? Disinfection means you only remove the pathogenic organisms, whereas sterilization means you remove all the organisms, right? Even doctors don't know these differences, trust me. And you need to understand these basics to understand whether you will suggest sterilization or you will suggest disinfection, whether it is compatible, the chemical that you're using, say, to sterilize, or if you're using, say, autoclave, is it heat labile or is it heat stable? Or when you're using plasma or ETO, for example, we did a study when the COVID-19 outbreak was there, when the masks were difficult to get, on using plasma. We did 6 methods we tested for your N95 masks. That is, we did an ethylene, isopropyl alcohol dip. We did a hot air oven. We did ETO. We did plasma. We did autoclave. And then we also did a proper steam sterilization and said whether these are okay. Now, what we found was that ETO and plasma were both allowing the N95 mask to retain its capacity to filter 99% of the air that is coming through, the particles that are coming through. But ETO is more harmful because it's carcinogenic. So when a patient or staff or healthcare worker is wearing an N95 mask, after it is being ETO'd, are they going to breathe in any chemicals that are harmful to them? So these kind of risk benefits are also something that you as healthcare professionals, as infection control professionals will have to think of. So it's no longer looking at one patient. It is looking at the entire scenario. Now, in the last 2 years, so many situations where I have faced, where I've been told, ma'am, we'll take care of this patient. We can take this patient for cath lab, right? COVID-19 patient. Now, when the decision is to be made by me, I have to keep so many more things in perspective, not just whether this patient can be taken to the cath lab or not. What I need to see is, okay, after the cath lab, who is going to take care of the patient? Am I going to isolate that patient, or is that patient going to be in general ward? If the patient is going to be in isolation, is there going to be a 1:1 nursing where I have one person taking care of this patient, and it has to be round the clock in shifts? And if that patient, if that healthcare worker is going to stay in the dormitory, if that person gets infected, am I responsible for everyone there? So the repercussions of what you think are at a broader sense in infection control than in a single patient whom you're taking care of as a PA. When you're taking care of a single patient is very different than when you're taking care of the hospital patients. So you're thinking of patients, you're thinking of healthcare workers, you're thinking of your colleagues, you're thinking of so many other aspects that need to be considered. Engineering control. So this is the key. Teamwork. And if we work like this, we're not going to get a solution at all. We need to be working as a team. So who makes up your team? You usually have an infection control chair, and then you have a microbiologist or an ID physician, and then you have infection control nurses, and then the whole team that is made up by link nurses, pharmacy, drugs, purchase, engineering, etc. And what should be your goals? Primarily to identify and reduce risk of infection in the patients and healthcare workers. You have to coordinate all activities from surveillance. Okay, so that once the patient goes back also, are you sure that the patient has not had an infection because of you? Prevention, control, and ultimately improving clinical outcomes. And secondary goal, of course, is to reduce the cost, which will eventually come if you put the primary goals in place. Okay, so the goal is to balance the cost with the quality of work that you're giving. So what is your role that you can possibly do? Supposing you're going to a hospital that is already having an infection control program, you will just join the team. But if you are going to a hospital where you want to create an infection control program, right, you can offer to do that by one. You have to have, you can either create an efficient program, or you have to assess the quality of the present program. And ultimately, you have to increase the quality of care that is given and the outcomes. But you can also be involved in teaching, in academics, in research, in innovation, and you can be at the forefront of a multidisciplinary round that needs to be taken for patients. No longer is it that, okay, my GP said it, so this is what works. Nobody can know every field right now. Okay, I finished my MBBS, I finished my MD, I finished my PhD, but can I say I know everything? I have no clue about, say, cardiac surgery, for instance, or I have no clue about, say, nephrology, for instance. Okay, now the clue all over the world, okay, and keep this as a point even when you go abroad, is to know how to work in a multidisciplinary team. Okay, it's called an MDT. And when you go, especially to the West, your ability to be a team player is more important than your ability to lead, because you should know, because as you know, 5 fingers in the hand are not the same length, are not the same breadth. Similarly, 5 people in a team are different. Why 5 people in a team? Even in your own house, your own sibling and you are miles apart. aren't you, in so many things? You may have similar likes and dislikes, but you're miles apart. So when you're working for a common thing and when you have passion towards what you're working with, especially in the team, you will be doing a lot of coordinating discussions, communications, implementation of the care plans with various consulting physician services, nursing, respiratory therapy, pharmacy, nutritional support, and other coordinating teams, which you are already doing right here now, right? But by creating a multidisciplinary team, see, now your activity is not really recognized because you're doing it on a 1:1 basis. You're picking up the call and saying, ma'am, what do I do? Should I isolate this patient or not? So infection control, you've spoken to me. Then you pick up the call and you call Dr. Supraja and say, ma'am, pulmonology wise, what other investigations do you want me to do? Then you pick up the call and you talk to, say, the gastroenterologist. So you individually, you are doing it. Whereas if we all work as a team, right? Your role actually is to bind the team together, and you probably play a bigger role than any individual one taking care of the patient. So the role of a physician assistant, because it was an older article, 2019 article, but this article is talking about multidisciplinary care team that slowly evolves over time, allowing improved efficiency and delivery of critical care, but essentially any care to the patient gets enhanced when you are doing it that way. And the projection is to see the introduction and assimilation of PAs into the world of telemedicine, mirroring the augmentation of care delivery, much like is seen in a brick and mortar model of the ICU. Okay, so you are going to be critical parts if you are able to associate yourself into a multidisciplinary team when you're caring for a patient. When you have an existing program, how do you make an assessment of it? Include any new customers into your service. You have to assess for compliance to written standards and review the standards because standards change. As you know, this is the 5th edition of the NABH that is going on. So at least with respect to your department. So how many of you are working in the OTs here? Put your hands up. Okay. Can you tell me what is the differential pressure that has to be between the OT corridor and the OT inside in terms of the pressure difference, pressure gradient between the two areas? Any of you? 2.5 pascals. Okay, now this is not something that is directly related to your work, but having that information is greatly beneficial for you, because if you see that in your surgeon's control panel, if you see this is not being followed, you can be the person to alert this. It is important to learn beyond your sphere of action. In fact, I would all recommend you to hear one of my favorite conversations online. If you go to YouTube and look at the founder person of Apple, and if you see his Stanford address that he's talking about, he will tell you how he dropped out of college, okay, and just to pass time he went to his friends rooms to sit and learn calligraphy. Now calligraphy had no bearing at all on his passion to work with electronics and electronic communications. But eventually what happened is, when he was sitting in his garage to develop the Mac systems, what he could do is what he learned of the calligraphy script, he put into the different fonts of computers today. And today, if we have so many fonts of computer language, it is because he went for that calligraphy class then. So sometimes you don't know why you're learning something, okay, but eventually the knowledge that you gain is how you apply it in various other fields that you may be actually figuring out with. Next is to list any practices that are not against the policy. So if you know the policy, only you know what is not against the policy. So it's important that you read the policy, right? Use current guidelines wherever available, and assessment should be made internally and externally for resources for areas of development. So have a proper plan checklist. So you can have an authority statement, a vision, mission. So this is how you create your program. You have goals, primary goals, and then secondary goals, objectives. How will you reach them? What is your game plan? Okay. And then how will you assess whether these, it's just not important to put something in place and go. As you go, you have to keep monitoring whether this is actually being followed or not. And then what are the job descriptions of the personnel who are working with you? What areas will they look at? And then what is your surveillance strategy? How will you look at the environment? Now, for example, we had recently an outbreak of ralstonia in our hospital. 17 patients, okay, in a span of 3 months. And the first time, in fact, when this organism came, I had a big argument with CEO because he said, Anusha, it's a hospital-acquired infection. And I said, sir, to call it a hospital-acquired infection, you have to have 2 patients. He said, no, but I want you to look at it in great detail. I said, okay. And lo and behold, next day I had the second patient. Okay. Now we knew that we were in trouble. We had to start looking. And we started digging, and suddenly we are noticing 2 surgeons who are involved with it. Now we're checking all their techniques. Everything is in perfect order. We're going on digging, what could be, and I couldn't do it without my team's help. So when I'm saying we are digging, it is my whole infection control team with my nurses and Angel and all of them. So all of you contribute towards me, okay, towards me working. Now then we go on digging, and we are seeing all of it are in post-cardiac surgery cases. So this, if there is a patient who is non-cardiac and is having a surgery in the same OT, is not getting the infection, okay, because that time the OTs were all running on the 8th floor. So if it is say a reproductive medicine case or a transplant case also, that infection is not there. Only in cardiac surgery patients. Now again, we're digging what is commonly used, what, then we said, okay, we are putting the neckline of the patient in the induction room, that there is a sink close to that. Now, though the levels in the water of this organism is less than the acceptable levels, so 50 CFU per ml is acceptable for this organism in water. Okay. We are having 2 or 3 organisms. So it's not even enough for me to start digging into it, but there is a source of an infection. Now we are sitting and thinking, what could be the possible cause in only post-cardiac patients? And trust me, we looked at the perfusion. We took multiple cultures from the OTs, and we really struggled to figure it out. Finally, lo and behold, one of my infection control nurses said, ma'am, all the cardiac surgery patients are coming to the adult ICU. Why can't adult ICU be the cause? And we said, yeah, that makes sense. Okay, let's chart out. Let's make a picture of how the adult ICU beds are placed and where are these patients? Where were they when we identified the problem? And you know what we found? So interesting. It's almost like, a mystery novel, because and it's a real-time mystery novel, because your heart is in your mouth, because you have patients struggling there. You have answers to give to so many people, and you want to desperately find the cause of this infection so that you can put it to rest. It is not that the patient is getting, an adverse outcome because of that, but the length of stay is increasing. Okay, patient may not die because of the infection, but an increased length of stay is increased cost to the patient. So you are still responsible for that. So we digging. And then when we charted out, we found that all the beds were next to the sinks in the adult ICU. In our adult ICU, we have 3 rows of patients. 1 row is near the corner where the sinks are there, and the 2nd and 3rd row. None of the patients were on row 2 and row 3. Everyone was near the sink. Next day, we broke down all the sinks and said goodbye to ralstonia. Touch wood, so far we haven't had another case of ralstonia. So let's hope we've addressed the issue. But it's a lot of investigative medicine that you're doing there. And to be doing that, you have to keep your eyes, ears, nose, everything open, because you have to really think what could be the possible cause. Okay. So I've told you about this. I'm going to jump all of these things. Surveillance, I told you how to start doing that. I gave you an example. Environmental monitoring, also I told you a story, so you don't need to know anymore. Now, there are some obsolete procedures that you have to know about. Like, for example, everybody thinks if you fog the environment is clean. Not at all. The fog goes into the environment and then settles on surface, and that's the end of it. Okay, now, if you've been in your house, you've kept water in a mug for a long time, you've seen a slimy layer that comes on that. All of you know that's a biofilm, right? That's a biofilm. So it's got multiple organisms, rows and rows of organisms there. Now, if you just empty the water, will that slimy layer go? No, you need to physically scrub it. And that's precisely why fogging is no longer an accepted technique, because just puffing chemicals into the air is not going to give you a solution. What you need is surface scrubbing. And that is the key. So even if you don't fog, your air handling units will be able to circulate the air. But if you fog and then don't scrub, you've lost the plot already. So you have healthcare associated infections with active surveillance in all these areas. So when you develop an infection control program, these are the areas you need to look at, from dialysis units to burns units to transfusion units to food handlers, because they can be potential sources of infection, drinking water and the CSST. All of these come under the HIC policy. Operation theaters and ICUs, where you have various quality indicators to see if your program is running well or not. All of this is also important. And next comes the really important role of a physician assistant or a physician associate, that is in antimicrobial stewardship. Okay. So core members, components of a stewardship program is, of course, leadership, commitment, accountability, drug expertise, action, tracking, reporting, and education. But the physician and the pharmacist play a key role in avoiding unnecessary use of antibiotics. And if you look at this, the key physician pharmacist role is to provide inputs during and developing the policy. So you are the end user. So now if I tell you, use this antibiotic, it would be better than you, that would not be as good as, rather, I'll rephrase that. That would not be as good as you telling me, ma'am, if we use this antibiotic in this cohort of patients, we are not seeing that good outcomes. Whereas if we are using this antibiotic Y, we are seeing better outcomes. So you describe and help us develop the antibiotic policy and provide support for the daily tasks. So if we call you up, for example, there was a patient even today on an extended infusion of clindamycin. Now, why do you use extended infusions? You use extended infusions on time-dependent antibiotics so that the concentration of the drug remains high for a long period of time, because you have extended the infusion of the antibiotic in the patient. Now, you cannot do that for concentration-dependent antibiotics. So where to use which strategy is also important, which is why we were able to talk to the clinician and change that program for that patient, because it did not seem to improve the outcome. And then, like I told you, unless you measure, you don't know. Okay, so it's important. So where are the? So take a few minutes to consider the way the antibiotics are used in your clinical area. So you don't need to be an infection preventionist. Even if you're working in a clinical area, tell me if you can do this. Take a few minutes to consider the way the antibiotics are used in your clinical area, and do they work or not? Do you know how they work? Okay. Is the antibiotic use increasing or decreasing? Okay. Have you noticed a shift? Like earlier we were using piptazole, now we are using Magnex. We're seeing better outcomes with Magnex versus piptazole, right? It happens. Observership is very, very important. Are the antibiotic prescribing policies in place? And trust me, even Alexander Fleming, had he thrown away the plate that grew the penicillium that was killing the Staph aureus and not observed that killing of the Staph aureus, we wouldn't have had the first antibiotic that actually came about, right? So it's very important that you notice what is happening around you. If so, how will you follow the policy, and how will you allow or encourage other prescribers to do it? Many a times you are called as the via media or a referral for a patient, right? You're called to give a referral, and your doctor has said, go see that patient, give me all the details. Now, you may see that patient having 2 antibiotics of the same class. For example, you have the patient having, say, cephrazone sulbactam, and the same patient also on piperacillin tazobactam. Now, you know the mode of action is literally the same, except for enterococcus, where piperacillin tazobactam will work better than cephrazone sulbactam, because all enterococci are intrinsically resistant to cephalosporins. Now, if you have not looked at the old prescription, you may miss that point completely, and you may add another antibiotic of the same choice. Now, this has happened multiple times here in the past, where we've had patient is on oral clindamycin and they have added a IV clindamycin along with that. It is important that you go through the notes of the patient from the previous referrals as well to help you do that. Next is, you are asked to send a particular test, and as far as the labs are concerned, it's garbage in, garbage out. Okay, so if you send good quality specimens, you're going to get good quality results. If you're sending bad quality specimens, trust me, you'll get bad results. Okay, so the right test and the right choice is very, very important for you to have, where you can use rapid diagnostics, you can use point of care diagnostics, but you have to know where to use them, simply not in every place because they may not make sense. So order the right test. Talk to your microbiology department if you're not sure about what you're saying. Transport it appropriately to the lab within the right span. Like many a times we get lymph nodes from the OTs in formalin. Microbiology cannot process a specimen in formalin because the organisms are killed, and we grow organisms, right? If you killed it before it's even reached the lab, what is the point of even sending the sample? Then the biggest point, when you take samples of high volume, like an ascitic fluid, don't send a parsley 2 ml to the lab. Please be generous. You can send us the whole bottle. We'll discard the rest, but please send adequate quantity of sample to the lab. Differentiate between pathogens and commensals. Everything that grows does not need to be treated. Very important to remember that. And pus cells and urine routine are very different from having culture. Why I am repeating this is because many a times we have urine cultures that have no growth. 0 to 1 pus cells. Remember, urine routine, which is done in biochemistry department or clinical pathology department, is centrifuged. And what happens when you centrifuge anything? All the high volume cells, etc., will concentrate in the bottom. So they will look like there are many pus cells. But in microbiology, we do not centrifuge urine. We directly look for urine per ml of specimen, right? We will tell you how many CFU per ml. So important to understand that pus cells and urine routine is not equivalent to a urinary tract infection. Sample collection needs to be meticulously looked into, and do not treat asymptomatic bacteriuria because there is growth. We in the lab have not seen your patient. You know your patient better. Don't treat the report, treat the patient, right? Don't treat the report from the lab, treat the patient only based on symptoms. Next is the empirical prescribing, for which you need to have a very clear idea of what are the organisms or bugs working in your hospital, what are the antibiotics that are good for those bugs, and how do you get better at them. For example, you have a gram-negative organism growing in culture, but you want to continue teicoplanin, which has no action on gram-negatives, only on gram-positives. Right? So then there's absolutely no use of that antibiotic. And it is not only is it one other antibiotic that's costing the patient 2,000 rupees per day. In addition, it is also hitting the kidney of the patient and the liver of the patient. Right? So there is repercussions to everything that you're doing. So you cannot be just doing that. So guidance is important. Use the appropriate choice of antibiotic. We're not telling you not to use antibiotic. Trust me, ID, infectious diseases and infection control, does not tell you don't use the antibiotic, right antibiotic. We're telling you use the right antibiotic in adequate doses, the right doses. And then you can have something called as antibiotic timeout, that is at 48 hours review based on the results. Don't just send a sample to the lab, start an antibiotic and forget about it. At 48 hours, when you get your report, please review that report. That may give you vital information, whether you need to continue this antibiotic, change the antibiotic, escalate it, de-escalate it, any of this can work. And to also decide end of treatment when it's required. For example, here, antibiotic usage. Now look at this. This is just an idea. So look at here, 120 vials of vancomycin in a hospital where the majority of infections are gram-negative. Now I've blinded the year, date, all of this. This is just a random set of data, but this is general. This is from my hospital. So that is how you figure it out. So basically, for hospital-acquired infections, you have to have surveillance of resistance and the consumption of data, consumption data. You have to look at it with the hospital antibiogram, whether it is fitting with the policy of the hospital. What are the standard treatment guidelines for these organisms? And that is nothing but stewardship. I told you already about outbreak management. Let me give you another example of how we did. We had a serratia outbreak in the adult ICU and CCU. Okay, in our hospital. Again, this was over a 6-month period. You can see 2014 to 2015, and this is published data, so I'm able to show it to you as is. So we had one case in November, two cases in November, 4 cases in December, And then January, we had one case in the adult ICU, two cases in the CCU. And then we had a small time gap. February, March, we had one case here and there. And then we had in April, again, a spurt of cases. And all these months, we were continuously doing cultures from the environment to figure out what is the course. When we did a genetic analysis of the isolates, we found that there were two clusters. One cluster was that in the adult ICU, which also was in the preloaded heparin injections that were there because they were used across multiple patients, right? So that was the source of the infection. So immediately we changed to single-use pre-filled syringes. They're expensive, but they avoid these kind of outbreaks, right? So that's important. And we found the second cluster in the CCU that had no respect to the environment. So we knew that it was simultaneously, it was second. Then as an infection control person, you have to inform the government when there are communicable diseases. You are part of education as a physician associate. So as you can see, we've done various educational programs in the past. Tomorrow, we also have our Rangoli competition. But this week, for all our staff here, we have a flu vaccine camp going on. And this time, the hospital has subsidized the cost to 100 rupees. I really encourage all of you to please go and get your flu vaccine done. You don't need to be in a vulnerable age group to get the vaccine. Adult vaccination is important, and that I think COVID proved that. We have innovative methods to look at that. And then look at your policies and procedures, see if you need to have any volunteers to review it, and look at a committee or consultant involvement. You could be part of consultations as an outside consultant for other hospitals as well. You could be part of budget preparation because you need to know how to have every cost considered. So as part of infection control, you can be part of budgeting. Occupational health is very important. Sharp injuries. Now, many of you can be liable to sharp injuries. So please see that your hepatitis titers are adequately high. Avoid recapping, avoid wrong practices that you've used in the past because your health is more important than anything else. So please see that you're fine and how to deal with MDR organisms. The other responsibilities are just to complete it that you can do is CSST practices. What are the kind of disinfectants you use in the hospital? SUDs or single-use devices like I told you. Biomedical waste in the hospital. How do you reduce key performance indicators like surgical site infections, catheter-associated UTIs, central line-associated bloodstream infections, and ventilator-associated pneumonia. So you can develop bundles that are, for your hospital, spill management and legal requirements, MDRO tracking, isolation, when to ask for contact isolation, when to ask for respiratory isolation, when to ask for airborne isolation. Very important that you have all of that in place. Sorry. Hand hygiene compliance. I started off with Semmelweis story, and I need you to understand that it is still relevant today, that hand hygiene is very poor in most areas. You can see here, it goes down to 60% even when we are watching. So you can imagine when we are not watching how low it can go to. Okay, and then knowing which of them to use where. So my 10 best strategies to you are hand hygiene, environmental hygiene, screening and cohorting patients, vaccinations, surveillance, stewardship, care coordination, following evidence, appreciating all departments that support infection control, and comprehensive unit-based safety programs. So with that, thank you so much for your kind attention. I would still urge you to wash hands and take care. Thank you very much. Do we have questions or? Do you have questions or can we go to the cake cutting? I think that's more interesting. Okay, I'll ask you one question. I started off with asking you, how many of you would like to go into infection control? Anyone who's interested now to think that you can use quality or infection control as something that is a goal that you can achieve? No, one more. Okay, thank you. Two more. I have a couple more who are interested, please. Okay, forget all of that. The second important thing that I told you, common sense is so uncommon, right? So can you all use the common sense of infection control in each of your areas that you're practicing in? That itself is equivalent to doing good infection control. Okay, thank you so much.
Thank you. Thank you, ma'am. To celebrate the 30 years journey of Physician Associate, let's cut the cake to make this moment more memorable. I request our CEO, Dr. Roger George, to join the celebration. I also request Dr. Anusha Rohit ma'am, Dr. Dinesh sir to join the celebration.
I request the organizing committee to join the celebration and make this event even more gracious.
Today, we achieved an important milestone. Today, we are no longer alone. I'd like to thank all the audience on